The Committee on Health, Hospitals, and Human Services is called to order. Pleasant good morning and greetings to the general public. I want to give a special welcome to our testifiers. Also want to say a special shout out to my son Mario. How you doing, Mario? I want to express condolences to the family of Mr. Kenrick Thomas, a well-known contractor in the community. He recently passed away. Condolences to his daughter, Sandra, and the son, Cecil, and also the mom and the whole family and all the friends. I want to say special good morning to the testifiers. We're extremely grateful that you are here today to be able to present testimony regarding the areas that you are in charge of. And we're looking forward to a fruitful hearing. This Committee on Health, Hospitals, and Human Services is a super committee in that there are actually 9 members. So we're going to, try to speed through everything rapidly, and we're going to try to be on time today. Madam Clerk, do we have any correspondences that need to be read into the record?
Yes, Mr. Chairman.
Please proceed.
May 3rd, 2023, the Honorable Ray Fonseca, Chairman, Committee on Health, Hospitals, and Human Services, 35th Legislature of the Virgin Islands. Dear Senator Fonseca, I will be tardy to today's scheduled Committee on Health, Hospitals, and Human Services hearing beginning at 10 a.m. in the Earl B. Athley Legislative Hall on St. Thomas. I thank you in advance for your understanding in this matter and sincerely apologize for any inconvenience my tardiness may cause. Sincerely, Novell E. Francis Jr., Senate President, 35th Legislature of the Virgin Islands. This concludes the reading of correspondence, Mr. Chair.
Thank you, Madam Clerk. Madam Clerk, can we have a roll call?
Senator Marvin A. Blyden.
Present.
Senator Blyden, present. Senator Diane T. Capehart. Present. Senator Capehart, present. Senator Samuel Carrion.
Present.
Senator Carrion, present. Senator Ray Fonseca.
Present.
Senator Fonseca, present. Senator Novell E. Francis Jr. Senator Francis Jr., absent. Senator Donna A. Fred Gregory. Senator Fred Gregory, absent. Senator Kenneth L. Gittins. Senator Gittins, absent. Senator Maurice C. James.
Here.
Senator James, present. Senator Milton Potter. Here. Senator Potter, present. Mr. Chair, we have 6 present, 3 absent.
Thank you, Madam Clerk. Okay, yes. Can you go ahead, Madam Clerk, please?
May 3rd, 2023, Honorable Ray Fonseca, Chairperson, Committee on Health, Hospitals, and Human Services. Dear Chairperson Fonseca, please accept this letter as a formal notice of my late arrival to today's Committee on Health, Hospitals, and Human Services meeting, which is scheduled to begin at 10 a.m. in the Earl B. Athley Legislative Hall in St. Thomas. Please have all circulated documents placed on my desk for immediate review upon my arrival. Thank you for your consideration on this matter. Kindest regards, Donna Fred Gregory, Chair, Committee on Budget, Appropriations, and Finance, 35th Legislature. This concludes the reading, Mr. Chair.
Thank you, Madam Clerk. We have a quorum. Please mark Senate President Francis as excused and Senator Donna Fred Gregory as excused. You know, May is National Mental Health Awareness Month. And this year's theme is Look Around, Look Within, challenges us to take a second look at factors that may be affecting our mental health in our immediate living situation or genetics. During National Mental Health Awareness Month, we honor the absolute courage of the tens of millions of Americans living with mental health conditions and we celebrate the loved ones of the mental health professionals who are there for them every day. Treatment works, and there is no shame in seeking treatment. Together, we will keep fighting to get everyone access to the care they need to live full and happy lives. Many factors come into play when it comes to mental health. Take some time to look around and make note of your surroundings and look within to see how they may be affecting you. Increasing awareness and understanding of mental health, the steps our citizens can take to protect their mental health, and the need for appropriate and accessible services for all people with mental health conditions. If you or someone you know is struggling or in a crisis, help is available. Just call or text 988. Look within and check on your mental health. Okay, at this time, I will like to give special recognitions to two distinguished Virgin Islanders. Media, you ready? We want to celebrate the contributions of Dr. Marilyn J. Nutter. She recently departed this life in March 11th of 2023 at her residence in St. Thomas. Marilyn came to St. Thomas in 2003 and worked at East End Medical Center. She subsequently worked at the Department of Health from 2006 to 2023. She attended to many patients in the clinic at the Snyder Regional Medical Center. She also worked in private practice as well as did medical consulting. Dr. Nutter adopted the Virgin Islands as her new home. She was a healthcare provider at the University of the Virgin Islands, and she also assisted at the Division of Mental Health, Alcoholism, and Substance Abuse, which is now called Behavioral Health. In addition to her parents, she is survived by her only daughter, Alexia Commission. Dr. Marilyn Nutter was a physician with a big heart, with passion for her patients, co-workers. She will be greatly missed. Rest in peace. Additionally, we wanted to celebrate a Virgin Islands legend and international humanitarian, Dr. Alfred O. Heath, MD, FACS, FICA. Dr. Heath, having been born on St. Thomas in December 4, 1929, he is a retired surgeon, educator, pilot, and community leader. He is a nationally recognized general thoracic surgeon and vascular heart surgeon. He served the Virgin Islands as Commissioner of Health, the Chief Executive Officer, the Chief of Surgery, and Medical Director. He is also a recipient of the Virgin Islands Medal of Honor. Dr. Heath was recognized by the U.S. Department of the Army for his meritorious work in Hindenburg, Germany. He also served as the USVI Assistant Adjutant General. One would think that at his young age of 93, he would be permanently retired, but instead we are continually blessed to have his experience, wisdoms, and instructions. Blessings, Dr. Heath, my dear friend. You can play the video, media. This is Dr. Heath being honored by the Veterans Affairs Director. He's getting several pins. He's received a lot of awards in the community. He's a very, very dear local humanitarian. Thank you very much, Dr. Alfred Heat. Okay, so welcome once again to the testifiers. We'd like to ask with the testifiers to introduce yourself and put your name on the record. And then we will begin with the testimony with Mr. Finch on my left. Then we'll go to Mr. Smalls, and then, oh yeah, that's right. Oh. Madam Clerk, can you please read the agenda block 1?
The committee will receive testimony on the operational and implementation status of the Governor Wong F. Louis Hospital and Medical Center. Invited testifier, Mr. Doug Koch, Chief Executive Officer, Governor Wong F. Louis Hospital and Medical Center. Mr. Christopher E. Finch, Chairman, Virgin Islands Government Health and Hospital Corporation. Mr. Darrell A. Smalls, Executive Director of Facilities and Corporate Development, Territorial Hospital Redevelopment Team. This concludes the reading of Block 1, Mr. Chair.
Thank you, Madam Clerk. Okay, testifiers, welcome once again, and if you can please introduce yourself, put your name on the record, and then we'll begin with Mr. Finch on my left, and then we'll proceed to the right. So please begin.
Christopher Finch, Board Chairman, Virgin Islands Government Hospital and Health Facilities Corporation. Good morning.
Good morning, Senator. Darrell A. Smalls, Executive Director of the Territorial Hospital Redevelopment Team.
Good morning, Senator. Doug Cook, Chief Executive Officer of JFL.
Good morning, Senator. I'm Hazel Filbert, Chief Operating Officer of JFL.
Good morning, Doris Plaskett, Chief Nursing Officer, Governor Wong F. Louis Hospital.
Thank you, thank you, thank you, and a special welcome. You know, we're so excited to hear, you know, what you guys are going to present to us today, because, you know, during the campaign, there are two things that everyone has as their priority. It's health and education. Some folks have the economy, but health and education is always on everyone's top priority. And if you look at our budget, when you add up the amount of funding that goes to the Wong Louis, to the Snyder Regional Medical Center, and to the Department of Health, the Virgin Islands government has a major commitment. So thank you very much. Mr. Finch will receive your testimony at this time.
Thank you. Good morning, Honorable Chairman Ray Fonseca, other members of the Committee on Health, Hospitals, and Human Services, other senators attending, Senate staff, hospital leadership testifiers, and the listening and viewing public. I am Christopher Finch. I am the chairman of the Virgin Islands Government Hospitals and Health Facilities Corporation, commonly known as the Territorial Hospital Board. Thank you for this opportunity to testify on the operational, implementational, and redevelopment status of the Governor Wong F. Louis Hospital and Medical Center, the Schneider Regional Medical Center, the Charlotte Kimmelman Cancer Institute, and the Myra Keating Smith Community Health Center. I'm joined today by the top hospital leadership team of the Wong F. Louis CEO, Mr. Douglas Cook, the Schneider Regional Medical Center, Ms. Tina Commission, Esquire, and the Hospital Redevelopment Team, Executive Director, Mr. Darrell A. Smalls. These testifiers will provide much of the detailed hospital testimony. My testimony will be focused on the larger overview impacting all facilities, especially from the Board of Directors' perspective. I will begin with recent successes. The Wong F. Louis Hospital successfully moved to the interim JFL North Hospital on April 22nd. Tremendous credit goes to the Wong F. Louis and the Hospital Redevelopment Team staff for a successful move and for all the work that has gone into creating JFL North from its inception. I especially want to thank CEO Doug Cook and Executive Director Darrell Smalls for their leadership during the last several months, identifying and addressing safety concerns. As this body is aware, those concerns included delaying the opening for an additional month after the ribbon cutting to correct deficiencies uncovered during final inspections. A hospital never stops work and must remain in full operation even while moving. Early in the morning on moving day, the new emergency room had patients waiting to be seen, even while the transition of hospitalized patients was ongoing. Before 24 hours passed on moving day, 1F Louis received 2 gunshot victims and 2 car crash victims. Within a few days, surgical operations were conducted, and the first baby has already been born in JFL North. The demolition work on the Charlotte Kimmelman Cancer Institute is nearly complete. A request for proposals, an RFP, for renovation of the Charlotte Kimmelman Cancer Institute has been published, with bids due on June 14th. Last September, the Schneider Regional Medical Center successfully completed the accreditation survey by the Joint Commission on the Accreditation of Hospitals. I want to thank CEO Tina Commissione and her team on that accomplishment. Both hospitals have begun implementing Meditech Expanse. This is the electronic health record system that makes patient information available instantly and securely to authorized users. It enables better communication and coordination of care, assists with diagnoses, reduces medical errors, improves documentation and efficiency, and streamlines coding and billing. Union contract negotiations have been completed and fully signed with the licensed practical nurses, the LPNs, the registered nurses, the RNs, the advanced practice nurses, the APNs, the nurse midwives, and the certified registered nurse anesthetists, the CRNAs. Negotiations are ongoing for the nurse supervisor's contract, which is the final remaining nurse union contract. Our plan is to follow the execution of all nursing contracts with negotiations for the Association of Hospital Employee Physicians, our AHEP contract. We have additional expired union contracts to follow thereafter. Our goal is to have all union contracts current as expeditiously as possible. From a board work perspective, we continue to meet regularly as a body and in committees. We continue our focus on standardizing policies for both hospitals. We're very pleased with the communication and cooperation that occurs between the hospitals. Last November, we held a 2-day board training retreat. The board is implementing proposals that came out of that retreat and is planning follow-up fiscal training for this summer. I will now briefly discuss construction projects. Mr. Darrell Smalls will be providing more detailed information in his testimony. Along with the transition into JFL North and the construction soon to begin on the Charlotte Kimmelman Cancer Center, there are additional projects in various stages. For St. Croix, work continues on the CMU project, which includes much of the critical environmental support for JFL North, including water storage, fire suppression pumps, hot water electrical service, backup generators, and medical gases. This work is substantially complete. However, the Territorial Board recently approved the supplemental contract to allow for the rerouting of water lines for greater efficiency. A contract has been awarded to construct the critical administration building, which will be the official entrance of JFL North. The hospital redevelopment team expects to issue the notice to proceed for that project this month. Future work on the campus includes the construction of parking behind JFL North. The leased land, which will hold the parking and additional support buildings, is undergoing a required environmental assessment. External work and interior preparation work has begun on the Cassava Gardens building, which will house many of the JFL non-patient-facing staff and provide warehouse space. Leasing space for this support staff and material storage is necessary to completely vacate the 1F Louis Hospital so that it can be demolished and a new hospital built. Architectural firms are in place for the rebuild or renovation of the 1F Louis Hospital, the Schneider Regional Medical Center, or specifically the Roy Lister Schneider Hospital, and the Myra Keating Smith Community Health Center. At this point, we have been only fully granted the renovation funds for the Charlotte Kimmelman Cancer Institute. That is why the Charlotte Kimmelman Cancer Institute is ready to proceed to construction. The FEMA process to provide us, and I should say the final part of the FEMA process, to provide us with a fixed cost construction offer for the 1F Louis Hospital in the Myra Keating Smith Community Health Clinic is in the final review step with the Army Corps of Engineers. We have reason to believe that we will receive the fixed cost construction, the final amounts, from FEMA this month. FEMA recently approved a project worksheet, a PW, for the furnitures, fixtures, and equipment and build-out of the Myra Keating Smith Community Health Center interim facility. Although that work was done years ago and paid for by Schneider Regional Medical Center, the decision by FEMA to reimburse Schneider Regional Medical Center was only granted last month. The Roy Lester Schneider Hospital is not as close to resolution as Juan F. Louis and Myra Keating Smith. However, it is also undergoing the process with FEMA to determine the final fixed cost offer for a new hospital build. The major importance of securing the FEMA fixed cost offers is that we must have that funding decision before we can proceed with construction. Another factor, and this is also critical, is that our financial plan for the hospital redevelopment team is to fund it through the management fees we will receive with each construction project. Presently, with budget assistance passed by the legislature, we are funding the hospital redevelopment team, which is working full speed to develop those projects. Once we receive the FEMA financial decisions, we can soon start receiving management fees. If we get the decisions later, we carry the cost longer. I will now discuss some of the major funding challenges for the hospitals. Both hospitals have provided balanced budgets as the board requested. We know there are uncertainties and numerous factors outside of our control, but it's important to start with a plan that is balanced. In recognizing our board fiduciary responsibility, it is important we understand some of the major factors that impact the hospital budgets. I read an industry article recently that described the large operating loss that Cleveland Clinic had in 2022. Their CEO is quoted as saying that more than half of the U.S. hospitals lost money in 2022, despite patient demand, because of healthcare services pausing during the pandemic, labor shortages leading to higher wages, and inflation affecting supply and pharmaceutical costs. Of course, he could have been described in Juan F. Louis Hospital and Schneider Regional Medical Center. Nationally, we are negatively impacted by the large inflation in staffing costs, due in large part to the number of professionals who have left hospital work during the pandemic, plus the large inflation in pharmaceutical costs and on healthcare costs in general, as well as supply chain issues. From the federal government level, there are two factors that impact our revenue. These are the Medicare and Medicaid federal health care cost subsidies that cover 2/3 to 3/4 of our billing. For Medicare, the financial challenge is our federally mandated TEFRA payment system. The name TEFRA is made up of the initials for the Tax, Equity, and Fiscal Responsibility Act of 1982. TEFRA was a budget bill designed to save the federal government billions of dollars on Medicare costs. The federal government eventually moved away from TEFRA as the primary Medicare payment system for hospitals, except they left it in place for certain specialty hospitals and hospitals outside the 50 states and Puerto Rico. This is why we still use TEFRA to determine our Medicare payments. We do not have the option to use the more modern system. TEFRA, for us, has not been rebased, meaning it has not been recalculated in numerous years. Presently, the Schneider Regional Medical Center uses 1982 as its TEFRA base year, and the Juan F. Louis Hospital uses 1996. There is no local hospital or GVI control over the rebasing. Congress can force the rebasing, or the Health and Human Services, the Federal Health and Human Services Department can administratively agree to do it. If it happens, both hospitals expect their revenue will increase. CEO Doug Cook had the recent opportunity, along with Governor Bryan and Chief of Staff Knight, to make this argument to the Secretary of HHS and the CMS Administrator. Without the rebasing happening, we continue to be underpaid for a large percentage of our services. For Medicaid, the issue is now the annual cap on federal expenditures. Medicaid is a program that splits costs between the federal and state or territory government, with the local match for the states varying according to state per capita income and the territorial match rate set by law. Recently, the federal government increased the federal match rate for the Virgin Islands for Medicaid to 83%. This is wonderful for us and puts us on par with low per capita income states, which is something we have requested for decades. The previous federal match rate for the Virgin Islands was 55%, although it has been temporarily higher since the 2017 hurricanes. At 83%, it means that for healthcare expenses for a Medicaid recipient, federal funds pay 83 cents of each dollar. This is true until we reach the annual cap on federal Medicaid expenditures. The federal government has a cap on total Medicaid funds available for the territories each year. No state has a cap. I will repeat that. No state has a cap. Once the Virgin Islands reaches the cap, for the remainder of that year, Medicaid will pay zero federal and 100% must be funded with local dollars. The Department of Human Services is estimating that we will slightly exceed the cap this year and estimates exceeding it by as much as $40 million next year. The fiscal year 24 Medicaid cap for the Virgin Islands is estimated to be $139.4 million. If the cap is not eliminated or raised, which takes an act of Congress, then locally the Medicaid system may have to make some hard decisions. We know any cuts to the program, should that be the decision, mean more people coming to the hospitals for free services. From the local level, we also have budget uncertainties. The hospitals have been reliant on PAFRD-supplied nurses and other professional staff for the pandemic period. The federal funding for that has come to an end. Hospitals must have sufficient staff, and when they cannot hire staff nurses, they use travel nurses supplied by staffing agencies. These travel workers are very expensive. I know hospital leadership expects that the recently concluded successful union negotiations will allow us to hire permanent staff and rely less on travel staff. We expect the new salaries to make us more competitive for recruitment. Hiring permanent staff is more affordable than the travel staff, plus it positions the hospitals better for the consistent delivery of quality of care. Locally, we also continue to have a large percentage of clients who do not pay. These are most of the so-called self-pay clients that make up 9 to 14% of the expenses, including the boarders. We're working on the borders with the Department of Health taking the lead, and the hospitals, the Department of Human Services, and the Office of Management and Budget participating. This process of weekly meetings has been helpful. We hope this year to find complete solutions. The number of borders fluctuates over time within each hospital. Presently, Juan F. Louis has 3 borders, and Schneider Regional Medical Center has 13 borders. This is a low number for Juan F. Louis, which had over 10 borders a few months ago. Generally, borders are mostly elderly people who can no longer provide for their self-care. The patients who become borders either do not have anyone to provide the care they need, or their care requirements overwhelm their caregivers. In most cases, borders are people who need the support of a 24-hour care facility like a nursing home. The hospitals become the placement site when the better options are not available. Hospitals are not a good environment for borders as they do not have the right staff. They're not able to provide the socialization and other supports of a long-term care facility, and they are by far the most expensive placement sites. Hospitals cannot bill for border care. Our border issue is directly related to the lack of long-term care beds in the territory. This is a long-standing problem. I became aware of the local shortage of long-term care in the late 1980s when Lutheran Social Services, where I then worked, started providing housing for low-income senior citizens. The problem was long-standing back then. Perhaps it has been exacerbated since the hurricanes, as we have lost some of our limited supply of beds, as the chart below shows. And just for those listening, the chart shows that before 2017, between Herbert Grigg Home for the Aged, Queen Louise Home for the Aged, and Seaview Nursing Homes, we had 95 long-term care beds. Today, that number stands at 42, a loss of 53 of those beds. In addition, before the storms, Human Services was providing services to frail residents, at Lucinda Millen Home to 25 residents, and today that capacity is 10 residents, a loss of 15 resident capacity. A rule of thumb I was once given by a federal official is that a community should have enough long-term care beds for 5% of its population over 65 years of age. While there is not, to my knowledge, an official consensus on how to determine long-term care bed need for a community, I have encountered the 50 beds for every 1,000 people over 65 years old, or the 5% yardstick in other research. A federal Health and Human Services report last year indicated that 3% of the over 65 population lives in nursing homes. A recent private statistical report claims that 4% of Americans over 65 live in long-term care. The 2020 census showed 18,541 people over 65 living in the Virgin Islands. It's about 21% of the population. 5% of this number is 927 beds. 3% of that number is 556 beds. We have only a small fraction of that. I do not know if the 3% or 5% target is a useful figure for us. I do know that people working in the field of elderly services agree that we have a shortage of long-term care beds and a shortage of home-based health care and personal care services. That shortage leads to borders. I know there are plans to rebuild our nursing homes and to build them with more capacity than existed pre-hurricanes. I know there are also plans to increase home-based care. These approaches are critical if we are to eliminate the challenge of hospital borders. The hospitals also face financial competition from private surgical centers in the Virgin Islands, plus for care delivered out of the territory. This takes away a significant portion of the privately insured potential clients. We know we must work on making the hospitals the preferred choice for residents. We may be able to be helped through creating incentives for those with private insurance to choose to use the hospitals. There are positives financially. The funds from the government of the Virgin Islands for the Meditech Expanse, which a few years ago seemed unattainable, has set both hospitals hard at work at implementation for a system that provides so many of quality of care and financial benefits. The millions of dollars from the government of the Virgin Islands through OMB for critical staff recruitment and retention help mitigate one staffing crisis. The millions of dollars of PAFRD staff assistance from the government of the Virgin Islands through the Department of Health has helped staff some of our most critical and hard to hire departments. And although it's at its end now on May 11th, carried us through the pandemic. The emerging health information exchange through the Office of the Governor will help us all with communication and improve patient experience. The executive branch and the Senate have provided millions of dollars to allow both hospitals, especially the Juan F. Louis Hospital, to settle very old debts. We are reestablishing hospital foundations. We look forward to the foundations assisting us gain private support to supplement our other funding. Both hospitals have recruited members to be on their foundation boards, and the Schneider Regional Medical Center recently held a very successful fundraiser for its foundation. We thank this body for the naming rights it granted the hospitals. In conclusion, the past few years have not been easy for the hospital world. Not only were hospitals on the front lines of responding to people affected by the pandemic, but the pandemic itself caused disruptions and changes to the very nature of hospital business. Some reports indicated that 20% or even more workers left the healthcare profession. I've attempted today through my testimony to illustrate some of our successes and challenges. During this hearing, you'll receive more detailed information from the testifiers who are leading the work of the hospitals every day. As I conclude my testimony, I want to thank the leadership of the Schneider Regional Medical Center and the Juan F. Louis Hospital and Medical Center, hospitals and the hospital redevelopment team, and all their staff for their hard work, dedication, and being there for community needs 24 hours a day. I want to thank all the people who work in our hospital systems, from the patient-facing to the non-patient-facing staff. The work of each one is critical, and on behalf of the Board of Directors, I thank them. I also want to express my thanks for the support of the Governor, his senior staff, and the support of the legislature. Time and after time, the executive and legislative branches have come through the hospitals. We have challenges, we have had some success, we have much work to do. This concludes my testimony, and I'm available to answer questions at the appropriate time. Thank you.
Thank you, Mr. Christopher Finch, Chairman Governor Wang Louis, Hospital Board of Director, and also the Chairman of the Virgin Islands Government Hospitals. At this time, I'd like to recognize the presence of the Honorable Vice Chair of the Committee of Health, Hospitals, and Human Services, Senator Kenny Gittins. And also, I'd like to recognize the presence of Senator Donna Fred Gregory. Welcome. Madam Clerk. Also, I'd like to recognize, I see in the video there's some testifiers in the Well and St. Croix chambers. I'd like to recognize their presence, and can you introduce yourself and put your name and position on the record?
Good morning, Greg Bryant, Chief Information Officer, JFL.
Good morning, James Rollins, Public Information Officer, JFL.
Good morning, Chris Lewis, Vice President of Finance and Accounting.
Good morning. My name is Rosalie Javois. I'm the interim Vice President of Finance for Governor Wang F. Louis Hospital. Thank you.
Okay, welcome to all, and pleasant good morning. Yes.
Good morning, everyone. I'm Patricia
yes,
Welcome.
Go ahead.
Good morning, everyone. I'm Patricia Welcome, Chief Legal Counsel at Wang F. Louis Hospital.
Yes, welcome. There was a little feedback in the mic from St. Croix Media. Take a look at that. Okay, Mr. Darrell Smalls, you may proceed with your testimony.
Good morning, Honorable Senator Ray Fonseca, Chairman of the Committee on Health, Hospitals, and Human Services, Honorable Senators of the Committee on Health, Hospitals, and Human Services, other Honorable Senators of the 35th Legislature, Senate staff, fellow hospital testifiers, and the listening and viewing audience. Excuse me. My name is Darrell A. Smalls, Executive Director of Facilities and Capital Development for the Territorial Hospital Redevelopment Team, which I serve under the leadership of Chairman Christopher E. Finch of the Virgin Islands Government Hospital and Health Facilities Corporation. Thank you for this opportunity to testify this morning as to the status of the recovery efforts as it pertains specifically to the Governor Wang F. Louis Hospital and Medical Center on the island of St. Croix. As the Executive Director of the THRT, my primary role is to manage and oversee the planning, programmatic design, final design, bidding, project management, procurement, construction, and project closeout for the redevelopment of our territorial health facilities to include the Wang F. Louis Hospital, the Roy L. Schneider Hospital, the Charlotte Kimmelman Cancer Institute, and the Myra Keating Smith Community Health Center. With respect to the Governor Wang F. Louis Hospital and Medical Center, I'm excited to report that we have successfully achieved several key milestones that have long been in the making. As you have already been apprised, the successful opening and transitioning of patients from JFL into JFL North was the direct result of planning and that culminated with the seamless transition that was several years in the making. Many kudos have been shared towards our many dedicated partners, vendors, and stakeholders. However, I would like to take this opportunity to personally thank Mr. Charles Creighton of the Virgin Islands Department of Education. I personally reached out to Honorable Commissioner Dion Wells Hedrickton in early March, who without hesitation, through Mr. Henry Lloyd, Director of Transportation, provided the requested assistance. Mr. Creighton worked tirelessly alongside the JFL team after hours, nights, weekends, and even in the rain to assist with moving many pieces of medical equipment and supplies. A heartfelt thank you and a debt of gratitude to you, Charles. While we have experienced great success thus far, there are 4 important milestones that remain. First and foremost, we will soon break ground for the construction of the critical administration building, which will house critical non-clinical functions for up to 20 personnel to include physician and nursing administration who will directly support JFL North. The critical administration building will also serve as the primary entrance to JFL North and will provide connectivity between JFL North and the VICC. We will commence the construction of the foundation within the next 2 weeks, after which we will commence with the erection of the 6,500 square foot facility. The building is already in production, and the long lead component, the elevator, has been released for fabrication. The building is scheduled to be completed and ready for occupancy by October of 2023. Another key objective is the development and construction of the 5-acre lease lot to the east of JFL North. The development of this lot will provide space for the much-needed parking that is required to support the operations of the interim hospital facility as well as for visitors. Equally important, this lot will house a 10,000 square foot building that will provide relatively close access for medical records, materials management, and facilities maintenance. Our construction plans and specifications are 100% completed, and the project will be publicly advertised during the month of May 2023. Construction is slated to be completed by the second quarter of 2024. Thirdly, and proceeding concurrently with the 2 previous projects, is the transition of the remaining non-clinical personnel that remain within JFL Maine to our leased off-site facility. The retrofitting of this facility has commenced and will be ready for occupancy no later than September of 2023. This off-site facility will house all non-clinical support functions such as the executive leadership team, human resources, business office, medical records, IT, and will provide for the major bulk storage to support materials management and dietary, along with other critical hospital supplies. Fourth, and equally significant, are the renovations that are required within the VICC. These interim renovations will enable critical functions that presently remain within JFL Maine that are critical to the operations of JFL North to be safely relocated. These vitally important functions support direct patient care, which were not integrated into the JFL North facility, yet are essential to the provision of care. A few of the non-patient functions include the network data center, the telephone communication center, as well as the critical, not critical, but the television network hub, which is feed directly out of the VICC. Other outpatient care functions include outpatient radiology services, the interim JFL North inpatient and outpatient access, physical therapy, and outpatient diagnostic cardiology services, just to name a few. While these are significantly huge milestones, I would be remiss if I did not take this opportunity to state for the record the most important project yet to be undertaken that is not within the functions of JFL North is the demolition and eventual construction of the new state-of-the-art Juan F. Louis Hospital. To date, we have cleared the major hurdles to finally arrive at a fixed cost offer from FEMA. No later than Friday, May 12, 2023, it is anticipated that the independent expert panel, the IEP, which is an entity outside of FEMA but within the Army Corps of Engineers, will have completed their review, and the project will then proceed to what's called the Large Project Notification Process, or LPN process, which can take up to 45 days, after which we will have received notification that the project has been obligated. Due to the fact this is considered a mega project, or one greater than $25 million, there are a number of reviewers who must review the overall project in great detail. As this is a large project, Congress will be involved, as they too must approve the funding for this most important project. Once we receive the official fixed cost offer, we will commence immediately with the issuance of a solicitation, specifically a request for qualifications, RFQ, to review and establish a pool of qualified respondents who ultimately will be deemed responsive and be eligible to submit a proposal once issued for construction of the new Juan F. Louis Hospital and Medical Center. My team and I, along with FEMA and the Office of Disaster Recovery, have remained and will continue to remain vigilant throughout this entire process. Similarly, The THRT, along with the Territorial Board and the Executive Leadership Team, has forged a transparent and collaborative working relationship to bring to the forefront and address all issues that may arise. As with any construction-related projects, we have encountered numerous roadblocks. However, my team and I have continued to work tirelessly and creatively to obtain the required outcomes needed to successfully meet our objectives. While there is still more work to be accomplished, there is no doubt in my mind that together we will be stronger, provided we work collectively towards one objective, and that is to construct the most efficient, standardized, resilient, sustainable, state-of-the-art healthcare facilities for the people of the Virgin Islands. As I conclude my presentation today, I want to personally thank Ms. Kristen A. Hodge, Recovery Director, JRO, or the local arm of the FEMA in the territory, for her continued support of our hospitals, and Mrs. Adrienne Williams-Octolan of the Office of Disaster Recovery for her unwavering support as the liaison between the hospitals and FEMA. Equally important, I want to thank the Territorial Board, the executive leadership of JFL, the staff of JFL for their support of the Territorial Hospital Redevelopment Team, and I also want to personally thank the professionals who make up the Territorial Hospital Redevelopment Team. This concludes my presentation. I will remain available to answer questions at the appropriate time.
Thank you very much, Mr. Darrell A. Smalls, professional engineer, executive director for the Territorial Hospital Redevelopment Team. I'd like to also recognize the presence of non-committee member, Senator Frankie Johnson, over in the chambers on St. Croix. At this time, Mr. Doug Cook, we would receive your testimony, and media, you can also begin the presentation.
Good morning, Honored Senator Ray Fonseca, Chairman of the Committee of Health, Hospitals, and Human Services. Honorable committee members, other senators of the 35th Legislature. And the US
Can you speak
Virgin
closer into the mic, Mr. Cook?
Is this better?
Yes.
Great. Other senators of the 35th Legislature and the U.S. Virgin Islands present and the listening and viewing audience. I am Douglas Cook, Fellow of the American College of Healthcare Executives, and I am Chief Executive Officer of Governor Juan F. Louis Hospital and Medical Center. I appreciate the opportunity to be with you this morning to discuss our recent move to JFL North, current staffing levels, current recruitment activities, wait times at the ER, and the ongoing situation with our borders. To assist with this presentation today, I have invited Chief Nursing Officer Doris Plaskett, Chief Operating Officer Hazel Filbert. Our Chief Medical Officer Mavis Matthew is unable to attend our Senate hearing today. Chief Legal Counsel Patricia Welcome, Chief Information Officer Greg Bryant, Chief Executive Vice President of Finance Rosalie Javois, and Vice President of Finance Chris Lewis, and Public Information Officer James Rollins. I want to begin by thanking the incredible JFL staff, the staff of the Territorial Hospital Redevelopment Team, the Territorial Governing Board, for our successful move from JFL to JFL North. On April 22nd, 2023, the first patient arrived at 7:15 a.m. to JFL North. The last patient arrived at 12:17 p.m. We had a total census of 35 at the beginning of the morning, 4 were discharged during the move, and a total of 31 patients were moved. We had the incredible support and partnership with FEMA, Office of Disaster Recovery, Department of Health, Virgin Islands Territorial Emergency Management Agency, Department of Education, Department of Property and Procurement, Virgin Islands Fire Service, Twin City, and AeroMD. Virgin Islands Water and Power Authority, Carib Supply, National Guard, everyone at Government House, the Senate, and our dedicated board. As you are aware, JFL North represents a temporary hardened structure hospital consisting of 53 inpatient beds. This is broken down into 23 medical surgical beds, 12 critical care beds, 10 labor and delivery beds, 4 neonatology intensive care beds, and 4 pediatric beds. This is relatively the same number of beds that we had available in JFL Main. The new emergency room at JFL North is expanded with 26 beds between the ER and the fast track areas, plus an additional 4 rooms available for behavioral health holding until appropriate placement can be arranged for them either as an outpatient or in inpatient care off island. Our facility has several innovative technologies, such as our laboratory analyzers that can process up to 25 times more specimens in one cycle than was previously available. We also have a new 128 slice CT scanner that allows us to scan patients in a faster period, which will increase the quality of image due to less motion artifact. Our new surgical suites are built to the latest standards and have a much larger square footage that will allow our surgeons and staff to have the much needed space for the different technologies being used. Our nursing teams can better provide care, quality of care, by having monitoring systems at the bedside, but also at a centralized nursing station so that the patients can be monitored remotely. While there are many nice features of JFL North, we should not forget that this is a temporary structure and that there are plenty of drawbacks and challenges that we will need to overcome in the weeks, months, and years to follow. Our teams are actively working to ensure the necessary preventive maintenance and contracts and support systems are in place to maintain our JFL North operations. Our collective goal needs to be on making JFL North work for now, while we focus our attention on designing and the construction of a replacement hospital for the St. Croix community. We look forward to working collaboratively with this committee as that process continues. The official invitation to provide testimony today requested a list of X-ray equipment over $10,000 and what equipment is still needed, a list of physician specialties currently staffed, as well as those still needed. All accounts payable to include Pafford staffing, all accounts receivable, our plan to improve our wait times in the ER, and our plan for borders. These will be covered in the following testimony along with other operational priority areas. With the recent opening of JFL North, we have added 2 new pieces of radiology equipment to the program. Those include the Philips X-ray room and the Philips 128 slice CT scanner. The other X-ray equipment over $10,000 is provided in your Exhibit A. While we are fortunate to have newer technology such as a CT scanner to our imaging department, the JFL hospital is without several basic imaging needs. Our current list of imaging equipment that is needed includes fluoroscopy, nuclear medicine, portable X-ray unit, C-arm, ultrasound, cardiac catheterization lab, stress testing, and MRI. Each of these units vary in cost and range from $25,000 to multi-million-dollar investments. These projects are currently being evaluated and will come forward through our board for future consideration as part of our capital budgeting request process. Due to the excessive costs of each of these and the ongoing support costs, it is extremely important that we do the necessary due diligence and the return on investment analysis. JFL currently has 30.5 staff physicians. You can see this in Exhibit B. An additional 35 staff physicians are needed to bring us to full capacity. For your convenience, we have provided a breakdown of physician needs assessment by specialty. It is also important to note that JFL does not necessarily need to employ all of these specialties. As Exhibit B shows, there are another 15 physicians with privileges that provide services at JFL, but not employed by the hospital. Clearly, there are exceptionally talented physicians in this territory, and we welcome and encourage them to apply for privileges and support care locally at the only hospital in St. Croix. Much of our time over the last year has been ensuring that JFL North becomes operational. Now that we have accomplished that, we must earn the trust and respect of the local physicians by consistently providing them a high quality and efficient place to practice medicine. Our accounts payable continue to improve. While the current outstanding balance is approximately $19 million, it is worth mentioning that we have decreased our accounts payable over the last 3 years from $35 million to $19 million. This has been accomplished by working closely with the legislature, the Office of Management and Budget, the Department of Finance, and our board to settle some legacy outstanding debts. You specifically asked about PAFR staffing. To date, we have not received an invoice for our 10% obligation for the past 3 months for PAFR staffing. We do, however, use other staffing agencies, Aya and Anders. At the end of March, our balance was $155,000 and $236,000 respectively, which are all current. Our current accounts receivable continues to improve by increasing our collection rate through the implementation of our Craneware software system. Because of the limited capacity of JFL Maine and our limited ability to grow our gross revenue has only been growing by 2%, but our net patient revenue has improved by 19% over the past 2 years. We are working in collaboration with the board to reconcile our receivables with the reconciled number of $21 million. Based upon our current collection rate, we expect to collect approximately $10 million over the next 3 months. Exhibit C will show our average wait times for the past year by month in the emergency room. While we have a goal to see patients within 25 minutes, you can see our average ER wait time from first contact to seeing a physician is 81 minutes. We know this is longer than we want it to be, and we certainly know that it's longer than our patients want to see as well. It is also especially important to note that all of our patients are triaged upon arrival, and those with critical life-threatening issues are immediately taken to exam rooms and treated. As you would expect, this causes delays for those patients with less urgent needs. To provide further context, the slide that you see now shows the average ED wait times by state. The average wait time in the U.S. is currently at 145 minutes, approximately 2.5 hours. Again, it is important to note that these times are reflective of non-life-threatening emergencies. Emergency department wait times are complex, hospital-wide issues that are impacted by resources such as staffing levels, treatment room and bed capacity, radiology laboratory turnaround times, physician specialist consultation availability. For all of these reasons, JFL has established a multidisciplinary team called the EDIT Emergency Department Improvement Team to plan, oversee, and monitor quality improvement strategies to reduce our ED wait times. One of the benefits of this type of multidisciplinary team is that different disciplines bring different perspectives and knowledge about the challenges, underlying causes, and are engaged in the potential solutions. Moreover, JFL North has a designated ED fast track space with 4 treatment areas. Aggressive plans are in motion to utilize this to reduce the non-emergent minor complaints of our waiting room. The long-standing issue of borders has plagued the territory for decades and is largely outside of the control of the hospitals. In 1986, Congress enacted the Emergency Medical Treatment and Labor Act, EMTALA, to ensure public access to emergency services regardless of the ability to pay. Section 1867 of the Social Security Act imposes specific obligations on Medicare participating hospitals, such as the Juan F. Louis Hospital, that offer emergency services to provide a medical screening examination when a request is made for examination or treatment for an emergency medical condition, including active labor, regardless of the individual's ability to pay. Hospitals are then required to provide stabilizing treatment for patients with EMCs. If a hospital is unable to stabilize a patient within its capability, or if the patient requests, an appropriate transfer should be implemented. The long-standing borders at JFL and Schneider Regional Medical Center is primarily due to the lack of long-term care beds in the territory. Our case management department continues to work closely with the Department of Human Services and other transitional care and home assistance services to facilitate the placement and disposition of border patients. This is an ongoing and continuous effort to reduce the extended length of stay of our patients to improve the timeliness of discharge placement for patients that do not require acute hospitalization. There are presently 3 borders, and our case managers are working diligently to find appropriate discharge placements. This is a notable improvement from just a few months ago when the number exceeded 10. As I mentioned above, the collaborative effort of many agencies and individuals has contributed to the lowering the number of borders at JFL. I would like to take this opportunity to update the committee on a few recent changes at JFL. Dr. Raymond Cintron resigned as the Chief Medical Officer position effective April 3, 2023. Dr. Cintron served as the Chief Medical Officer of JFL for the past 7 years. We will begin the recruitment efforts for a permanent CMO in the coming weeks. It will take some time to find the right leader to support and partner with the hospital's medical staff. Until such time, I am extremely excited to announce that Dr. Mavis Matthew has accepted the interim Chief Medical Officer role. She began her role on April 1st. Dr. Matthew has practiced pediatric medicine in St. Croix since 1987. She also previously held the Chief Medical Officer role at JFL in 2016 and was Commissioner of Health during the Turnbull administration. Recruitment and retention of permanent staff continues to be one of the top strategic priorities and is critical for the future of our success. For the past several years, JFL has had multiple interim human resource leaders. Due to the extreme importance HR plays in every organization, we are moving forward with a permanent leader over this department. Ms. Patricia Canagata has been hired as our new Chief Human Resource Officer and will be joining the JFL executive team on May 8th, 2023. I want to personally thank Nicole Samuel Miller for her time as our most recent interim VP of HR. JFL is also working collaboratively with Schneider Regional Medical Center on recruitment efforts and focusing on the development and the innovative marketing and advertising materials to create a new talent, to recruit new talent and reduce our resilience on contact labor. I surely do not need to explain to this committee that our country is experiencing a national healthcare staffing crisis. The American Nurses Association stated that there are more registered nurse jobs available than any other profession in the United States. The U.S. Bureau of Labor Statistics projects that more than 275,000 additional nurses are needed from 2020 to 2030. And the average age of registered nurses in the U.S. is currently 51 years old. And more than a third of nurses said they plan to leave their current roles by the end of the year due to burnout and stressful work environments. Our territory hospitals are just like every other hospital in this country that has been relying on contract labor. JFL is currently supplemented by contract staff, 15 traveling RNs, and 2 traveling X-ray techs, and 25 PAFFord RNs and 5 PAFFord registered respiratory therapists. The contractual arrangement with PAFFord that is a 90% subsidy through DOH will conclude on May 11th. Our leaders are working proactively to address these problems. We have recently completed the negotiations of the Virgin Island LPN Nurse Association, the Virgin Islands Registered Nurse Association. These new wage agreements will put the hospitals at a more competitive pay plan to recruit permanent advanced practice nurses, RNs, and LPNs. Negotiations are still ongoing with the Registered Nurse Leadership Union. JFL's clinical partnership with the USVI School of Nursing continues to be very productive and mutually beneficial. In May of 2022, JFL reestablished the Graduate Nurse Program as one of its recruitment initiatives. 9 of the 14 graduate nurses participated in JFL's graduate nurse program, and a total of 7 have successfully passed the NCLEX RN exam and are now on staff. So far, JFL has hired 10 RNs from the 2022 nurse graduate class. There are now 10 prospective nurse graduates in May of 2023. JFL has already planned a recruitment fair and an open house for May 9th in hopes to recruit all 10 prospective graduate nurses to participate in the graduate nurse program. As our teams focus on recruitment and retaining the best staff, we are also focusing on the quality of care being provided. With the continued transition into JFL North, our regulatory compliance with CMS conditions of participation is a top priority. Note that there is no distinction between the regulatory standards for a temporary hospital or a brick-and-mortar facility. JFL has worked towards this goal to ensure compliance with regulatory requirements and provide safe quality of care for the patients in our place. JFL also recognizes the need to augment revenue to stabilize our systems that are key to the delivery of quality of patient care for the people of St. Croix. Our focus on improving efficiency and quality will help us increase our overall volume of patients through the facility. We also recognize the need to restore some of the revenue-generating outpatient services from which we were once the sole provider of, and at least reclaim a percentage of that market. The opening of JFL North, combined with the demanding work to decrease our border population, has created an opportunity for our organization to grow and reintroduce service lines that have been abandoned over the past years. As I begin to close today's testimony, I want the committee and the community to know that we value your insights, feedback, and suggestions. Since my start in this position, this committee has repeatedly stressed the need for a public information officer. Our newly hired PIO, Mr. James Rollins, is leading JFL's efforts on community engagement and communications. Mr. Rollins has lived in the St. Croix community since 2015 and comes with close to 20 years' experience in communications, marketing, and public relations. Efforts have already been made to improve the JFL website and our social media presence. In fact, JFL's Facebook page has seen a 195% increase in reach, and our Instagram page is up 199% in reach since January of 2023. These increases, combined with radio talk shows and television appearances by me and other JFL leaders, along with radio and newspaper ads and community events, will allow for the increased efficiency in the communication with those that we serve. As always, the JFL executive team thanks Honorable Senator Roy Fonseca, for Chairman of the Committee of Health, Hospitals, and Human Services, and all committee members of Health, Hospitals, and Human Services for granting us the opportunity to provide testimony today. As stated on a recent radio show, I believe my new title should be Chief Thank You Officer, as I am constantly thanking so many individuals and groups for their ongoing support. A special thank you to the Governor and his team and the support of this legislature. Our Board of Directors continue to demonstrate their commitment to our hospitals, and I thank them for their ongoing dedication. The entire JFL family deserves our appreciation, and my executive team has moved obstacle after obstacle to get us where we are today. And I can't thank them enough for the long days, sleepless nights, and time away from their families. Finally, to the community of St. Croix, thank you for the overwhelming support, grace, and love you have shown JFL. I will omit my last paragraph as it was a transition to Mr. Smalls, but since we changed our testimony order, this concludes my testimony. We look forward to answering any questions you may have. Thank you.
Thank you, Mr. Cook. You know, this is incredible. You know, in reading your testimony, I noticed you have that Philips CT scanner, which could do 128 slides. So I'm very, very excited to hear that Senator Gittins, you're recognized for your point of information.
Thank you, Mr. Chair, and good morning to all. Mr. Chair and colleagues, I've sat here and listened to 3 testimonies, and in recent weeks, we've seen an uptick in shootings throughout the territory. We've listened to 3 testimonies, and I've yet to hear any substantial information on safety and security at the hospital. I just wanted to know whether or not anyone that's sitting at the table is responsible for the hospital's law enforcement division. And if there's someone here, who would that person be?
Senator Gittins, this is Doug Cook, Chief Executive Officer. I'm responsible for all services at the hospital, so if I can hopefully answer your question that you may have.
So there's no law enforcement chief for this division?
The law enforcement chief, as you stated, the security department of JFL reports to Patricia Welcome, our chief legal counsel.
CEO Cook, you and I both know that the hospital legislation have created a hospital law enforcement division. And are you telling me that the HR person is responsible to have oversight of this division? Was it the HR or legal counsel? Who did you say this? I'm sorry.
Patricia Welcome, Chief Legal Counsel, from an executive level, oversees the security department at JFL.
Okay, thank you, Senator Gittins. I'd like to recognize the presence of committee members, Senator Bolkers, non-committee member, Mr. Frankie Johnson, and also committee member, our Senate President, Novell Francis. At this time, the Committee of Health, Hospitals, and Human Services will stand in recess for 3 minutes. the Committee on Health, Hospitals, and Human Resources is back in session. Mr. Cook, you know, it's so excited. You know, I got to go back to that Philips CT scanner that can do the 128 slice. Because, you know, what we experience in the Virgin Islands is a lot of our residents go off island for medical treatment. And, you know, sometimes we need to, you know, advertise what we can do so that our residents can, be aware of, what treatment can be offered here. Because I was doing some research, that 128 slice, compare that CT scanner to what you get at Cleveland Clinic or Mayo Clinic. What's the difference? Do they have a better CT scanner than us?
Thank you, Senator. Doug Cook, CEO for JFL. It's relatively the same type of quality of scan, absolutely. They might have a higher slice, so as technology evolves over time, the more slices come out. We have currently 128 slice. I'm sure they have 128 slice as well. They might have a 256. What that means is you're able to scan a larger portion of the body in one revolution of the CT scanner. Which that means from a patient perspective, from a physician perspective, is that we're able to scan a larger section of the body, which your body is constantly moving while that's happening. So the faster we can scan, the less artifact that we get, and the more precise of a diagnosis that we're able to give to our physicians and for our treatment of our patients. So this scanner is state of the art. It is in Cleveland Clinic. It is in every major hospital system in the country.
Okay, that's so good to know. We for this block one, we're gonna go to a round of 6 minutes, Senator, and we'll start with Senator Marvin Blyden. Senator Blyden, are you there? You're recognized for your 6 minutes. You may proceed.
Thank you, Mr. Chair. Good morning to my colleagues, the listening and viewing audience. Staff, Secretary Staff, and good morning, testifier. Thank you so much for those most comprehensive testimonies. A lot of information, good information. Well, let me start with the last testifier, CEO Cook. And I'm going to continue on the line of questioning in respect to your listing of equipment. You have those that are needed and those that need to be replaced. So how do you strike the balance of exactly prioritizing which equipment you're going to try to get first? How will it fit into your budget? And lastly, how can you find a way to build back that trust with our community in terms of assuring that, you will get the best care here instead of going elsewhere when it comes to equipment and replacement of equipment? Because apparently that's very critical to your operation. So can you succinctly explain that to me, please? How do you strike that perfect balance?
Thank you, Senator Blyden. This is Doug Cook, CEO of JFL. A very good question. As technology continues to change within healthcare, there is always going to be new technologies and new equipment out there. What leaders of healthcare systems need to do is to work with their boards to strategically plan which pieces of technology they're going to invest in. With the list that you have in front of you related to JFL, there are some basic equipment needs that are in almost every hospital that we do not have in JFL Maine or JFL. And I'll speak to one of those specifically, our fluoroscopy unit. What fluoroscopy is essentially live x-ray so that you're able to visualize through x-ray a patient as we're doing a what we call a barium enema or an upper GI study, and we're able to diagnose different digestive issues. This fluoroscopy is a basic function of most every hospital, and yet ours is non-functioning, has not been functioning for years. So that to answer your question specifically, how do we go about choosing which ones we invest in? First, we have to focus on the quality and safety of patient care. And following quality and safety, we then go to working with our physicians related to what will attract new physicians or new technologies to our hospital. And finally, we look at return on investment of how our investment in this technology can come back and produce additional revenues for the organization.
Okay, thank you for that. And also, Mr. Finch and Mr. Small spoke to the challenges of JFL North, and I appreciate them explaining that because it is a new facility and you are going to have challenges, but I'm sure that they will overcome those challenges. But let me ask in respect to Myra Keating Smith in St. John. And I believe it was Mr. Smalls or Mr. Finch, I'm not sure which one, spoke to FEMA and the reimbursement. And he said they were just reimbursed, I believe, last month. Can you?
Good.
FEMA, how much were we reimbursed from FEMA? How much?
Okay, good morning, Senator. This is Mr. Darrell Smalls, Executive Director. The Myra Keating Smith recovery effort is sort of a unique situation occurred after the hurricane. Unlike most of the other entities within the government of the Virgin Islands, FEMA was the first entity that stepped in. In the case of Myra Keating, it was a mission assignment by the Army Corps of Engineers. So the Army Corps of Engineers provided the facility or the structure that was placed on the island of St. John. Unlike, I would say, FEMA, where they funded the development of the facility, not only the structural facility, but equipping it and building out the interior, the Army Corps simply provided a structure. The Schneider Regional Medical Center, in turn, had to do the internal build-out of this facility out of its own costs. Subsequently, we appealed to FEMA to create a project worksheet that would have been able to fund or refund the Schneider Regional Medical Center for all of the funds that were outlaid to make Myra Keating Smith a functional facility. So that's why that took some period of time. It was a mission assignment by the Army Corps, and through diligence of my team, we were able to successfully work with FEMA and get a PW, which now we are in the process of getting reimbursements to the Schneider Regional Medical Center.
And what the price tag? That's what I want to know. That's what I want to know. What the price tag? How much are you going to be reimbursed?
I believe it was just under $500,000 that we had expended.
Okay, very well.
We meaning Schneider Regional.
Page 5 and Mr. Okay, thank you. I believe on page 5 and Mr. Finch's testimony, he also spoke to Tierra, and he spoke to Mr. Knight, the governor, other individuals, trying to see how they can basically deal with that situation. But I did not hear any, the delegate. What role does the delegate play in respect to Tierra? Because I know that's from Congress, but I did not hear the delegate name mentioned. Is there a reason for that, or what did the oversight?
Chris Finch, Board Chairman. Senator, I think you're talking about the TEFRA rebasing. The delegate has had a bill that is still active, and you're correct. I did not mention and perhaps should have. The delegate has had a bill for the last couple of years that would require. Congress would then be requiring the Federal Department of Health and Human Services to do the rebasing study. That bill also included increasing the federal Medicaid match rate to the 83%. That piece of it was taken out and was done within another bill within the current presidential administration, but the TEFRA piece was not. I know the government law firm of Winston and Strawn is also attempting to work, I guess, from a lobbying perspective, on getting the TEFRA rebasing done. The only point that the hospitals will have a strong argument to somewhat force it is when new facilities are built. JFL North won't do that for us, so we've been told, but the new JFL, the new Schneider will. But those are ways down the road.
Okay, thank you so much for your response, and thank you, Mr. Chair, for the time. Thank you.
Thank you, Senator Blyden. It's been a lot of comments in the community for the JFL North modular. The governor was over there for the groundbreaking for the new construction recently, and he made the comment, and I want to echo him because this has been going on for a long time, and he said something to the effect that some people graduate magna cum laude and some summa cum laude, but for JFL North is thank you laude. So we're so happy that that facility is open. Real quickly, I'm going back to that CT scan, Mr. Cook, with the 100 and, 828 slice capacity. The residents that go off island, can you give me an example of a popular treatment that our residents go off island now that we can do locally with our new equipment?
Well, certainly, the care of our patients is really a relationship that they have with their primary care physician, and depending on what their diagnosis is, it will depend on if they can have those treatments or those services provided locally, or if JFL or Schneider Regional doesn't have that service, they might have to go off island for. So, a very clear example of things that people go off island for is radiation oncology. Neither island has that service available now. So people do transfer off island, that's appropriate. But bringing now with JFL North coming back online, there are new technologies that we're able to provide, such as colonoscopy procedures, for example. We provided colonoscopy procedures before, but now we have a dedicated suite just for colonoscopies. We can do it much more efficiently. We can do it, all of our physicians that do colonoscopy procedures have access to that suite and are able to schedule their patients here and keep the care locally.
Okay, that's very good to know, because I remember when I was a younger guy, when the Roy Lester Snyder Hospital had just opened up. I remember Dr. Snyder and Dr. Heath, they were performing kidney transplants, liver, and all those things, So we're getting to the stage now where we're opening new hospitals. So that's good to know. So we're gonna go. Yes, Madam Gregory, Senator Gregory, you're recognized for your point of inquiry.
Thank you, Mr. Chair. I want to go back to the discussion around the TEFRA rebasing. I want to say Commissioner Finch. Very quickly, I know that one of the things that are considered as we are looking at the TEFRA rebasing is the national average cost. But of course, in the Virgin Islands, I don't believe that we sit within the national average. So are we truing up any documentation in order to justify, outside of the rebuilding of new hospitals, et cetera, to justify the need for the consideration for the rebasing?
I believe, and perhaps the hospital financial people can answer better, Senator, but the hospitals are, they're audited every year, and they're able to demonstrate their costs for providing certain procedures, and so I think the task is going to be specifically for that, is to attempt to show that the Medicare reimbursement is not reimbursing the actual cost of the hospitals.
Okay.
For procedures.
So let me just follow up a little more. But what I'm basically asking is, so is there true discussion around consideration for TEFRA rebasing, and is there work that's occurring to support what we're trying to accomplish? I think that's what I'm asking. And of course, this is not only for JFL, but this is a territorial discussion. So put on your territorial hat for this one.
Correct. And I would bow again to the financial people if there's parts that I do not know. I do not believe at this point there's specific work happening, because we haven't had any hope that it was going to happen. If we got a notice that, okay, you can be rebased, then we'll do the work.
Okay, so right now there isn't a priority, and that consideration happens on the national level, then we trickle on and begin to do the work. I would think that it would be the other way around, where we would show our justification, as if you will, and then consideration would be given for, to open a door for even the discussion.
And I did mention in my testimony that Mr. Cook was able to meet with the Secretary of HHS and the Administrator of CMS, along with the Governor and Carl Knight, Chief of Staff, and to specifically ask about the TEFRA rebasing to be done. I understand your point, and we are. There's a robust effort to attempt to get as much financial information, as much understanding of our finances as possible. The original rebasing years are so long ago, with it only being adjusted by an inflation factor. Since then, we know, particularly in the case of Schneider, that has the original 1982 year, that there's absolutely no way some cost determinations made in 1982 have much relevance to 2023.
Got it. Absolutely. Thank you for your response.
Point of inquiry, Senator Potter, you're recognized for your point of inquiry.
Thank you very much. Just on that same note, Mr. Finch, regarding TEFRA, I was just curious. You mentioned that Schneider Regional uses 1982, while JFL uses 1996. I was just trying to understand, since we have one hospital system, just trying to understand why the difference.
It's a very good question, Senator. I actually don't know the answer. For some reason, JFL was rebased in that later year, and Schneider was not. The hospitals were much more separate back in those days. I think that was before the creation of the territorial board. But I don't know if anyone from
after Hurricane Hugo.
Oh, it was a post Hugo rebasing.
Okay, thank you.
Thank you, Senator Potter. Next, we're going to go to Senator Diane Capehart, and then following Diane Capehart will be Senator Maurice James. Senator Capehart, you're recognized for your 6 minutes.
Thank you, Mr. Chair. Good day to my colleagues. Good day to the testifiers. Congratulations to you, Mr. Chair, on your first committee meeting.
Thank you.
And I want to just congratulate the JFL team for getting the modular hospital up and running. So I just wanted to say that because I've had the opportunity to do the walkthrough and I was quite impressed. When you look at it from the outside, you like, what is this? But when you go inside, you are impressed with the modern technology of equipment that you have at that hospital, at the modular. But one existing problem that I know that we have is a lot of individuals get airlifted out of the territory, out of particularly Wang Lui. I can't say for Roy Schneider Hospital, but tell me, why is a lot of patients being airlifted and you cannot render the service at the hospital?
Thank you, Senator. Doug Cook, CEO for JFL Hospital. I'll start to answer that question. There's a variety of reasons, and it really depends on the condition of the patient. For example, if there is a car accident and there's a major blunt trauma to the thorax, we do not have a cardiothoracic surgeon in this territory that's able to care for that type of injury. So that's one example. So it's really about physician specialty and availability. Another example would be is if a patient's coming in with an acute stroke. We do not have a neurosurgeon on island to be able to do a declottation of a thrombolysis into the cranium. So I think number one, it really goes down to physician specialty and the ability to treat. But it's not just about the physician specialty. It's, do you have all the services available to support that physician, and because it's a care team.
So CEO Kosh, it's Kosh?
Cook.
Yeah. Okay. So with that being said, are you trying to recruit specialty doctors to the hospital so you could minimize the amount of airlifting of patients?
Thank you again for the follow-up question. Yes, we are. But one of the things we need to do, for example, in cardiology, is we need to get out of JFL Main to create space, because what we were doing is we had such limited
3 minutes.
space available to work with. Our VICC, which was built and designated for cardiac care, was taking care of borders. It was taking care of just regular medical surgical. Now that we have JFL North open, we will now begin the rebuilding of that cardiac program.
Okay, thank you. Can you tell me the dollar amount for your uncompensated care?
I do not know the number off the top of my head. I would defer that question to our VP of Finance, Chris Lewis. Chris, are you able to give us that number?
Uncompensated.
While he looks for that information, do you still have presumptive eligibility at the hospital?
Yes, we do still have the presumptive eligibility program, and we're very thankful for it. Every patient that is coming through our facility, either through our ER, is screened for that availability for that resource.
So you're saying that individuals who do not have health insurance, they come for a first-time visit, they are offered presumptive eligibility.
They are screened to go through the process, but it's a multi-step process to be able to be approved for it. So yes.
Okay. How many travel nurses do you have?
We have currently 25 traveling nurses being provided by Pafford, and we have 15 other traveling nurses being provided by other staffing agencies.
Thank you for that. So I spoke to someone from Pafford, and they said that the hospital have not paid them. But in your testimony, you stated that you're waiting for invoices. Can you clarify that for me?
1 minute.
Doug Cook, CEO for JFL. Yes, I can clarify the fact that prior to 3 months ago, all expenses were being paid through the VA government, through the Department of Health. For the last 3 months, the agreement was that moved to a 90-10 split, where the hospitals would be responsible, and other agencies that are using Pafford Nursing would be responsible for 10% of that cost.
30 seconds.
So does that answer your question?
Yes.
Okay.
We could have further discussion on that.
Sure.
Where is your offsite facility that would house your non-critical support staff?
Good afternoon, Senator. Good afternoon, Senator. Darrell Smalls. That is located on the Hess Road. We call it Cassava Gardens.
Okay, and that would be it would not cause any interruption with your service, with the administrative staff being offsite?
No. The critical administrative building that can accommodate up to 20 persons is kind of a float site. So individuals, whether it be executive leadership, business office, can float to the critical admin, but their permanent location perhaps will be at Cassava Gardens.
Time.
Okay, thank you. Mr. Chair, if I may.
Yes. Proceed.
I just want to ask, as it pertains to supplies, I'm going to just give you a scenario of what happened to two individuals taking their children to the Wang Louis Hospital. And it was basically for the child inserting an object in the ear and the nose. And they were not able to be serviced at the hospital because there was no equipment to remove those objects from their ear and their nose. What is the hospital doing for those critical supplies that is well needed, and as simple as it sounds, that the hospital doesn't have these critical supplies? Can you tell me?
Thank you for the question, Senator. In order to answer that question fully, I think I need a little bit more information, because depending on the depth of the object inserted into a nose or ear will require if it's visible, you could remove that with a simple device. If it's much deeper, where you need to use basically a scope and go into the into the nasal cavity, then that's a different type of piece of equipment. I can tell you, to answer your question further, I have recently just sat down with one of our ENT surgeons to walk through specifically what piece of equipment we currently do have and which we don't, and have formulated a list to make sure that we have all those supplies available for them.
Thank you, Mr. Chair, for your leniency.
Yes, thank you, Senator Caput. Mr. Cook, I wanted to follow up with one point there when the PAFFORD nursing, it's being phased out. You mentioned in your testimony that you have about $19 million in accounts payable. Is PAFFORD part of that, accounts payable? Is the PAFFORD staffing part of that?
No, sir, not currently, because we have not been billed for any PAFFORD nursing services at this point.
Okay, so you paid up current with the PAFFORD nursing?
We have not received a PAFFORD statement yet, so we have not been billed anything, so it wouldn't be in our accounts receivable. The two other staffing agencies which we are currently working with, one is called AYA, one is called Anders. We are current with our payments with them.
Okay, thank you very much. Senator Maurice James, you're recognized for your 6 minutes, followed by Senator Samuel Carrion.
Good afternoon, Virgin Islands. Good afternoon, testifiers, colleagues, everyone. Thank you, Mr. Chairman. I just want to remind you that Senator Johnson came in after I did and before Senator Carrion. So we protocol, right?
Yes.
It's just a quick reminder for you. I want to first ask, well, first of all, I really want to extend my condolences to the family and friends of Judge Eileen Peterson. As you know, as an attorney in the Virgin Islands, I, of course, knew Judge Peterson. And I know that my colleagues sitting in here also knew her well, and I believe you were her last law clerk, Attorney Pat Welcome. So my condolences to the friends and family, to the court family, to the Virgin Islands bar members who knew her, and of course, at her last position at the Casino Commission, my condolences and sympathies to all of us. We have really lost a woman who was a trailblazer for all of us young women in the territory, knowing how difficult it is as a woman in our society. I want to first start with Mr. Finch, Chairman Finch. Well, here I reverted back to being a board member. Mr. Finch, I wanted to ask a little bit about the annual cap, because I don't think most of us in the Virgin Islands understand that when the Medicaid cap has been exhausted, that at that point the Virgin Islands is solely responsible for paying for the Medicaid recipients' services. What is being done? I believe maybe in this case it's working with the delegate. Can you speak a little bit about the cap and what we're doing to get it removed? Because you did mention no state has a cap, and so that's important.
Correct. Thank you, Senator, for the question. And may I start by saying we missed you on the board? And
Thank you.
You certainly are correct that there's very little that's really understood about the Medicaid reimbursement system, and in itself is extraordinarily different than Medicare. The territories were all have always had a cap on the annual expenditures. For the states, if a state had a downturn economically, it had to put more people on Medicaid. It would not worry that there was ever a point where it would run out of the federal share. With the territories, that's been a worry. And years back, that cap was extraordinarily low. I remember when it was $6 million as compared to the $140 million it is now. But under the Medicaid system, once services are agreed upon that will be provided for Medicaid recipients, those services must be provided. The territory can't say, well, I'll provide them as long as we have federal dollars, and then we'll stop providing them until the next year. That's not allowed. If the service is a one part of the state plan that Medicaid recipients get, then it must be provided. So if you hit that cap, and it's been years since the Virgin Islands really has, since the beginning of the Affordable Care Act, when the cap was raised, the territory was not hitting on it, so it's only really going to first time in years be a problem for next year. But when the cap is raised, the Virgin Islands has to say, we still have to provide these services, agreed upon services, to Medicaid recipients, and if there are no federal dollars, it has to be done completely out of local. And the switch from numbers that I was provided, for example, in fiscal year 2021, the Virgin Islands was 40 million under the cap and is expecting in fiscal year 2024 to be 40 million over. So what are the reasons for this? Well, there's two reasons. One has been increased number of people placed on the Medicaid rolls, which is a good thing because it takes them off of the absolute no coverage. So that's a positive, but also with the larger, the sort of the, I guess the backside, if you will, with the larger percentage of the federal government picking up the larger percent, we use up the federal dollars faster. So when the federal government was paying 55 cents on the dollar, their money lasts longer than when they're paying 83. But since the pandemic, they've been paying the 83 plus a COVID enhancement, so they've been at 90% and higher for a couple of years, so we're eating up the federal dollars.
Right. But quickly, so is there an effort now on our part locally to get the cap lifted?
30 seconds.
And what's being done?
I know it's been elevated up to the concern of the governor. I believe it was also part of the delegate's bill, and I know Human Services through their consultants, and I'm sorry for forgetting the name of the company that works on Medicaid. Those are the folks that have first brought it up as a concern that has to be addressed. So the actual work of lifting it, I think, is coming more from the GVI than the hospitals.
Time.
Okay, thank you. One more question, please, Mr. Chairman. It's a quick
Yes,
question,
you may
if
proceed.
I may.
I just know the guy's name.
This is a question for Mr. Smalls. I have some more questions if we have another round, but it's just quickly, you referenced the independent expert panel in terms of the review for the new state-of-the-art Wang Lui Hospital. And because of the past and what has happened in terms of not having what we should have in the contract, the terms and conditions, who makes up the independent expert panel?
Good afternoon, Senator. The independent expert panel is actually a subdivision of the Army Corps of Engineers. It's part of the FEMA review process to arrive at the fixed cost offer. So it's really not on a contractual side or anything from a construction side. This is strictly on FEMA to arrive at the fixed cost offer.
Okay, thank you. I needed clarification on that. And thank you, Mr. Chairman. I appreciate it.
Thank you, Maurice James. One quick follow-up to that, Mr. Finch. With the Tax Equity and Fiscal Responsibility Act of 1982, you mentioned that you had some contact with the Health and Human Services on that. Can you give us an update? Because apparently it's all federal regulations. Can you give us an update on how that's coming?
Senator, what I had mentioned was that CEO Doug Cook, along with Governor Bryan and Chief of Staff Carl Knight, was able to have a conversation with the top officials from Health and Human Services, the Secretary and the Director of the Centers for Medicaid and Medicare Services. So
Okay.
I think if we could...
Mr. Cook, yes.
Yes, sir. We were able to have that meeting with them a few months ago, and they were, seemed very supportive, and they were going to take it under advisement to see what they could do within their control of HHS.
So if it's recalculated from the 1982 rates, do you have any idea of what additional fundings this would realize for the VI?
We do not know at this time. It really depends on how they go about that rebasing, if they bring it up to current standards or if they move it up to a different point in time would be effective of that.
Okay, thank you, Mr. Cook. Point of information, Senator Capehart, you're recognized.
Thank you, Mr. Chair. Through the chair, I asked earlier for the dollar amount for the uncompensated care. So if I can get that, we can get that information through the chair. Mr. Cook.
Absolutely. I have the number available to me now if we would like it now.
Please.
For fiscal year 2022, it is $28 million.
$28 million?
Of uncompensated care, correct.
Wow. And so the presumptive eligibility, someone asked me what is presumptive eligibility while I'm here. And through the chair's time, if you can explain.
Yes, proceed.
Being a former Medicaid administrator, I understand that presumptive eligibility came to assist with your uncompensated care. So I thought that dollar amount would have gone down, but it's pretty still high for the hospital. Thank you, Mr. Chair.
You're welcome. Wow, that's a big number, $28 million. Well, so quick question on that. Is the hospital, Mr. Cook, operating at a loss, breaking even, or at a profit? How are your monthly numbers? Do you have a monthly deficit? Approximately how much?
I'm going to defer that question over to our finance department. Chris Lewis, VP of Finance, will be able to give you more specific figures that they have in front of them.
You may proceed, Ms. Lewis.
Sorry, too. Good afternoon. I'm Chris Lewis, Vice President of Finance. Good morning. This is Chris Lewis, Vice President of Finance.
Yes, good morning. We can hear you. Proceed.
So for profit-wise, we were able to be in the black for 2022 because of the COVID funding that we received from the GVI and the federal government. That was able to keep us keeping things up to standard.
So profit, can you give me a number? How much was it for fiscal year 2022?
I would have to get back to you and look that exact number up. I wasn't prepared to answer that today. I apologize.
Okay. Senator Samuel Carrion, you're recognized for your 6 minutes.
Mr. Chair, good morning, but I will yield to my colleague, Senator Franklin Johnson.
Okay, Senator Johnson, proceed. You're recognized for your 6 minutes.
Good morning. Thank you very much, Mr. Chair. I want you to remember I'm the second senior senator sitting here. So you're the senior, the second. Thank you very much. I definitely want to start out by extending my condolences to all those who have lost loved one in the territory of late. But I definitely want to say special condolence to the family of Miss Enid Hansen Everson. She started her career and worked from the Peters Farm Hospital and was one of the last graduate at the Peters Farm Hospital. She also worked at Charles Howard Hospital and also at the St. Croix Hospital. She served for 30 years. She also was a board member for the Governor Juan Luis Hospital, and she passed in Juan Luis North on April 23rd, 2023. So this stalwart has touched the 4 hospitals on the island of St. Croix. She was the owner of Ebby's store downtown, which she ran with her husband and the family from 1969. So for the last 54 years, she has been a part of this community, either through the hospital or in her store business. So I said to my client, which I normally call her, rest in peace. A very generous woman that I met. And in fact, when I ran for my first seat, that was my first office, and then I had a second office, and she allowed me to utilize her store. People would come there, and ask for me or leave information there for me. When I reach here, she said, you have this note, you have that note. So I want to say thanks to the family and extend my deepest condolence to the Everson and Flood family. And I thank them dearly for their friendship and allowing me to be a family member. I dearly will miss what I call mommy badly. Today, I don't even know where to start my line of questioning because my colleague from Frederiksted touched something that's dear to both of us, which is security. We're from the line of security, and this month makes 15 years since we had a tragic incident in our hospital. 15 years. And that's something that's a tickler for me when it comes to security. And my colleague asked a point of information, and I respect Attorney Pat Welcome dearly in her position as counselor and legal counsel to the hospital. But I do have some concern about us not having someone in charge of security there. We must learn from our past in order to not repeat and allow things to happen again.
3 minutes.
And the tragic incident that happened last 15 years ago, we cannot let it repeat. And for those that don't know, someone did walk into a hospital and actually killed someone in the hospital bed, plain and simple. Execution in our hospital. And this month makes 15 years ago. I had some friends walk in there that was traumatized and probably still is. So to Mr. Cook, I will still extend that question. Do we have someone in charge of security to our hospital with law enforcement background to put the proper things in place for if we do have someone trying to invade our hospital again?
Thank you for the question. This is Doug Cook, CEO for JFL Hospital. We do have a supervisor in charge of our security department. We also have a position posted for a director of security for JFL Hospital. So currently there is a supervisor in place. We are actively recruiting a director for that position.
Please make sure we emphasize and put it out there that you're looking for that position. It needs to be filled. And as I said, I respect the attorney greatly in her position as an attorney, and we definitely need to have someone in that position in a timely manner. Again, to Mr. Cook, with our borders, are we in any kind of conversation with the Attorney General office to find out what can be done? Because some of the borders are people that collecting Social Security pension, family members holding on to that pension, was this government have to do this exorbitant cost. Are we doing anything with the Attorney General trying to find out how and what we can do?
1 minute.
Thank you for the question again. This is Doug Cook. We worked hand in hand with multiple different agencies, including the AG's office, depending on the situation of the border. As we stated in our testimony, we've been successfully at decreasing the number of borders we have. I think the number was 13 at one point last year, and we're down to 3. And I think as of maybe an hour ago, we are now down to 2. So each case is handled specifically, but for those instances where there are opportunities to put pressure on individuals or families from a funding perspective, we do make the appropriate, we work with the appropriate agencies to make that happen.
30 seconds.
Thank you. And how successful is the Meditech program? How successful is it? And how much of a financial increase have the hospital gained since the implementation of that program?
Just a point of clarification, did you say Meditech?
Yes.
Yes.
Okay, thank you. Our Meditech program, which is our upgrade of our IT system called Meditech Expanse, has not been implemented at this point. We are actually still in the building phase of our Meditech Expanse. Schneider Regional Medical Center, which I'm sure you'll hear later today, is probably a little bit further ahead of us. We actually took a pause on our build process to make sure that all of our teams were focused on JFL North and getting that place successfully open. And now we now regain our momentum on the JFL rebuild of our build of our Meditech Expanse.
Time.
All right, thank you. And Mr. Chair, may I wrap up with this question? One last question.
Yes, you may, Senator Johnson.
And again, I'll go back to Mr. Doug Cook. In your testimony, you say, while there are many nice features of JFL North, we should not forget that this is a temporary structure and there are plenty of drawbacks and challenges. Can you expand a little bit on that for me? What kind of challenges and what type of drawback do we have with JFL North?
Absolutely. Thanks for the question. JFL North is a beautiful facility, and for a temporary modular structure, I think everybody has been very impressed with it. However, as you become living in the building and accustomed to the building, one of the first things that is pointed out to our staff is the size of it. Right? So we have actually had to decrease the number of visitors that we allow for each patient, because from the safety of our patients, there is not enough room in the rooms to bring in 2, 3, 4, 5 family members. We've had to limit that to 1 because the rooms are built to a smaller size. That's just one good example of it. The next thing that I would point to is JFL North was built as a very functional clinical hospital, very patient directly focused. It does not have the space or the areas for all the support services, such as places for our case managers, places for our social workers. That all is work that is ongoing and will be built as part of the critical admin building, which will begin here shortly.
Thank you very much.
Thank you very much, Senator Johnson. Just to follow up, Mr. Cook, you had mentioned that you actually operated at a profit in last fiscal year, and we had asked some questions. Are you able to give us the number now on St. Croix?
Do we have that? I would defer that question to Chris.
Vice President of Finance. Last year, we profited $2.04 million. Was the final number, but that pretty much went out during the first month of October in the first fiscal year.
Okay, and so how about this fiscal year? What are you projecting, an operating deficit or a net profit again?
Right now, we are just finished up the cash flow, and it looks like at the end of September, we're on a pace for a negative $5 million. But we are in the process of working on some things to get that corrected.
Okay, thank you very much. Senator Samuel Carrion, you're recognized for your 6 minutes.
Thank you, Mr. Chair. Good it's afternoon now. Good afternoon to you, my colleagues, testifiers, staff, and viewing and listening audience this day. I also want to join you, Mr. Chair, in recognizing that May is the Mental Health Awareness Month, but it's also National Stroke Awareness, which is very important for us to continue doing our checkups and do everything necessary to stay healthy. I also join my colleagues in offering condolences to the many individuals in our community that unfortunately have been grieving the loss of family members, some of which are very known in our community, like Judge Pearson that we mentioned, Ms. Ebby, as she was affectionately known, and so many others that we have lost within our community. So my condolences go out and prayers to the family. Now we have a very important committee hearing today, hearing the status of our medical facilities, our hospitals. And I have a few questions to ask this morning. In regards to the implementation of Meditech that the CEO Cook mentioned, how is that process going, and is training available for the staff? Sometimes my concern is that sometimes we invest so much in these systems and softwares and we don't use them to the full potential. And we put so much money to it and we just use the basic options that are available when they have all these other features that additional that we paid for. So it's crucial that the staff is trained and the system is used to its full potential so that we could get the buck out of what we put in. CEO?
Thank you, Senator. A very good question. And to answer your question, training is crucial in any new implementation of a system that we do. And what typically happens in a lot of hospital systems, we don't put the emphasis on training that we need to, merely because people are busy taking care of patients. Now, that's not a good excuse for any reason. But going to your specific question of Meditech Expanse, we have not begun the training aspects of that. We are actually still in the building aspects of it. So imagine what we do is we bring in Meditech and their consultants, and they're sitting now with our doctors, nurses, our technologists, and saying, for the Department of Critical Care, how do you want your order sets built? How do you want them to look? And so we're taking what we currently have and we're building it into the new IT infrastructure system. So that's the work that's going on at this point.
So do you have a time frame plan as when the implementation phase will end, when the training will begin?
3 minutes.
When will this come on live?
Yes. To answer your question, and as I mentioned earlier, we took a brief pause for about a little over 30 days in our build cycle because our teams needed to focus on JFL North and successfully transitioning our patients over to that. Now, when we started this project, we believed this was going to be about a 12-month cycle. So we have several months into that process. So we still probably have a good 8 months left in this cycle before we're able to fully go live.
Okay. Now, I'm very, very concerned with the fact in your testimony, and I think the chairman of the board also alluded to the fact that the contractor, Panford contractor arrangement concludes on May 11th. You currently have about 25 RNs that are on staff through that contract. What will happen on May 12th? I know some of them are in the ICU division, will be left without some nurses on some shifts and some other areas. So this is critical. We're talking about a good number of people. So what's the plan? Today is May 3rd.
Yeah, absolutely. And I'll start to answer that question. I may defer to our Chief Nursing Officer, Doris Plaskett, for additional comments. But we've known that this date was coming for some time. And it doesn't mean that those people necessarily need to walk away at that point. It means that the payment, the structure with DOH goes away as of May 11th. We have, both hospitals have been working with Pafford we can sign our own contract directly with them to utilize them as a staffing agency. So that's one aspect of the work that's going on.
1 minute.
Pafford just responded to, or provided us numbers, I believe, yesterday or the day before, related to a new contract with them. We've also initiated contracts with 2 other staffing agencies that we are utilizing. And third and foremost, the ultimate goal is to hire our own nurses. And with the recent completion of our negotiations and increasing the wage that we're able to offer to our permanent nurses will hopefully continue to improve our ability to recruit and retain nurses locally.
Thank you
We have
very
less
much.
than a week. CEO Cook.
Was that a
So the
question,
time-
Senator Camillon?
The same time that I was just called, that same time will be called. So we need to ensure that our patients have the necessary staff and receive the care they need. So this is an urgent matter, and I hope to hear some positive outcome out of this. My time has been called, so I'll leave the remaining of my questions for the second round. Thank you very much, Mr. Chair.
Thank you, Senator Carrion. And there is indeed some good
Point
news.
of information?
Yes, point of information. Senator Bolkes. Who is that? Senator Frankie Johnson?
Point of information, Senator Johnson.
You proceed, Senator Johnson.
Thank you very much. On that same line of questioning of my colleague there, I'd like to ask the cook, what's the comparison of the salary that he has offered to the nurses in comparison with the mainland nurses' salary? What's the comparison to? I want to know it's attractive that it will allure other folks who want to come home and want to have gainful employment with us. So what's the comparison of the salaries based on what has been offered recently?
Yes, thank you for the question. This is Doug Cook, CEO of JFL. We are very competitive, and I want to thank the board. I want to thank the legislature, the VI government, and everybody involved in making this happen. We are actually able to offer a salary that we feel is probably right in the middle. You know, if we take 50 states, in every state, wages are differently based upon where you live. We are very much in the upper half of what our salary is that we're able to offer. Clearly, so I would say we're in that 50% to upper 3rd% of all the states in the country, in the U.S.
Yes, thank you very much,
Mr.
Senator
Chairman,
James, for
may I
your
just add-
point of inquiry. You must proceed, Mr. Finch.
I just wanted to add one additional piece of information on that, because I looked at this just yesterday. Was looking at the average RN salaries across several states, and so and thinking about where Virgin Islanders have gone to and where we can attract from, and so Florida and Georgia, we are right there with them, maybe even $1 higher, but we're extremely competitive with those states. New York, we would be below, and that's perhaps to be expected. Those are really just the 3 I looked at, but I wanted to add that.
Okay, thank you very much, Mr. Finch. And I know the nurses are very happy with the new negotiated contract, and so we want to encourage the final process to get done so that it can be signed off, and the nurses start working at the new salary. I understand it's about a 25% increase. Next, we'll have Senator Gittins and then Senator Potter. Senator Gittins, you're recognized for your 6 minutes.
Thank you, Mr. Chair, and good afternoon to all. Colleagues, while I would like to go straight to the Pafford contract, again, safety and security is a true concern. And I too want to say I hold a lot of respect for the good attorney. However, we need to take this division seriously. I'm fully aware of the questionable time and attendance of your enforcement officers, and I believe that this is duly due to the absence of having a qualified chief to run that division. And I'm also fully aware of the lack of equipment, personal safety equipment for these law enforcement officers to carry out their duties and responsibilities. CEO Cook and Attorney Welcome, are you all aware that these officers are fully vested peace officers? Yes or no?
I can start with answering that question, Senator Gittins. This is Doug Cook, CEO. I think it's more than just a yes or no answer. We have multiple levels of
Sir,
security
one second,
within
sir.
JFL,
One
sir.
second. 1 second, sir. Let's not start off on the wrong.
Proceed, Senator Gittins.
Are
Proceed.
you aware that they're fully vested peace officers? That is a yes or a no answer, and that's all I expect to hear. Please, don't run the time. Yes or no?
Yes, we acknowledge that some of them are, and some of them are not.
Thank you. Attorney, welcome.
Good morning, Patricia Welcome, Chief Legal Counsel. Some of them are post offices, not all of them are.
Yes, I am fully aware. I'm talking about those that have successfully graduated from the Law Enforcement Academy. Are you aware that they are full vested peace officer on a 24-hour basis? Yes or no?
I know that they're post offices. I would like for you to explain what vested means in your vocabulary.
Again, if they graduated from the police academy and have status certification. Are you aware that they are full vested peace officers? Yes or no? On a 24-hour basis?
Yes, they're post officers on a 24-hour basis.
Thank you. So I want to refer you all to Section 2 of Act 8027 that grants peace officer status to these enforcement officers of both hospitals. The Senate President is seated there. He was the chief sponsor of this measure, I believe, in the 32nd legislature. I really don't want to have the in-depth conversation here, but I'm really disturbed with what's going on within the security or law enforcement division at the hospitals.
3 minutes.
I will be having a separate conversation with both hospitals on this matter. The nurses at the hospital, we heard that 25 are from Pafford, 15 are other travelers. This is about 40 nurses we're talking about. How many local nurses do we have, or what percentage of our nursing pool does this represent? Somebody, talk to me, please.
Recognize the mic of Ms. Plaskett, please.
Doris Plaskett, Chief Nursing Officer. The total amount of registered nurses that we have working at the bedside is 73. Based on the number of established beds, our staffing plan requirement is 137. This leaves a need of 65 registered nurses and 15 travel nurses and the 30 PAFA nurses, which represent, as you mentioned, about 35 to 40 is the minimum amount that we need to provide the current level of services that we are now offering.
So Chairman Finch spoke to travel nurses that they're very expensive. But besides contract negotiations, what are we doing to retain any of the Pafford employees as regular employees of the Governor Juan Francisco Luis Hospital? Isn't it cheaper to outright hire them at a good salary rather than hiring them through a travel nurse contract agency?
Doris Plaskett, Chief Nursing Officer.
1 minute.
We have been in conversation with the current PAFA nurses. We have engaged in conversation, offering opportunities for them to join us on a permanent basis. The newly negotiated contract agreements with the increase in the more competitive salary place us at a better position to offer them permanent employment. So that discussion is ongoing. We do have a few that are interested in signing off, coming on as a permanent staff.
30 seconds.
Thank you. And in the 30 I think I heard 30 seconds.
Yes.
On page 5, Chairman Finch also spoke to funding challenges and quoted an article of the Cleveland Clinic CEO. But I want you all to tell me, how are you addressing the future of our fiscal climate here at Juan F. Luis Hospital? When can we see the return of some of our revenue-generating services that we once provided, such as pharmacy, the dining room service that was even open up to the public, and even outpatient surgeries?
Time.
Senator, thank you. This is Doug Cook, CEO. The three that you mentioned, and I'll take them in the order, of probably importance for us. We are, acute care hospital, so our focus on surgeries would be very relevant in doing outpatient surgeries. Now, clearly, we now have the capability of doing more surgical procedures with our new JFL North. Next in line is that you mentioned in importance to us would be pharmacy. We do provide inpatient pharmacy services. We do not provide outpatient pharmacy services, and there's a variety of reasons for that, which we can go into further detail later if you'd like. And then third and finally would be the cafeteria revenues that you spoke of. We do not plan to offer cafeteria services to the general public in a substantial portion, in a substantial point, because of the limited size and space of JFL North.
Thank you, Vice Chair Senator Gittins.
Mr. Chairman.
And definitely we want to, keep security as a high priority because we don't want to have that repeat
Chairman.
incident that we have. Yes, Senator Maurice James.
Thank you, sir. To follow up on my colleague's question just now about the service lines, what service lines are you contemplating reintroducing? Because I know there was a sentence in your testimony saying that you are going to reintroduce revenue-generating service lines. So I would like to know, what are you contemplating, since the ones that were mentioned are not going to be ones that you will be providing? Thank you.
Thank you, Senator James, for the question. This is Doug Cook. To answer your question specifically, when a hospital looks at what services it's providing, number one, we look at safety and we look at quality of care being provided to our patients. That is our mission. That is what we're about. We're not just focusing on revenue generating. So when we talk about moving our patients out of JFL North, out of JFL Main to JFL North, this is really the kickoff and the opportunity for us to expand our services or bring back services that we have had to go without for many years. So services that we need to bring back. Cardiac stress testing is a key one. Again, I mentioned earlier in my testimony that because the VICC was filled with boarders and medical surgical patients, we were not able to provide cardiac stress testing and other cardiac procedures to be able to provide to the community. So you take cardiac stress testing, you take that one step further, you move into fluoroscopy. There are many. Fluoroscopy is also something that we want to bring into the VICC and provides a great amount of quality and safety of care for our patients. From there, we move into our cardiac catheterization program. Many years ago, we lost a interventional cardiologist. We need to make sure that we have the equipment available to them so that we're able to attract and bring back a interventional cardiologist to provide that safe, high quality of service for our community, and that will keep people from having to leave the island for those services.
Thank you very much, Senator James. Next, we will go to Senator Potter and then Senator Donna Fred Gregory. Senator Potter, you're recognized for your 6 minutes.
Thank you very much, Mr. Chair. Good afternoon, colleagues. Good afternoon to our testifiers. Good afternoon to the people of the Virgin Islands. My first question, really, I know we had some discussion about the new nursing salaries, and I wanted to know, I don't know if you mentioned it, what is the new starting salary for an RN now with the new contract?
Doris Plaskett, Chief Nursing Officer. So for a registered nurse with 0 experience, the starting salary for both hospitals is at $75,000, and there are incremental increases based on years of experience, going to a maximum of 20 years plus, for a salary of $101,000. For advanced practice nurses, continue. For advanced practice nurses, I'm happy to hear that it took your breath away. For advanced practice nurses for the hospital with 0 to 3 experience, they're starting at $115,000 and going up incrementally to 20 years plus of $140,000. And then for the certified registered nurse anesthetist, for the hospitals, it starts at 0 at 185, going up to 20 year plus for a $235,000 a year. These salaries are for the hospital-based registered nurses and advanced practice nurses. The salaries are a little lower for the nurses in the Department of Health.
Thank you very much. I think those are competitive salaries, and you probably make. My son is a second-year nursing student, so he probably will be very excited with those numbers.
And I would like to add to that we also negotiated the salaries for licensed practical nurses. They do have a role as far as employment in the hospital, and the salaries for the hospital starts at for 0 years experience is at $50,000, going all the way up to $75,000 for 20 years plus.
Excellent. Thank you very much, Ms. Plaskett. Mr. Finch, as the chair, as the board chair, territorial board chair, are you satisfied that we're launching sufficient of a full court press with regards to getting congressional intervention regarding this whole Medicare, TEFRA initiative? I know you mentioned it. Seems like something very significant. In your view as board chair, are we launching enough of a full court press in this regard? In your opinion?
Chris Finch, board chair. Senator, I'm sure we could do more. It would not be a hospital alone initiative, I don't think, because it's a territorial issue. It cuts across numerous agencies. It has to do with our nursing home pays. It obviously has to do a lot with Human Services and the Department of Health work that they do. The delegate has a bill, but a lot of our delegates have had bills addressing this over the years. Like I said, the governor, along with Mr. Cook, had the extraordinary ability to present it directly to the Secretary of HHS and the head of CMS. I don't recall that ever happening before. So those are positive aspects. But in the current climate where there is a section of the federal political establishment that wants to cut Medicare and Medicaid, I'm just not sure what more we can specifically do.
Okay. Thank you for your response. Are we experiencing the same level of challenges with regards to turnover as other jurisdictions, other healthcare facilities on the mainland, particularly during and post-COVID here in the territory?
And that's to who?
To Mr. Cook.
Thank you for the question. Doug Cook, CEO for JFL. Healthcare turnover is a national crisis, and the pandemic has exacerbated that crisis. As I mentioned during my testimony, the average nursing age is 51 years old. That, on top of the amount of stress and anxiety our staff are put into on a daily basis, is forcing many people to leave the healthcare field across this country. We average a turnover rate of about in the high 20s. That is right on par with where a lot of hospitals across this country are seeing for a variety of different reasons. And again, I thank our board, and I thank everyone involved in taking the stance to offer a much higher wage for our nurses. Clearly, what we're offering a new nurse is much better than what we used to have, and is right on par with the rest of the country.
30 seconds.
Thank you very much. We're projected, according to DHS, in your testimony, Mr. Finch, to slightly exceed the federal Medicaid cap this year, with projections to exceed it by $40 million next year. And I was a little shaken by that drastic, from slightly this year to $40 million next year. I was curious as to what methodology you were using for this projection and what is the explanation for such a large jump.
Time.
Thank you, Chris Finch. The Department of Human Services uses a consulting company to help them with all matters Medicaid. And like I said earlier, I remember that I know the names of the individuals because I used to work with them, but I don't remember the name of their company. But they provided a chart, I guess, to Human Services, and I was given a copy of it that showed for fiscal year 23 the Medicaid cap to be $135,200,000, and the total expenditures that applied to the cap, because it gets into the weeds, but not every Medicaid expenditure goes against the cap. But nonetheless, the ones applied to the cap, they estimate for this fiscal year to be $139,403,501. So the deficit above the cap would be $4.2 million. I guess that's not really a small number. For next fiscal year, they expect a cap, because it raises by a healthcare inflation index, to go to $139,392,477. But they were estimating the expenditures applied to the cap to be $177,870,497. So the deficit would be $38,478,020. That's an estimate at this point, and as I said, I believe, the two factors, or maybe three factors in there, maybe more people being registered and signed up and covered under Medicaid, but before that they were just completely free care for the territory. The higher percentage of the Medicaid dollars being paid by the federal eats up the cap faster, and perhaps there's been additional services, although I'm not conversant on that, added that are covered under Medicaid, so there might be more work being done.
Okay. If I may, Mr. Chair, just one final question.
You may proceed, Senator Potter.
And I just wanted to get a handle on what the hospital redevelopment team was, the scope of their duties and responsibilities, who was currently on that team.
Good afternoon, Senator. The current makeup of the hospital redevelopment team comprises of engineers, procurement, finance, as well as we have a clinical administrative person to help us with all hospital-related activities. As we start to get into actual building of the hospitals, I could see us our teams are going to grow. We're going to have inspectors, project management, and more individuals that are really going to get into the weeds of the actual construction activities.
And as internal folks at the hospital who comprise?
Technically, the redevelopment team, I report to the territorial board. We do have employees in the St. Thomas, St. John district that report to me, as well as individuals in the St. Croix district that report to me. Our salaries are paid on the respective islands, but our funding eventually is going to be 100% federally funded through our management costs.
Okay. Thank you very much for your responses. Thank you for your flexibility, Mr. Chair.
Thank you, Senator Potter. Vice Chair Senator Gittins, you're recognized for your point of information.
Thank you, Mr. Chair. Mr. Chair and colleagues, I want to first thank my freshman colleague here in St. Croix, who I believe also served at one point or another on the hospital board, for her follow-up to my question regarding the revenue-generating services. On the second to last page of the CEO's testimony, I have to say the second to last page because these pages are not numbered. But the second paragraph speaks to JFL also recognizes the need to augment revenue to stabilize our systems. And they went on, and also said, we also recognize the need to restore some of the revenue-generating outpatient services for which we were once the sole provider of, and it goes on. I want to say that even in the follow-up question by my good colleague, we still did not get a response. So I'm asking, what are some of those revenue generating services that you believe will be or can be returned so that we could see some revenue coming in to the hospital?
Thank you, Senator Gittens. This is Doug Cook, CEO for JFL. I apologize if I didn't fully answer the question previously. When the revenue generating procedures that I mentioned a few minutes ago, cardiac stress testing, highly a great service for the community and provides a high quality of care, but also generates a tremendous amount of money for our organization. And one step further, I also mentioned previously cardiac catheterization. Again, you focus on quality, you focus on safety, and that keeps patients on island. Highly a great source of revenue for the organization. I can add additional things on top of that. When I mentioned in my testimony about bringing back services that we were once the sole provider of, it's a transition of healthcare with technology and the way business is done nowadays. Years ago, almost all, you take hip surgery, for example, and knee surgery. Every knee surgery was done in a hospital inpatient setting. It then morphed into, because of technology, which is wonderful, it moved to an outpatient hospital setting. And now those procedures are being done in surgery centers. There's nothing wrong with that. That's great. That's good competition, and patients should have the ability to have procedures done where they are. But what that does do for a hospital, if we're not actively involved and engaged in that process of those procedures, it takes more revenue out of the hospital, and that then makes it harder for us to fund the necessary services that we need to fund to be a safety net hospital for this island.
Thank you. Thank you. Thank you for that response. Hopefully at some point, Mr. Chair, he'll let us know the status on the Meditech, which is the hospital system that does the documentation for our patients. Thank you.
Thank you, Mr. Vice Chair, Senator Gittens. Next, we'll go to Senator Donna Fred Gregory. You're recognized for your 6 minutes.
Thank you, Mr. Chair, and good afternoon to my colleagues, and good afternoon, of course, to the testifiers and the listening and viewing audience. You know, there's so much to contemplate around healthcare in the Virgin Islands, and, you know, these folks that sit in front of us, you know, they put their feet on the ground every day to ensure that we have some level of reasonable, decent healthcare in the Virgin Islands. But we can't negate or forget the fact that we are challenged with staffing. Staffing remains a critical issue. As I listen to the conversation, I just ask my colleagues for us to not forget that we are challenged with staffing here in the Virgin Islands and attracting specialized physicians here in the Virgin Islands. So I took the opportunity to look at the medical staff metrics from JFL, and I note specifically that your proposed staffing should be some 65.5 individuals or professionals, if you will. And your current number that you have on board is 30.5, and you need 35, but I note that you also have additional physicians with privileges. So what does that mean? And that's 15. So what does that mean?
Absolutely, and thank you for the question. This is Doug, CEO of JFL. And that document was put together by our new Chief Medical Officer, Dr. Mavis Matthew, who couldn't be here with us today. But when we talk about privileges, so every physician that provides services at our hospital, it has to be granted privileges to provide those services. And when
okay,
that
hold
doesn't,
tight. Is this extra individuals, or they fall within the privileges? These individuals are part of the current staff and they have certain privileges, or is this an extra?
Those are extra,
those
additional.
Are extra. So if those are extras, then you have so then your need is give or take about 20 additional
give or take, depending on the specialty that they are in.
Okay, so now I understand. So let me ask, and I'm not sure if this question is for Finch or Mr. Cook. I made a note here. So let me just ask, what conversations, if any, are we or you guys having to strategically secure specialists in the healthcare profession, of course? And are there any considerations to establish relationships, or if you have relationships with healthcare facilities or organizations outside of the Virgin Islands to fill the gap where we are unable to provide these specialty areas here in the territory? Because we have to face it. We're in a small territory, and there are a number of challenges that we have with specialized physicians.
3 minutes.
So what are we doing, if anything?
Doug Cook, CEO of JFL. Thank you for the question, Senator. I'll start to answer that question. In order for us to be able to attract good, talented physicians to this community, number one, we need to be able to pay them. So there is extensive work going on right now to look at our AHAB physician contract because it needs to be upgraded. We need to improve the amount of money that we pay those physicians that are employed through the hospital. Second to that, we need to come up with different models of care. So the way healthcare has evolved over the years, physician employment models have really changed. The days of physicians having their own individual practice has really gone away. Actually, the number nowadays, 80% of physicians in the country are employed by a health system or a hospital system. That's very different than what we have here. And that's something that we need to look further at and explore. The third and final would be, how do we partner with health systems in the country that can provide specialty services? So it is something that we don't have, I would say, a strategic plan around. We are having those conversations because we know that we cannot support to have every specialty in this territory full-time. We need to bring in those specialists to provide those services on a scheduled basis and hopefully then continue to keep care here locally.
French?
Thank you. To what Mr. CEO Cook said, I would just add that there has been some effort and some grants have been received by the hospitals to improve their ability to do basically the internet-based medical services, and so that in the future some of the specialists you need, the connections may not be a physical presence.
1 minute.
But done virtually, and the whole country is going in that direction. So we want to make sure we do that as well. And just to add that. The next time the territorial board meets is actually a week from today, and one of our agenda items is to start talking about the physician hiring models as a part of the exact same issue that you were bringing up.
And thank you for your responses, because I believe that we continue to have the conversations around healthcare in the territory, but it is mission critical that we establish what is it going to look like in the future for the Virgin Islands. As you traverse the landscape and you do this work every day, you have to be working towards the improvement, the true improvement. I know there's a lot of conversations about the physical structures, but for me, what matters most is the actual daily work and what's available to us as Virgin Islanders. Because I was just saying to my colleague that's at the right of me that we are now our parents.
Time.
So that's a quick minute. We are now our parents, so we have to make sure that we are now able to get the proper health care that we see that our parents were not able to get. So we have to really fight and push for that. I wasn't able to ask but one question, but I think it's a critical question around where health care is going in the Virgin Islands. I know that we're probably not going to have another round, but I think that is a very, very important component to where we're going, all the other conversations around shortages, etc. But where we're going with healthcare in the Virgin Islands is what we really need to primarily focus on. As we out our fires, we also need to be focusing on, so how do we get to where we need to go as it relates to good, decent healthcare in the U.S. Virgin Islands. Thank you for the time, Mr. Chair.
Thank you very much, Madam Chair. Next, we'll go to Senator Angel Bolkes, and then we'll finish up with Senate President Nobel Francis. You recognize Senator Bolkes for your 6 minutes.
Thank you, Mr. Chair, and good afternoon, colleagues. Good afternoon to the listening and viewing audience. Good afternoon to Central staff. Good afternoon to our testifiers. Offsetting the balance between life and death is a never-ending battle where no one side can concede. And I say to my testifying panel today, the administration, the entire staff, your responsibility in the grand scheme of maintaining the equilibrium as a premier healthcare service provider is critical to the well-being and survival of our people. And I truly appreciate all of your efforts and sacrifice in this endeavor. Now, I also want to offer quick condolences for everyone who has passed, especially for Mr. Alric Thomas, who was gunned down at the end of our carnival season. Now, let's talk about proactive approaches and strategic planning. As we know, the hurricane season will be coming up soon. And with that impending hurricane season, what is the status of your contingency planning and preventative maintenance, if that, for those North modulars in JFL?
All right. Good afternoon, Senator. What we have been doing with the implementation of JFL North is trying to secure all of our service agreements. We're looking at all of our long lead items. You heard us talk about our off-site facility and being able to stockpile and have maintenance parts or spare parts here within the territory to, one, cut down on the downtime for services that we provide. Facility maintenance is a significant aspect, I think, across the territory. And as we go into every hurricane season, we always try to make sure that we have adequate supplies here in the territory. Typically, we try to have at least 2 weeks worth of supplies.
And let me cut in there, Mr. Smalls, please. What is the status of those maintenance contracts for those emergency mitigation scenarios?
Well, we presented, we meaning the Territorial Hospital Redevelopment Team, presented a few to the board most recently. And just this past week, we presented to the leadership. So we're trying to secure all of those contracts within the next 30 days or less.
And concerning the structural integrity of the modulars, what are their ratings?
The modular is rated at 175 miles an hour.
Okay, very well. Is there a designated shelter space on site in the North Modular area for patients in the event of such a disaster?
Well, that's actually a good question. The CEO and the team, we've been talking about this recently. The fact that we just recently moved out of the VICC as well as JFL North, we're looking at that because those structures will still be in place. What if we had to utilize those facilities in the interim until we could plan going forward?
And may I ask, those modulars, can you expand upon them? Is that something relatively easy to do if you needed to add on an area or subsidize it in that fashion?
I would say a modular is easily expandable. However, because of where it's located on the property, we're limited in what expansion that we can do.
And concerning power redundancies in those scenarios, of course, what's the status of generation of power and water?
We have, with JFL North, we have a 260,000 gallon water storage tank. As it relates to generation, we have a number of generators on the site. As a matter of fact, I was just working with my architects in trying to see how we could integrate these generators to provide even further redundancy within the campus. Currently, we have more than 6 generators feeding different components, so we're trying to see how we could integrate them.
Okay, very well. And from a territorial scope, with respect to the building projects that are before you, and rebuilding the facilities, are you confident that your team and yourself can handle those projects simultaneously?
Absolutely. We're a young team, but we recognize our challenges, as I answered before, that we are looking at additional assistance, consulting firms that will be able to help us manage these projects. And that is the purpose of the management costs, to do just that, to be able to manage the projects.
And while we appreciate all of the doctors and nurses that do their job on a day-to-day basis, we also have to incur the importance of having a facility that is in good structural integrity and maintained properly in order for these men and women to provide these very critical services for our people here in the Virgin Islands. So
I'm happy to hear some of the answers that you've given me today
1 minute.
concerning structural integrity and planning on the strategic side of things. If I had it my way, I wish things would move a little bit faster. But, you know, we all have to work around that red tape that exists, and I understand the process. And again, I appreciate each and every one of you and look forward to more advancements in JFL and across our healthcare system in the Virgin Islands. Mr. Chair, thank you so much for your leniency. I appreciate it.
Thank you, Senator Bolkis. Real quickly, Ms. Plaskett, I wanted to follow up on a question from one of my colleagues, because I'm getting calls from the nurses. When is the effective date? Because I understand that the new negotiated salaries has not started, but is it effective what date?
Doris Plaskett, Chief Nursing Officer. So the newly negotiated salaries are fully executed and signed by the governor. We are in the process of processing those NOPAs so that the nurses can receive the compensation based on the negotiated rates.
Excellent. Thank you very much.
And Mr. Chair, if I may add, this signing was last week.
Great. Excellent. We're moving ahead. Thank you, Lottie. Next, we'll proceed to our Senate President, the Honorable Novell Francis. Senator, you're recognized for your 6 minutes.
Thank you very much, Mr. Chair, and good afternoon to everyone. And let me say that these nurses have been waiting a long time for their money. So we should take night and make day to make sure that they're compensated and at least stop the bleeding and try to keep some of these folks here at home. So this afternoon, I heard a lot about the safety and security over at the Governor Juan Francisco Luis Hospital, and I wouldn't beat that to death. Just to simply say that these individuals are not there just to provide security for the CEO or the legal counsel. They're there for the nurses, the doctors, the patient, and the community. We work hard after that 15-year incident that you heard about, where we created law enforcement, not just at JFL, but at the University of the Virgin Islands, here at the legislature, and elsewhere. Because we want to give individuals a fighting chance to be able to be self-sufficient until such time as the Virgin Islands Police Department could respond. If you all don't want them, I'll hire them. We'll place them at the UVI. We'll place them at the Virgin Islands Police Department. But please, consider the safety of your nurses, your doctors, the allied workers, custodial workers, and everybody else that occupy those facilities. Mr. Chairman, I ask you to please pay some attention to what's happening there. If there's a financial delta, it'll be our responsibility here as legislators to make sure that we're providing that support. But not having law enforcement and safety and security there will be detrimental to the facility and everything else that you've been working hard to implement. So please pay some attention to that.
Understood, Senator.
Thank you. Mr. CEO, in respect to the, and I know that autopsies have been a bone of contention, and now that we have the JFL North, is there any relief that has been brought to that situation? I know that Justice is also working and standing up their own morgue. Is there any concerns right now being raised in respect to autopsies?
No concerns being raised at this point. JFL North does have a fully functioning morgue within it. It is smaller than our current JFL main morgue, but we believe that we'll be able to handle those bodies. It does have a full autopsy suite as well within JFL North, so no concerns bringing forward at this time, sir.
Very well. In respect to the borders, I'm happy to hear that we're down to 2. That is long in coming. I know that we have heard for years about the situation with our borders, and I'm
3
happy
minutes.
to hear that we're down to 2 on that. There were some concerns about the air conditioning working at the JFL. Have we been able to resolve that issue?
Again, good afternoon, Senator. Probably just about 15 minutes ago, I received a text from the vendor. The one unit that was offline is back online.
Great. Very well. And also, I saw that there was some recent graduation of some coders Mr. CEO? How will those be incorporated? How will that help you to be able to make some inroads in your collections?
Yeah, M1 Enterprises, who started up I think the recent graduation was billing, and they're just starting the coding program right now out at RT Park. They've been a great partner for us. We've had multiple conversations about how we can collaborate. I attended the graduation, and we offered opportunity for those people to apply for positions. But again, another great opportunity for collaboration with a local company here on site. So absolutely.
And also, Mr. CEO, in regards to air transportation or airlifts, I was getting some feedback that there's some difficulties in being able to make that transition between, I guess, the approval for the referrals and anything else, and getting those patients out. Have we been able to make some improvement in that area, as well as have we reduced the number of airlifts that's been required most recently?
Air transportation off island, thank you, Senator, for the question. Air transportation off island is a really a complicated issue that deserves a great amount of discussion related to it. By and large, JFL Hospital or hospital operations is outside of the control of how that process is handled. This is largely due to the patient, if they have flight insurance, and where the receiving hospital is located with the specialty and where they're able to fly to. The hospital, and I can't say enough for our case management team that does extensive work, working with all of those entities to facilitate and make that process as fast and as easy as possible. But I think that there are air transport vendors for the territory that have stopped taking Medicare. And that is putting additional strain and financial strain on the limited number of air transport vendors that remain here. So I think it deserves a large conversation.
Mr. Chairman, I hope you made some note of that, because I think we need to also bring in those air ambulances services as part of that discussion. While my time ran down real quickly, I wanted to say that one of the issues of attracting doctors has to do with timely licensure processing as well.
30 seconds.
We recently moved some additional legislation to allow for the medical de facto board to be able to assist in making sure that we're having all our boards properly aligned, so that we could be able to start to attract, some of the physician there. But I wanted to get an explanation in my final minutes in regards to the $28 million uncompensated care that you referred to. I know that you're capturing that as uncompensated care and the amount.
Time.
But I would imagine that, and I'll conclude here, Mr. Chair, in terms of presumptive eligibility and also the TEFRA rebasing, the Medicaid, Medicare reimbursement, how are we narrowing that $28 million? Because I don't want to leave the impression that we just out there short of $28 million. Can you just speak to how we're actually narrowing that number in regards to some of the other benefits that we're receiving?
Yes, sir, and thank you for the question. Uncompensated care is obviously a major impetus for our organization as well as Schneider Regional Medical Center. And utilizing the programs that we have available are to our benefit. When I mentioned the fiscal year 2022 was at $28 million, we are estimating fiscal year 23 right at $17 million. So clearly the programs that we have in place are working. We just need to make sure that we continue to utilize them and that every patient coming into our facilities goes through the presumptive eligibility process. That doesn't mean every one of them are going to qualify for the longer term aspects, but for that initial visit, hopefully that they will. Yep.
Point of inquiry, Senator Bulkey. You recognize Senator Bulkey.
Thank you, Mr. Chair. Mr. Chair, the President inquired earlier about air travel, and I wanted to shift that from a local standpoint. We have a number of helipads that are either not being utilized at all and are in good, they're operational basically, but we're not using them. There have been a number of passings on the island of St. John, and if in fact we had a helipad, I believe that potentially we could have saved some of those lives. My understanding from the constituents who reach out to me is that they're saying there was an issue with the boat not working and contacting another provider to get a boat to get the individual over. Can you please tell us what the status is on those helipads and how soon can we see some sort of activity?
Again, Senator, I could speak to that. Specifically here in the St. Thomas St. John district, we do have a helipad up at Myra Keating Smith. We have a helipad at the Royal Schneider Hospital. However, we do not have an air provider in the territory. That is the challenge. It's not just a regular ambulance. You're talking about just as how we have a flight crew that comes in to take you off island. There are no flight crews here for helicopter service in the territory.
Thank you, Mr. Chair. I'll ask another question during my time for the next block.
Thank you, Senator Bulkis. Senator Donifred, you're recognized for your point of inquiry.
Thank you, Mr. Chair. I just want to follow up on the question around the uncompensated care and this 28 million, and the fact that you do the presumptive eligibility, and of course, not all individuals who fill out the application for presumptive eligibility qualify. So we have a lot of self-pay individuals here in the Virgin Islands. So tell me, do you have documentation as to the individuals who are the difference between the self-pay and those that actually qualify for Medicaid? Do you have information on that?
Senator, great question. Yeah, absolutely, we have that information. I don't have it available here in front of me right now. I know our finance team has it, and it's something that we track separately on a monthly basis.
Thank you. So, through the chair, if you can send that to the chair, that would be great. And I asked the question because we know that in the Virgin Islands that we are challenged with individuals who have businesses, et cetera, with private healthcare insurance. I know there's lots of conversation around establishing private healthcare insurance, but absent of us being able to have a private healthcare insurance system in the territory, then you're going to continue to see numbers like 28 million. So that's something that collectively, not only from the Department of Health, but also from a legislative perspective, that we really need to begin to truly look at how do we really work with our self-pay citizenry here in the territory to address the challenges that we have with the hospitals in both districts. So I wanted to make sure that I put that on the record. Thank you, Mr. Chair.
Yes, point of inquiry. Senator Caput, you're recognized for your point of inquiry.
So I have a question, and this is regarding the federal funding that is coming to an end for PAFFORD. So what are your plans, CEO Cook, plans to replace the PAFFORD nurses as they are pulling out of the territory?
Thank you, Senator, for that question. And this is probably one of the most immediate emergency needs that we have to solve very quickly. So again, going back to a couple things. Number one, putting a salary in place that we're able to offer permanent employees so that we're able to move PAFFORD nurses that choose to want to take a permanent assignment. They're offered a very good wage. That's number one. Number two is working with other agencies. I mentioned Aya and Anders. I believe that Schneider Regional works with a couple of other agencies to be able to augment that with other agencies if necessary. Number three, we are in active discussions with PAFFORD about signing our own contract with them to provide, have those nurses stay on with us. And number four, Doris and I are meeting early next week on a staffing matrix, plan for once we cross this threshold. Because even if we're able to continue to bring in other agency nurses, the financial drain it's going to have on the organization is high. So we need to continue to very aggressively recruit and retain high-quality nurses here within our hospitals.
Are you working with the University of the Virgin Islands to recruit nurses from their program?
Yes, absolutely. So in my testimony, I mentioned that last year we reinitiated what we call the graduate nurse program. And we hired, I believe, out of the last year's class of 14, we hired 10 of their students. There are now, this year, there are 10 graduates coming out of the nursing program next month. We have a dedicated kind of welcoming thing for them at JFL on May 9th, where we are attracting them and hoping that they will sign on to our graduate nurse program to become fully employees of JFL Hospital.
Well, I'm glad to hear that. And if I may, Mr. Chair, as to follow up, drill down and the $28 million, you mentioned that for 2023 that the uncompensated care is going to be $17 million. But can you tell me what was the components of that $28 million? Because that's pretty high.
Yeah, Senator, thank you for the question. Unfortunately, I don't have the breakdown here in front of me. I was just basically texted that number, that's what our number was. We can, through the chair, if you'd like, we can provide a breakdown of what that $28 million includes.
Okay, thank you. If I may, just also for the airlift.
Yes, proceed.
The airlift. When individuals are airlifted, it's based on the payment it goes directly to the patient, or does the hospital incur that cost?
From my understanding, the hospital does not incur that cost.
Okay. So if they don't have insurance, presumptive eligibility pays for that?
I'm not sure. I know that the MAP program has a big part of that. I don't want to misspeak and say that it's part of presumptive eligibility.
Okay, thank you. That's a follow-up question that we'll have. Thank you.
Yes, thanks, Senator Caput. Colleagues, we're a little bit pressed for time, so what we'll allow now is if any colleague have any particular burning question, we'll let one question be answered now. So if any colleague has a burning question, we'll permit that at this time. Okay, Mr. Cook, okay, we've discussed, we've opened the new Wang Louis modular. You have the new CT scan, you have the 128 slice capacity. Basically we have state-of-the-art equipment right now in the territory. So I'm going to allow you to convince the residents of the Virgin Islands, those that are, considering going off island for medical treatment. Go ahead and tell us why we should now have our medical care be done locally instead of going off island.
Thank you, Chair, for that opportunity. JFL for a number of years has been plagued because of the hurricane in what the hospital was able to provide. Although we had tremendously talented doctors and nurses available to providing that care, it was clouded by the devastation of the condition of our facility. Now that we are in JFL North, we have a facility, we have the conditions available, and in some areas the technology to be able to provide those services more efficiently and at a higher quality of care. And so we would always advocate that care is provided locally. Clearly, there are still services that JFL is unable to provide here locally, and that conversation about where people receive their care is a conversation that needs to start between the patient and their primary care physician, so that we can ensure that they're getting the best care possible. But for those services that are able to be provided at JFL or on St. Croix, we would highly encourage all residents to seek those out, to talk with your physician and see if they're recommending a type of procedure for you, to see if it can be performed right here at home. Thank you, sir.
Thank you very much, Mr. Cook. So there it is, residents. You've heard it from Mr. Cook on why, in addition, it helps the economy because, the healthcare industry in the Virgin Islands is a big industry. And, like I said, when we opened the Roy Lester Snyder Hospital, we were doing the kidney transplant, the liver, all of these things here. And we're now at that point again where we're opening new hospitals with new diagnostic equipment. Senator Gittins, you're recognized for your question.
Thank you, Mr. Chair. I wanted to ask the CEO, CNO, about the Meditech program. Where are we with Meditech?
Thank you, Senator Gittins. This is Doug Cook, CEO of JFL. That question was asked earlier, and maybe I didn't state it correctly. We at JFL put a pause on our building of the components of it so that our teams could focus on JFL North. So we had, to answer your question, we started the process. We were about 3 months in. We had to put a pause on it. That activity now kicks off again next month where we continue the rebuild, or I'm sorry, the building of all components of it. And we would implement, I think we still have about 8 months in our window before we can actually go live.
What's your target date on this?
I don't have that information in front of me. I would refer to our Chief Information Officer, Greg Bryant, who is in your chambers.
Yeah, I'm looking at Q1 of 2024 to go live.
Say that again?
Q1 of 2024. So first quarter of 24 to be fully implemented.
So break that down for the layman. What's the date we're looking at?
February. I don't have an exact date yet because we got to meet with Meditech on Monday to get the exact date because it's based on what Meditech gives us as a go live date.
So we just went from hearing from the CEO next month, which is June.
Yeah, to start. Yeah,
to now hearing February.
Yes, to start the project in June to be live and fully ready in February. Yes.
Okay,
that's correct.
All right, and lastly, Mr. Chair, if you may.
Yes, you may proceed, Mr. Vice Chair.
I think you noted on page 5 that borders at the hospital have decreased over the past few months from 10 to 3. Where did these persons go? Bro, how were we able to address this?
Senator Gittins, this is Doug Cook, CEO for JFL. We reduced it by a variety of ways and working with the different agencies. Several of them, I believe the number was 4 of them, were transferred to Puerto Rico to a long-term care facility there. Others were found other on-island resources that were able to obtain those patients. Some of them simply went back to their home and were able to be supported with at-home services versus other online areas that were able to take care of our patients.
Okay, thank you. I'm really sorry that you guys got to go for us to bring in the other one. I wish next time we probably need to do each hospital one day and then the other. But thank you all for your responses. I know I was a bit firm today. That doesn't mean that I'm not satisfied with the work that you're putting in, your team is putting in. I just know that we can do more. And I want to see us doing all that we can do from the full spectrum. Because we've seen the number of incidents. We've had, my colleague spoke about that incident 15 years ago. I was a cop back then and had to be called out in the middle of the night when that execution style took place. The incident took place at the hospital. So I want you all to take the hospital security seriously. The Senate President can speak for himself, but when he introduced this legislation, he did have a conversation with me, and the concern was there. The concern is still here, and that's why it's in place. So I want you all to take a look at Section 2 of Act 8027, I think it is, which granted the peace officer status to these enforcement officers. And hopefully in your closing, Mr. Cook, you could also tell us what it'll take to bring the wait time at the emergency room down to the 25 minutes that you spoke about. Thank you.
Thank you, Vice Chair Gittins. Senator Caput, you're recognized for your burning question.
Thank you, Mr. Chair. I wanted to do a follow-up on the presumptive eligibility that the hospitals have. Do you still have outstation eligibility workers at the hospital? So I understand with these outstation eligibility workers, they are to capture the individuals who are eligible based on the basic questions that you have to determine if you're eligible for presumptive eligibility. Do you still have outstation eligibility workers? Because what happened, and probably this is a contributing factor of why your uncompensated care is so high, where the outstation workers are to get that information to determine eligibility on the spot. Do you still have those at the hospital?
Yes, thank you, Senator, for your question. Yes, we still have one person in that role on site at JFL. In addition to that, all of our front desk staff that see these patients, a lot of our patients come in the middle of the night through our emergency room. They are all trained in the initial intake process of presumptive eligibility to help them complete the form and answer the questions that are necessary.
Well, CEO Cook, I would really like to see the components of that $28 million, and then you had a drop in 17 for 2023, because this is something that is serious for our territory, that uncompensated care is very high. So look forward to further conversation.
Sure. Thank you for the question.
Thank you.
Thank you, Senator Caput. Senator Maurice James, you're recognized for your final question.
Thank you, Mr. Chairman. On the issue of revenues, and I want to just go to collections and ask Mr. Cook, are the payment options still where you can pay in person and by mail? Are those the only ways that you can pay your hospital bill?
So yes, you can still come on site to JFL Main in our business office to pay your bill there. I'm going to actually defer to our Chief Information Officer, Greg Bryant, because we are actively in the process of setting up an online payment option through our website. So if Greg is in your chamber, Greg, could you please answer if that program is live?
Yeah, that's exactly where I was going, because we need to improve patient collections. If we're talking about the hospital generating revenue, you can generate revenue with the services, but then you have to collect the payments. So please address that. Thank you.
Yes, Greg Bryant, CIO of JFL. So I've actually been working with Meditech on this issue, and we have the online portal 85% there. The one issue we're having is because we're in the Virgin Islands, a lot of the payment companies do not do business here. The automatic payment companies that will take the payment, that's the one issue we're having. The site itself is built, but we need to get the payment. We need to find somebody that we can do business with to be able to take payment processing and take your credit card or your whatever, your online check. But once it's up, it is a fully robust site to where you can pay an individual account or your total bill. So we're just looking to try and find someone that can do it in the Virgin Islands. Puerto Rico has the same problem. as well. So there's 1,000 companies that do it, but there's very little that does it in this part of the world. So that's where we're at right now. But other than that, we've got the site built.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator James. One final question, Mr. Cook. You mentioned that 4 boarders were sent off island for long-term care. Who is paying for those services, for those boarders?
Yes, sir. Thank you for the question. The 4 boarders that were most recently sent off island are covered by the Department of Human Services, is where that payment is coming from. Previously, several years ago, there were several boarders that were moved to Puerto Rico, and there are still 3 of those boarders remaining in Puerto Rico, and those 3 are paid for out of JFL's funding.
Okay, great. Thank you. I thank you for presenting to the legislature today. I think we're very excited. The Virgin Islands is in a time where we're building new hospitals, one on St. Croix, one on St. Thomas, a clinic on St. John. It's very rare that we get the opportunity to be in this kind of mode, recovery mode. So I want to congratulate all of you, and at this time I'll allow point of information. Oh, yes. Senator Donna Fred Gregory, you're recognized.
Thank you, Mr. Chair. I want to go back to this $28 million. And I guess my question is, how are we reminding folks that they owe us? Because I know that we all know that the squeaky wheel gets the oil, right? So if we send out a bill, and I'm asking this question for a reason, because I know in this district, I know of a situation where you get a bill last year and then you see another bill again. So people forget. So how are we, what system, if it's not in place, what system? I know we talk about the Meditech, et cetera, but I believe what matters at this point in the world of technology where we have the smartphones, we should have some system in place saying, hey, don't forget you owe me $1,500 every month. You got to keep reminding folks. So what is it that we have in place? Because I believe if we put a system in place where there is a constant reminder, folks will become a little frustrated and start to pay up these bills, because in a lot of instances, our uncompensated care is not only tied to those that really can't afford it, particularly since now we have the Medicaid component. It has a lot to do with self-pay folks. So what are we doing? Or what do we intend to do, or what are we doing?
Senator, thank you for a very, very astute, very good question. Again, Doug Cook from JFL. We are in a, and I think you might, hopefully you'll volunteer for our revenue cycle ad hoc committee that we start, because I love the idea of sending text messages. We are very much, unfortunately, in a very manual process with regards to how we do all of our billing. So we everything is done manually. Everything is mailed out monthly on a monthly basis. We do need to evolve. The move to Meditech Expanse allows for some of that to happen. It provides us a pathway to get to that point, but clearly we need to then integrate that with a third-party vendor that allows for that integration to happen. And we would look forward to further looking into that for the efficiency of billing for not only JFL, but Roy Lesser Schneider as well.
Absolutely.
Yeah.
Thank you for your response. I think if we move in that direction, you'll see significant improvement with the issues that we have with uncompensated care. Folks just need to be reminded. Thank you, Mr. Chair, for the time.
Yes, you're welcome, Senator Fred. Lastly, we'll have Senate President Novell Francis. Senator Francis, you're recognized for your final question.
Thank you. Thank you very much, Mr. Chair. I just wanted to wrap up and ask both Mr. Smalls and CEO Cook, now that we have relocated into the JFL North, what is keeping you up at night? What is it that you're challenged by, and what is it that you find difficulties in being able to move on to the next step. Would you like to share that with us at this time?
Good afternoon, Senator. What keeps me up at night? I think coming from a facilities background, the unique challenge that we have being an entity here in the middle of the ocean, not being able to have service within 24 hours, the fact that it's a hospital and a healthcare facility, by all means necessary, we have to get systems back up and running as quickly as possible. Even as recent as this past weekend, we had a situation there in St. Croix where we were told that we had to wait for a vendor to come from Puerto Rico. Fortunately, I was able to reach out to an on-island vendor in St. Croix, begged, pleaded. That vendor came out and was able to address the concern. So I would think right now between the maintenance and the upkeep, and of course the one question we keep talking about, finances, the necessary monies that we need for maintenance and upkeep of our facilities in this interim until we get to the new facilities.
And thank you, Senator. This is Doug Cook, CEO for JFL. There's a lot of things that keep me up at night. Last night I was preparing for today. But as we talk about JFL North, it is amazing that when we walk through that building, it's fairly calm. It's pretty quiet. The great physicians and the staff and nurses and techs that we have there are taking great care of our patients. I walk around frantic, because the things that I'm looking at is we're unfortunately having to provide care still in a building that is not what we want it to be. That's going to come with the next replacement hospital. So when we have to think about how we unfortunately transport patients and our staff from the south parking lot up to JFL North. It's these logistical things that get in the way of providing the excellent care that we want and efficient care that we want to on a daily basis. Not having a robust cafeteria that we can bring in and use as a sense of community and support for family members is concerning to me. Not having a adequately sized patient room to be able to provide visitation the way we want it to. Healthcare is a very personal issue for all of us, and we need the support of not only our doctor and our nurses, but of our loved ones and our community and our pastor to come and visit us. So those are some of the things that really are weighing on us of how we make it work, for the foreseeable future until we're able to get into a replacement facility.
Senator Bolkis, you're recognized for your final question.
Thank you, Mr. Chair. My burning question is, what are the short-term and intermediate needs concerning the demolition and rebuilding of JFL? And have you identified any potential long-range obstacles or drawbacks that you may face during that process?
Thank you for that question, Senator. I do believe our interaction with our architect of record, we have a lot of lessons learned. Some of our members of our team being in construction here in the territory. We've been looking at how we're going to ensure that we streamline this entire construction process. I don't see that we have any drawbacks at this point in time. I think the only thing that's holding my team and I back right now is that fixed cost offer. Soon as we receive that fixed cost offer, it's off to the races. And there's been a lot of apprehension based on what we experience with JFL North and what we typically see here in the territory. But you're going to see some innovative construction methodologies that we're going to implement here in the territory to ensure that, one, we standardize all of our facilities across the territory. But more importantly, how do we bring these facilities online as quickly as possible?
Thank you, Senator Bolkis. Okay, so at this time, what I'll do is I'll give you each 1 minute to summarize your testimony. We'll start with you, Mr. Christopher Finch.
Thank you, Senator, and thank you for the discussion today. A lot of good information got out, and a lot of great questions were asked. I will just use my time, and since I'll leave before the next session, ends to include both hospital systems on 3 islands. I just wanted to really, from the perspective of the board of directors, thank all of the men and women in all of the positions in Juan F. Louis, in Virgin Islands Cardiac Care Center, in Roy Lester Schneider, Charlotte Kimmelman Cancer Center, Myra Keating Smith Community Health Clinic, for all of their work, their dedication, their passion. At the end of the day, it's really the people that are sitting up here testifying are important to make sure the trains run on time. But as a patient, you come in, it's the day-to-day employees that you see and that are doing the work and are providing the health care. And so we just want to say God bless and thank them.
Thank you, Mr. Finch. Mr. Smalls.
In closing, I just want to say thank you to this body. Thank you to the government as a whole, the employees of the Juan F. Louis Hospital. It's been a challenge. It's been a long road, but the best is yet to come. And as our slogan says, together we'll be stronger. We know that we're going to be successful, and we're going to provide state-of-the-art, resilient facilities for the people of the Virgin Islands.
Thank you. Thank you. Mr. Cook, you're recognized.
Thank you, Senator, and thank you for all committee members. We sometimes think about coming here, and we're nervous about the questions that we're asked. But it's really very beneficial for all of us to have an open dialogue about the state of healthcare for our territory, and we respect it, and we invite more of it into the future. I want to thank so many people. I won't take the time to do it because I will eventually miss people. 11 days ago, we moved into a modular structure. We shut down JFL Main as it exists today. We did that safely. We did that without really a lot of fanfare. And there was a lot of disruption to our teams and the way we do things. And, I've learned very early on, we're not going to say mission accomplished yet because there are still bugs, there are still things that we are working out. And that will evolve over the coming weeks and months as we learn to live and deliver great care in our new facility. But we are here today, we're discussing a lot of the same things that have plagued healthcare in this territory for a number of years, whether it be staffing, funding, uncompensated care. These are tough things that we all need to work together on. Healthcare, I believe that healthcare is not a responsibility of a hospital. It is a community responsibility, and we are all part of that. And we appreciate this opportunity to have this type of dialogue so that we can move things forward. Finally, I always end by saying thank you to the incredible team of JFL. We're moving from a team to a family, and we really do appreciate everything that they do to take care of this community.
Thank you to all the testifiers. What we've learned by the testimony today is that we have to take security serious. There's a lot of my colleagues had a burning desire and a lot of information discussed. We don't want to repeat items of the past, but we've also learned that we have to build. We have to take that also seriously because, you're a hospital, and we know that medical care costs money. And we've also learned that the nurses, you've heard the testimony, the nurses, I think the community has shown a commitment to our RNs. So thank you very much for being here today. And at this time, you'll be released from In the Well. The Committee on Hospitals, Health, and Human Services stands in recess for 15 minutes. The Committee on Hospitals, Health, and Human Services is out of recess. I'd like to recognize the presence of non-committee member, Senator Carla Joseph. Welcome. Thank you. Madam Clerk, can you read into the agenda block number 2?
Block 2, the committee will receive testimony on the operational and redevelopment status of the Snyder Regional Medical Center, St. Thomas, and the Myra Keating Smith Clinic, St. John. Invited testifiers, Mrs. Tina Comisión, Esquire, Chief Executive Officer, Snyder Regional Medical Center, Dr. Jerry Smith, MD, District Governing Board Chairman, Snyder Regional Medical Center, Mr. Darrell A. Smalls, Executive Director of Facilities and Corporate Development, Territorial Hospital Redevelopment Team. This concludes the reading of Block 2. Mr. Chair.
Thank you, Madam Clerk. Are there any correspondence for Block 2, Madam Clerk?
Yes, Mr. Chair.
Can you read that correspondence into the record, Madam Clerk?
May 2nd, 2023, Honorable Senator Ray Fonseca. Chairman Fonseca, it is with regret that I write to inform you that I will not be able to attend the May 3rd meeting of the Committee on Health, Hospitals, and Human Services to offer my testimony as requested on the state of the facilities within the St. Thomas, St. John District. I was notified of a major staffing challenge in one of my facilities that I am forced to personally fill to avoid a negative effect on the care of several vulnerable patients. I further apologize for the late notice. I have been trying to remedy the situation in hopes of being able to attend the arranged meeting. To my utter dismay, I was not able to do so. In an effort to make sure that your committee receives all of the pertinent information regarding the St. Thomas St. John District, I reached out to the chairman, Christopher Finch, whom I learned is also slated to give testimony today on the same subject matter. Upon review of his testimony, I quickly realized that we would have been reporting identical data, so I can assure you that a full description of the district is encapsulated within his testimony. Again, I sincerely apologize for not being able to attend this hearing and look forward to future opportunities to offer testimony on this and other topics. Respectfully, Dr. Jerry R. Smith, PD, DPT, ATC, Acting Chairman, St. Thomas St. John District Hospital Board, Vice Chairman, Virgin Islands Government Hospital and Health Facilities Corporation. This concludes the reading of the correspondence, Mr. Chair.
Thank you, Madam Clerk. Senator Gittins, you're recognized for a point of personal privilege. Please recognize the mic of Senator Gittins.
Thank you, Mr. Chief. Good afternoon to all again. Imagine now while we're here discussing our healthcare facilities and discussing proactive healthcare security and the importance of security services at our hospitals. While we were here with the first half of this hearing, ironically, the city of Atlanta sent out through the police department, sent out a public safety alert indicating of an active shooter and mass shooting incident in the Peachtree area of downtown Atlanta. And this, not only that it's a mass shooting, but it actually occurred at one of Atlanta's medical facility. So I'm just saying, as we discussed today, proactive healthcare security and the importance of security services at our hospitals. I'm reminding all, and especially the executives at the hospital, that we need to take this matter seriously. My prayers goes out to those victims at this time, and I pray that the law enforcement officers are able to find and secure this suspect at this time. Thank you.
Thank you, Vice Chair Senator Gittins, for that important update. At this time, I'd like to recognize the presence of Tina Comisión and Chief Executive Officer for the Roy Lester Snyder Regional Medical Center and her staff, and also Darryl Smalls, who was with us in Block 1, and also Christopher Finch. And so we will like for everyone to, again, put your name and title on the record, and then we will proceed with the testimony, starting with Ms. Comisión. Yes.
Good afternoon, Senator. Thank you. Christopher Finch, Board Chairman, Virgin Islands Government Hospital and Health Facilities Corporation.
Thank you.
Good afternoon, Senator. Darryl A. Smalls, Executive Director of the Territorial Hospital Redevelopment Team.
Thank you.
Good afternoon, Honorable Senator Ray Fonseca, Tina Comisión, CEO, Schneider Regional Medical Center.
Thank you very much.
Good afternoon, Delphine Olivaci, Chief Nursing Officer, Schneider Regional Medical Center.
Welcome.
Good afternoon, Senator. Kenesha Angle, Director of Finance at Schneider Regional Medical Center.
Thank you.
Senator Peter John Baptiste, Director of Facilities and Engineering.
Thank you very much.
Vice President of Facilities and Engineering.
Thank you very much, Peter. Ms. Comisión, you may proceed with your testimony.
Thank you, sir. Good afternoon, Honorable Senator Ray Fonseca, Chairman of the 35th Legislature's Committee on Health, Hospitals, and Human Services. Good afternoon to other senators present and to the listening and viewing audience. I am Attorney Tina Comisión. I'm the Chief Executive Officer of Schneider Regional Medical Center. Appearing with me today are Schneider Regional Medical Center's senior leadership team members, Ms. Kenesha Engel, our Director of Finance, Dr. Delphine Olivaci, our Chief Nursing Officer, Mr. Christopher Borgeson, our Vice President of Operations, Mr. Peter John Baptiste, our Vice President of Facilities, Mr. Brandon Richardson, our Vice President of Information Technology, and Attorney Sulaine Walker, our legal counsel. Thank you for allowing Schneider Regional Medical Center the opportunity to appear before this committee today. I want to start by saying thank you to our talented, committed team of Schneider Regional Medical Center employees. We are all working hard for our community. We are making Schneider Regional Medical Center the best place to get care and the best place to give care. Schneider Regional Medical Center provides nationally recognized high-quality care to our patients and to our community. On September 30th, 2022, the Roy Lester Snyder Hospital and the Myra Keating Smith Community Health Center underwent a full accreditation from the Joint Commission and passed the inspection with flying colors, very, very high marks. The Joint Commission, which is an independent body that evaluates hospitals all over the country, found our facilities and operations to be in compliance with or exceeding the expectations of over 250 standards for the provision of quality health care. Our accreditation is valid for the next 3 years. Additionally, in March of this year, SRMC had a separate unannounced laboratory services survey, which we also successfully completed. And we anticipate receiving our accreditation certificate for our laboratory soon as well. We congratulate Ms. Tanel Francis, our Lab Operations Director, a Virgin Islander who we recruited to return home to work with us this year, and her team for a job well done with the lab survey. The positive assessments from the Joint Commission are a direct result of the hard work of the staff who show up every day to provide quality, compassionate care to our community. To them, and especially to our quality and performance improvement team, who took the lead on our surveys, I again say thank you for all that you do for our patients and our community. One of our top areas of focus for 2023 is expanding access to important medical services and medical specialties that Virgin Islanders need. Last month, we opened an outpatient behavioral health clinic called the SRMC Wellness Clinic. It is staffed with an excellent psychiatrist, Dr. Zen Maservi, with a psychologist, a therapist, and with other clinical providers who specialize in mental health treatment. This past year, we also added 2 Virgin Islanders who are physicians to the SRMC team. These local talented women are bringing new services and treatments to our community. Dr. Imnet Habteez joined the SRMC team as a full-time pulmonologist and critical care physician, providing new pulmonary testing and treatments and expert advice on complex cases. Dr. Danielle Cummins-Young joined the SRMC team as a full-time general surgeon and is providing new minimally invasive procedures and using the latest techniques in surgery for a wide range of traumas and other surgical interventions. It is great to welcome back home two of our very own physicians. We are now working very hard on reestablishing interventional cardiology services at SRMC. Adding an interventional cardiologist to our team will allow us to provide the immediate care a person needs if they are having a heart attack, and it will allow us to treat and manage other cardiac conditions right here on island before they worsen. Chronic heart conditions and heart disease affect a significant portion of our population, and it's imperative that we find a way to provide these cardiology services so that our residents can receive the care they need at home. Through the excellent work of our newly reestablished SRMC Foundation, we have secured a very generous donation of $350,000 for the purchase of the cardiology equipment that we need to provide this service. We appreciate the support of this committee for additional funding allocations for the operational aspects of the interventional cardiology program. This is truly a program with immediate, significant benefits that could literally save the life of anyone in our community, and it's money well spent in the public's interest. We are also currently working on adding services in gastroenterology. We need to be able to provide our community with important routine colonoscopy screening services that saves lives. Early detection is key. No one in the community should have to wait months to get a basic diagnostic procedure, such as a colonoscopy. We can avoid tragic outcomes by expanding access to this service in our district. We don't want our residents to have to travel off island and incur extra expenses related to routine diagnostic care. Securing additional equipment for endoscopy will allow SRMC to reduce the gaps in access to care that presently exist. It's good for our community to have that talented gastroenterologist's expertise on site to treat patients with GI conditions that come to the emergency room, and to be available locally to consult on complex cases within our hospital. It is within our reach to save lives and avoid much more expensive outcomes, but it requires funding. We need to purchase 2 new pieces of equipment, which total approximately $200,000. We need to do minor construction to optimize that space to allow for more patients to be seen, which totals approximately $50,000. And we need to support the operational costs, especially the physician and nursing staffing for the program. We also know there is, unfortunately, a growing need for hemodialysis in our community, and we need to invest in expanding our capacity to provide this life-sustaining treatment. To better serve our community, we will need to expand the SRMC outpatient hemodialysis unit and add additional machines and a new RO water treatment system. The purchase and installation of the hemodialysis machines and a water treatment system will cost approximately $1.4 million. There is also an additional cost for the construction that will need to be done to accommodate the additional patient care space. We have already begun the process of purchasing 4 new hemodialysis machines to replace our current ones that are past their end of life. But additional funding is needed to replace the remaining end-of-life machines and for obtaining the additional hemodialysis machines that are required to meet the growing demand for care. We also continue recruiting for some other permanent medical staff members to maintain and expand our other services that already exist. SRMC needs to add 2 emergency room physicians, 1 nephrologist, 1 psychiatrist, 1 internal medicine doctor, 1 orthopedic surgeon, 1 obstetrician gynecologist, 2 midwives, 4 CRNAs or certified registered nurse anesthetists, and 1 emergency room physician assistant to our team. Right now, we are filling those spots with expensive temporary locum tenens coverage to ensure that we continue providing care to the community. A second major area of focus for SRMC for 2023 is recruiting and retaining permanent nursing staff. While recruiting permanent nursing staff had long been a challenge for our organization, the COVID-19 pandemic made it even more difficult. higher salaries and generous sign-on bonuses from temporary nursing travel companies, and more reasonable costs of living elsewhere have all been stymies to getting permanent staff to sign on at SRMC. We have made great strides over the past several months in renegotiating with the nursing unions to fix our compensation packages so we can be more competitive and so we can successfully recruit the professionals we need. Our negotiations with our staff registered nurse union, VISNA, are completed, and last week we received all the signatures required to put the rate into effect. We have presented the new compensation and benefits package to the agency registered nursing staff, and we are working to engage them to come on board as full-time permanent employees. Some of those contract registered nurses have already expressed an interest in permanent employment with Schneider Regional Medical Center and are converting. If you know a registered nurse, please refer them to Schneider Regional Medical Center. We have a very, very attractive package now, and we need good nurses to help us take care of our patients. Our negotiations with the licensed practical nurse union are also completed, and the new rate has been implemented. Several LPNs who were functioning as patient care technicians due to pay have converted over, and we continue to recruit LPNs from the community to join our team to serve on almost all of our patient care units. I would like to thank Governor Albert Ryan for his commitment to assisting with our recruitment and retention efforts through the allocation of $8 million, broken down as $2 million per year for 4 years, of ARPA funding to assist with critical clinical staffing. I would also like to thank Attorney Joss Springett, the Chief Negotiator at the Office of Collective Bargaining, for her role in negotiating the new rates for the 2 nursing unions. In total, we require approximately 117 registered nurses on staff to care for the patients in our hospital. Currently, we have 71 registered nurses on staff, which is approximately 60% of our complement. When I sat before this committee last year, only 56% of our positions were filled. So we have made slight progress, but we recognize that we still have a lot of work to do, especially in our emergency room and our OR departments. In the ER, we only have 6 of the required 21 permanent registered nurse positions filled, which is only 29% of the permanent nursing staff we need. In the ICU, we have 7 of 13 required permanent registered nurse positions filled, which is 53% of the permanent nursing staff we need. On the medical unit, we have 7 of 12 permanent registered nurse slots filled, which is 58% of the RN permanent complement we need. On the surgical unit, we have 5 of our 12 permanent RN slots filled, which is only 42% of what we require. We also have nursing vacancies at our Myra Keating Smith Community Health Center, and we do supplement with contract nurses to ensure that we continue to provide 24/7 coverage to the residents and visitors of St. John. Now that we have a new competitive compensation package, we will begin aggressively working to hire more nurses. We have had an uptick in RN interviews since the start of the year. We anticipate onboarding 7 new licensed nurses within the next 3 weeks. And for the month of March, we onboarded 3 RNs and 1 LPN. So whereas before we had 34 nurses supporting us from Pafford, so far for this year, we already have 28 that are confirmed and committed to on board with us as permanent members. 19 of those nurses have already started, and we have 9 more to come. We have 6 that we are interviewing this week. 13 of those nurses who have recently committed to joining our team are VI locals, and 2 are from Tortola. And from the nurses that are going to be joining our team, 5 of them are UVI grads, which speaks to how successful our outreach has been with the UVI nursing program. We are also actively recruiting about 100 nursing students who will be graduating this year from several universities. We are in constant communication with over 40 nurses who are graduating from the University of Florida. We also had team members from SRMC travel to Puerto Rico to visit Interamericana University, to recruit nurses from their campus, and to meet with Alumni Association membership, and to meet with recruiters based in Puerto Rico who can refer and place nurses from Puerto Rico in our organization. To support new graduates, we are also restarting our graduate nursing and nurse extern programs this year. These programs provide both clinical and academic support for the graduates in their pursuit of successfully passing the NCLEX exam. For reference, the NCLEX exam is the licensure exam that's required to actively practice in the U.S. Virgin Islands. In 2023, we must also continue to improve the financial position of our organization, which will in turn help us to achieve our other strategic objectives, which include stabilizing our supply chain, advancing the improvements on our facilities, adding and expanding access to service, retaining our staff, and progressing on our IT infrastructure projects. Presently, our accounts payable and accrued liability stands at $28 million, a number which has grown over the past year. During fiscal year 2022, SRMC spent over $3.8 million in locum physician coverage and approximately $5.5 million for contract labor through staffing agencies to fill the gaps of clinical vacancies. So far this year, the organization has spent over $1.3 million in locums physicians coverage and more than $3.9 million for contract labor for nursing and allied health positions through staffing agencies. Due to this significant growth in expenses and in our accounts payable, we have also fallen behind with our obligations to GERS and the GVI Cigna insurance program. SRMC acknowledges owing over $690,000 in employer contributions and $1.3 million in employer contributions to GRS and has been working to catch up. We also acknowledge that we owe approximately $7.1 million to the Cigna insurance program. SRMC does not intentionally withhold payments to vendors. Difficult decisions are made based on our cash on hand. Our executive team meets regularly to assess and prioritize the vendor payments that can be issued based on the cash on hand. This process is done to ensure we have critical medical supplies available and staff available to provide safe, quality healthcare to our community. We recognize that we have to both increase revenues and decrease expenses in order to improve the financial position of the hospital. The expenses related to the contract labor are not sustainable, and therefore we have implemented and are working hard on plans to continuously reduce the number of agency staff, with the ultimate goal of completely eliminating the use of staffing agencies. Reducing these expenses will better allow the organization to address the outstanding accounts payable debt and the debt to other agencies. On the revenue side, SRMC's current payer mix is very unfavorable. SRMC's major payers consist of Medicare, Medicaid, and the uninsured, and this actually totals 77% of our business. Patients seen or treated at SRMC under these three categories have little to no insurance or are enrolled in programs that pay below cost, such as Medicare and Medicaid. Many of them simply lack the financial ability to pay their medical bills. Our payer mix is comprised of self-pay and uninsured at 13%, despite the presence of presumptive eligibility, Medicare at 39%, and Medicaid at 25.3%. Commercial insurance only contributes or makes up 19.8% of SRMC's business. We hope that with the improvements that we are making at the hospital and with structural changes we can make to incentivize care at the hospital, we will see a more favorable payer mix in the future. A better payer mix with more commercial insurance like Cigna will help SRMC to offset the care that it provides as a community hospital. A significant amount of intra-agency debt is owed to SRMC from other government agencies. Provided with our testimony is a document indicating the amounts owed by several government agencies, primarily the Workmen's Compensation Program, which owes SRMC $3.7 million for care already provided to members of that program over the past 5 years. While SRMC has been charged and garnished $275,000 every month to pay WAPA, there has been no garnishment of other agencies to pay SRMC for the services that we have provided. We are, however, very proud of the strong progress we are making in improving our billing and collecting efforts and working on our revenue cycle. We are seeing increased revenues. Currently, cash collections are up 11% from FY 2022 and continue to improve. Monthly cash collections over the past 6 months averaged $4.3 million, which is a stark improvement from previous years. Since putting a renewed focus on revenue cycle and restructuring to add staff on our billing and collecting and denials management teams over the past year, we have seen our monthly collections grow from $3.5 million on average in the past to somewhere between $4.5 and $5.2 million per month over the past 8 months. We're very proud of our revenue cycle team, and we're confident that our collections will continue to improve as we continue to tackle these revenue cycle improvements. We also continue to stress the importance of productivity and efficiency at the department levels to help to enhance our financial position. Our department heads and managers are continuously looking at ways to cut costs as well as ways to increase revenues within their departments. With the help of our department leaders and clinical teams, we've been able to realize several other successes related to increasing revenues and cutting costs. In just 1 month since the expansion of the pulmonary function test unit within respiratory, and in partnership with Dr. Habtees, SRMC's pulmonologist, our gross revenues for this unit have increased by 25%. The Pharmacy and Therapeutics Committee identified and modified our formulary to remove a costly medication and replace it with a cost-saving alternative that can save us up to $300,000 annually. The radiology department continues to see record months of gross revenue with a $132,000 increase between March 2022 and March 2023. In the respiratory department, gross revenues were more than $350,000 above month to target. While we are still affected by the hurricanes, which severely impacted our facilities over 5 years ago, and while FEMA has obligated money for a complete rebuild, it will still be another 5 to 7 years before that work begins to take place and we have a new hospital to move into. We must keep our existing buildings in safe working conditions to ensure that we are providing our patients and staff with a quality healthcare environment. Maintaining the facilities remains a challenge because the repairs are costly and are not budgeted for separately. We have made sure to take advantage of and use all of our available funding that has been dormant at the Public Finance Authority to complete as many repairs as possible. We recently completed a repair of the roof at the Royal Leicester Schneider Hospital, which was very necessary to better prepare us for the upcoming hurricane season and to prevent further water damage to our facility. We also recently completed the repair of fencing located on the 5th floor roof of the hospital. Now, our patients who are on the behavioral health unit, which is a locked unit, can resume outdoor activities. We are very happy that we were able to make this a reality for these patients. Even though it required using very tight operational funds, we had to do it for our patients' health, safety, healing, and well-being. Our current capital list stands at just over $10 million. Our capital spending is inadequate to keep pace with improvements and upgrades in technology and to address the organization's infrastructure needs. Every year, SRMC has had to defer capital improvements or use operating funds to meet emergency capital needs. Unlike similarly positioned hospitals, SRMC does not have the ability to set aside funds for regular capital improvement. The inability to fund capital items will continue to affect our operating costs as maintenance costs and emergency repairs will continue to increase. Our operating room, emergency room, radiology department, hemodialysis department, and laboratory departments all have identified the equipment they need to purchase. Additionally, we have identified the facility repairs and enhancements that are much needed to ensure the continuity of operations and to allow us to better serve the community through the expansion of service lines. $1.9 million of our projected capital expenses are related to facilities infrastructure enhancements. While it may seem possible to defer these, the replacement of the fire safety sprinklers, air handlers, and chiller pumps, and enhancements to our security systems, such as replacing CCTV equipment, installing improved security access controls, and giving training and equipment to our guards, just to name a few, are very necessary for SRMC to maintain safe operations and to remain in compliance with our regulatory bodies, CMS, and the Joint Commission. Approximately $1.2 million worth of equipment is needed for the operating room to sustain our perioperative service line. SRMC needs to purchase new equipment such as towers for laparoscopic procedures, cabinets to warm solutions, a washer for equipment sterilization, and scopes and monitors. This equipment will enable us to provide important screening procedures and expand our profitable revenue-generating services. The upgrades that are needed for our radiology and laboratory department will cost approximately $1.5 million. SRMC needs to purchase new equipment to continue to support diagnostic testing at both the Royal Leicester Schneider Hospital facility and the Myra Keating Smith Clinic on St. John. Additionally, we have to purchase several UPS machines, which will protect our diagnostic equipment against electrical damage. The cost of one UPS is approximately $140,000. Acquiring new radiology and laboratory equipment will allow us to continue to be more efficient in our turnaround time for resulting studies, especially for our ER patients. It will also have a direct impact on improving wait times. It will reduce the number of tests that we have to send away to be processed and will shorten the turnaround time for patients to get their results. SRMC needs to replace beds and monitoring equipment on both the pediatric and labor and delivery units. The estimated cost for that is $296,000. These replacements are necessary for patient care and patient safety. As healthcare technology improves and becomes more efficient, adopting IT advances are critical to our ability to keep pace with the larger landscape of the healthcare industry and to remain competitive. We thank this body for your support and for the support we have received thus far in funding our technology advancement initiatives. We need your continued support of funding for our IT initiatives so we can provide our community and our patients with connections to telemedicine, with access to their records, to virtual care, the ability to self-schedule their appointments, the ability to track their health status and metrics using wearables, and other user-friendly, modern options for interacting with SRMC as a healthcare provider of choice. We very, very much immediately need $1 million for the final payment for the Omnicell automated medication and supply cabinets. We have already funded the first $1 million, but we still need an additional $1 million to complete the purchase. These storage lockers account for over 30,000 doses of medications every month, and $800,000 in charges are recorded through these machines every month. Our current cabinets are end of life. SRMC has successfully maintained them for 20 years. It's time for them to be replaced. SRMC needs to install a disaster recovery solution as well. The cost for that disaster recovery solution is approximately $1.5 million. The disaster recovery solution is an IT backup. It's for our secure, sensitive medical data that could be potentially damaged in the event of a natural disaster. Having this disaster recovery system in place allows us to ensure that no matter what the incident is, we can still get access to all of our patient data within 48 hours of the emergency. I want to stress that all of the enhancements I've mentioned so far are for the overall betterment of the community. We want our residents to get timely access to routine services here at home when possible. And we do not want you to have to worry about adding on costs for airfare and lodging to get checkups because the wait time for your routine screenings or other care can be up to 6 months locally. To do the things that we know we can do, we have to have both the infrastructure and the manpower in place to successfully expand these important service lines, and to do that, we need this body's support of funding. Included with our testimony is a complete list of all the items I have discussed and their associated costs. I ask that this committee support our request for capital funding for these projects so that SRMC can provide the best possible care to our people. In August 2022, we officially launched the Meditech Expanse upgrade. This is a major technology infrastructure upgrade that's going to move us to a new version of Meditech, which is our electronic medical record, or EMR. The new EMR will help us to improve efficiencies, workflows, reduce errors, improve the patient experience, and help us to maintain compliance in reporting requirements to our regulatory agencies. Our anticipated go-live date for our new Meditech Expanse is October 2023. We want to say thank you to this body and to the governor for your funding support for this initiative, and we hope that we can count on you for your continued support to ensure the full success of the system. SRMC continues to deal with the global effects of COVID-19 and the Russia-Ukraine war as it relates to manufacturing, distribution, inflation, and the availability of pharmaceuticals and medical supplies. While our group purchasing option, or GPO, and our self-negotiated contracts are helping us to keep prices as low as possible, we have seen and expect to continue to see significant price increases on supplies. It has been projected that there may be anywhere up to double-digit percentage increases in pricing at the next series of contract issuances. Such increases are a significant factor contributing to our growing AP. Additionally, freight costs are an area of great concern given our location outside the continental United States and the increase in shipping costs nationally and around the world. To better manage our supply shortage situation, we have restarted our Value Analysis Committee to review any new requests for supplies and equipment. We want to be sure that we are reducing excessive expenditures while still offering the best products for patient care. SRMC's procurement and material management team continue to navigate the ever-changing landscape of the healthcare supply chain. In 2022, our organization saw approximately 14,836 patients at the Walter Schneider Hospital emergency room. We had 55 COVID admissions for 2022. SRMC consistently has a census of 70 dialysis patients over the past year, to whom we provided approximately 2,101 outpatient hemodialysis treatments. We have also had approximately 53,000 outpatient encounters in our other outpatient areas. At our Myra Keating Smith facility, we have seen an average of 6,800 patients per year, or in excess of 500 patients per month. Over the past year, we have started changing our processes within the laboratory and radiology departments to make registering for and obtaining these services more efficient and more patient-friendly. Our outpatient rehabilitation services have increased, and as of last month, we have relaunched our cardiopulmonary rehab program. In terms of our plans to address wait times in the emergency department, the emergency department at SRMC functions as a part of the larger safety net system for the St. Thomas St. John communities. The flow and wait times through the emergency department are dependent on so many factors, including internal ones and external ones, such as whether there is sufficient primary care and/or insurance in the market. Making significant and sustainable changes to patient flow in the emergency department at Schneider Regional requires recognizing and addressing many layers of issues. There is an interdependence between the key components of the healthcare system, including within the hospital setting and care settings that are outside of the hospital. And we have included a conceptual diagram to help to visualize all of the interactions for patient flow inside and outside of the hospital. To solve the problem of emergency department crowding and delays in admitting patients at Schneider Regional, improvements in both external and internal factors are needed. For the external factors, we must work together to address the environmental factors that lead to the growing use of the emergency department by the uninsured for non-emergent visits, and the increasing acuity and number of chronic conditions of the patients that are coming to receive services. The approach of tackling ED overuse as a community problem can truly help us to resolve it. To draw patients away from seeking non-urgent care in the emergency department, we must together educate patients about utilizing primary and alternative care centers and adopt preventative care practices. To improve patient flow in the emergency department, we also need to work together to address the biggest cause of bottleneck in admitting patients who need to be admitted, which is our large population of boarders, otherwise unsafe discharge patients. The lack of community-based wraparound services and nursing home placement options for these unsafe discharges has a direct impact on throughput in our emergency department. Currently, SRMC has 13 unsafe discharges. 7 are on our medical unit, 3 are on our surgical unit, and 3 are on our behavioral health unit. These patients are occupying beds intended for patients requiring acute care services for very extended periods of time, some as far back as 2018. As a result, patients needing acute care end up being cared for in the emergency department, leading to extremely long wait times for others who are waiting to get to the back of the emergency department to be seen. To address the border issue, we have been and will continue to collaborate with community partners to seek safe discharge options for boarders. We participate in regular meetings with other key stakeholders, including our Territorial Hospital Board, the Department of Health, the Department of Human Services, the Offices of Management and Budget, and others, in an effort to relocate the boarders to the right care and the right place. Compliments to our case management team, who work hard to find placements with very few options available. In 2023, we only successfully discharged 4 boarders to either their home or to a long-term care facility. If SRMC has been, is currently, and for the near future, likely to be responsible for continuing to shoulder the responsibility and cost for providing this long-term care to these persons because other entities cannot accommodate them, then perhaps this body can consider repurposing a portion of those funds that are allocated for that purpose for caring for these Virgin Islanders to the hospital. Boarders are a big financial stressor to our organization. Although they remain in-house and receive care from our nurses, medications from our pharmacy, and supplies from our material management daily, we have no ability to collect money for the care that we provide to them after the first 30 days of their stay. SRMC has a patient who has been at the hospital ready for discharge since 2018, more than 1,600 days, and has incurred more than $2.6 million in charges, of which over $2.5 million is uncollectible. It's also important to note that these figures are based on Medicare rates, which are the lowest possible rate of reimbursement and well below our actual cost of providing the care. Unreimbursed costs for our long-term patients in total exceeds over $8 million. The boarders further exacerbate the hospital's financial position, and they increase the demand for nursing staff, as they are additional patients that we have to account for in maintaining our regulatory nurse-to-patient ratios. We recognize that there are also internal factors that we have to work on that affect patient flow. Emergency department patients routinely receive a number of complex diagnostic and screening services. The timely administration of these testing and services and the prompt availability of test results is imperative for smooth hospital operations and efficient patient flow, especially through our emergency department. SRMC has recently redesigned and is about to implement a new process to ensure prompt turnaround times in diagnostic testing. Our team has created standardized, nurse-driven, physician-approved standing orders that can be issued at triage. These orders will facilitate the initiation and completion of laboratory and other diagnostic testing during the initial triage process, and then will result in the immediate review of testing as soon as the patient is transported to the main ER for medical staff evaluation and treatment. We are getting the turnaround times for laboratory and diagnostic imaging down to approximately 45 minutes, which is a recent significant improvement in our diagnostic testing turnaround times. We have also implemented several other strategies to improve hospital-wide patient flow, which will ultimately improve patient flow within our emergency department. We are convening an interdisciplinary team consisting of senior leaders, laboratory leaders, diagnostic imaging leaders, nurse managers, medical staff representatives, support services representatives, quality and performance improvement specialists, and frontline staff to identify deficits and bottlenecks in organization-wide and emergency department flow. We are also working towards separating emergency department patients based on the patient's acuity. The care of patients identified as non-urgent can best be done through a fast-track model of care. The low acuity patients can be quickly seen, diagnosed, and treated effectively, and most patients can be discharged home rather quickly. The consistent provision of fast-track service at Schneider Regional is hampered by the staffing shortage of professional registered nurses, advanced nurse practitioners, and physician assistants, but we are working to fill those positions. It's for this reason that the staffing of our emergency department in particular is a priority for us. We know that our wait times will drastically improve with adding these critical staff members. Another thing we've started is enhancing multidisciplinary rounds at Schneider Regional Medical Center. Multidisciplinary rounding is a model of care in which multiple members of the care team representing different disciplines come together to discuss the patients in real time. This has proven to be a valuable tool in improving the quality, safety, patient experience, and patient flow at a hospital. SRMC's MDR team members consist of physicians, nurse managers, social workers, physical therapists, and clinical dietitians. During these rounds, team members coordinate care, determine care priorities, establish daily goals, and plan together for potential transfers and discharges. Apart from the emergency department, we are always looking at ways to improve and expand upon the services we offer to our community. We strive to be your healthcare provider of choice when you have an option in the care you receive. On April 11th, President Joe Biden signed a bill ending the COVID-19 national emergency due to the disease achieving endemicity, which will be effective on May 11th, 2023. And while we are no longer experiencing the COVID-19 surges, we do continue to monitor its ebbs and flows to inform our best practices. We still have our highly infectious disease unit, though it has been mostly closed since January 26, 2023. We also still have our COVID task force in place, and it meets as necessary to inform best practices. We expect to feel the effects of the pandemic as it relates to operating costs and supply chain issues well into 2024. As such, managing the effects of COVID-19 remains a priority for us at the hospital. For an update on the rebuilding of our facilities, I will defer to the testimony from the chairman of the territorial board, Mr. Christopher Finch, and of Mr. Darrell Smalls, and of the territorial hospital redevelopment team. With the SRMC team, we are particularly excited about the progress that's being made with the Charlotte Kimmelman Cancer Institute. Resuming medical oncology and, importantly, radiation oncology services to the Virgin Islands is extremely important to us. We are passionate about this project, and we are so excited to see it moving forward. I am committed and honored to work with such a fine team that is really dedicated and working hard to make our hospital the best that any small island can have. We will continue to work with the Territorial Hospital Redevelopment Team, with our district and territorial boards, and with the Governor Juan F. Louis Hospital and their CEO, Mr. Doug Cook, to improve healthcare for all residents in the territory. Our challenges are many, but with the commitment of all of us, we can ensure that our residents are able to receive the care they need and deserve right here at home. Any of us could need the services of Schneider Regional Medical Center at any time, for ourselves, or for our loved one, or for our visitors. And it's in all of our best interests to support our community hospital and to make it the best it can be. I thank every member of the SRMC team who works towards our success and continued improvement. We hope that this committee and the 35th legislature will continue to champion the improvement of our healthcare system in the territory through necessary and appropriate funding. As you consider legislation this year, we ask that you look at the overall healthcare needs of the territory and prioritize funding that supports patients, caregivers, and providers. To the listening public, come to us for your care. We have a dedicated team who do their best to make sure your healthcare needs are met. We have some very well-trained, highly skilled nurses, doctors, and technicians working right here on St. Thomas and St. John at SRMC, and we encourage you to trust us with your care. I also would like to invite the public to come to our Dinner with a Doctor series. We are doing a lot more to increase our community engagement, And every month, one of the things we do is host physicians who provide education on topics that impact our community. We have had talks on mental health awareness, diabetes and kidney health, and cancer screening so far this year, to name a few. Our next series is going to be held in June in the Sunroom, located in the cafeteria at the Royal Leicester Schneider Hospital. And please check our social media outlets for updates on this event, or look at the dashboard in our lobby of the hospital for more information on Dinner with a Doctor. Again, thank you for allowing me to share these updates from Schneider Regional Medical Center with the committee, and I hereby respectfully conclude my testimony. My team and I are available to respond to any questions that you may have. Thank you, Senator.
Thank you very much for that very detailed testimony, Tina Commission. The Committee on Health, Hospitals, and Human Services will stand in recess for 2 minutes to change recorders.
Should I give them to Celine?
The Committee on Health, Hospitals, and Human Services is back on the record. Thank you very much for that testimony, Ms. Commission. Mr. Smalls.
Good afternoon. Good afternoon, Honor. Can you hear me?
Yes.
Okay. Good afternoon, Honorable Senator Ray Fonseca, Chairman of the Committee on Health, Hospitals, and Human Services, Honorable Senators of the Committee on Health, Hospitals, and Human Services, other Honorable Senators of the 35th Legislature, Senate staff, fellow hospital testifiers, and the listening and viewing audience. My name is Darrell A. Smalls, Executive Director of Facilities and Capital Development for the Territorial Hospital Redevelopment Team, which I serve under the leadership of Chairman Christopher E. Finch of the Virgin Islands Government Hospitals and Health Facilities Corporation. Thank you for this opportunity to testify this afternoon as to the status of the recovery efforts as it pertains specifically to the facilities which make up the Schneider Regional Medical Center, which include the Roy L. Schneider Hospital, the Charlotte Kimmelman Cancer Institute, and the Myra Keating Smith Community Health Center. As the Executive Director of the THRT, my primary role is to manage and oversee the planning, programmatic design, final design, bidding, project management, procurement, construction, and the project closeout process for the redevelopment of our territorial health facilities to include the Governor Juan F. Louis Hospital and the St. Thomas St. John facilities of the Schneider Regional Medical Center. With respect to the Charlotte Kimmelman Cancer Institute, I am happy to report that we have successfully completed the selective demolition of the facility, which was severely impacted by Hurricane Irma and Hurricane Maria. I am equally happy to report that the THRT recently issued the public solicitation as of the week of April 17th for the services of a responsive contractor who, once selected, will ultimately reconstruct the damaged facility. A pre-bid walkthrough for contractors is scheduled for the week of May 15th. The goal of the THRT is to issue a notice to proceed, NTP, for the construction no later than September of 2023. The target completion date that would coincide with the September NTP for this critically needed cancer institute is December of 2024. The Myra Keating Smith Community Health Center, which was also severely impacted, has cleared the final hurdle to arrive at a fixed cost offer from FEMA. No later than Friday, May 12, 2023, it is anticipated that the independent expert panel, which is the entity outside of FEMA under the Army Corps of Engineers, will have completed their review, and the project will then proceed to the large project notification process, which can take up to 45 days, after which we would receive notification that the project has been obligated. Due to the fact that this is considered a mega project, or one greater than 25 million, there are a number of reviewers who must review the overall project in great detail. As this is a large project, Congress will be involved as they too must approve the funding for this most important project. Once we receive the official fixed cost offer, we will commence immediately with the issuance of a solicitation, specifically a request for qualifications to review and establish a pool of qualified respondents who ultimately would be deemed responsive and be eligible to submit a proposal once issued for the construction of the new Myra Keating Smith Community Health Center for the residents of and visitors to the island of St. John. The final and most significant project to be obligated is the Roy L. Schneider Hospital. RLS, by far, has been the most challenging project, which, after years of arduous discussions, wrangling, and perseverance, we ultimately received notification that it met the criteria for a full replacement. Unlike CKCI, which to date has received a fixed cost offer, or MKS, which has cleared the final hurdles to obtain a fixed cost offer, RLS is currently in the process of developing the framework for which a final cost offer can be derived. Working collaboratively with our consultant, Wood O'Brien, along with FEMA, the THRT has remained steadfast through the discussions surrounding the elements of damages incurred and their respective costs. To put the discussions into perspective, both JFL and RLS were both designed and constructed as 250-bed facilities in the early 1980s. Utilizing the information garnered during the fixed cost determinations for JFL, the framework has been established and is being utilized as the benchmark for developing the ultimate replacement costs for RLS. We anticipate that the THRT and FEMA will mutually agree on a path forward no later than June of 2023, after which we can successfully arrive at a fixed cost offer by September of 2023. Working with our architect of record, we have been proactive with developing conceptual schemes which will facilitate an aggressive yet efficient construction schedule that could see construction commencing within 24 months after a fixed cost offer has been achieved. As I presented earlier today, my team and I, along with FEMA and the Office of Disaster Recovery, have remained and will continue to remain vigilant throughout this entire process. We will continue to be creative, thoughtful, and diligent on behalf of the SRMC personnel, its patients, along with the residents of and visitors to the St. Thomas St. John District. While there is still more work to be accomplished, there's no doubt in my mind that together we will be stronger, provided we work collectively towards one objective, and that is to construct the most efficient, standardized, resilient, sustainable, state-of-the-art healthcare facilities for the people of the Virgin Islands. As I conclude my presentation, I want to personally thank Ms. Christina A. Hodge, Recovery Director, for her continued support of our hospitals, and Mrs. Adrienne Williams-Octolin of the Office of Disaster Recovery for her unwavering support as the liaison between the hospitals and FEMA. Equally important, I want to thank the Territorial Board, the executive leadership of SRMC, and the true professionals of the Territorial Hospital Redevelopment Team. This concludes my presentation. I will remain available to answer questions at the appropriate time.
Thank you, Mr. Smalls, for your presentation. I know, Mr. Finch, you gave a presentation earlier. Do you have any additional parts for the Roy Lester Snyder?
Thank you, Senator. I believe I put everything into that first presentation, but since I'll be leaving soon, I just want to say what I said at the end and make sure that it's said in front of the Roy Schneider leadership team, that on behalf of the Board of Directors, I want to express my thanks for their hard work and their dedication and their passion and their creativity in keeping the hospital running, and as you heard through the very comprehensive testimony, all of the work that's being done and all of the continued aspects or continued attempts at improving services and streamlining services and getting the best value for the money. You also, as you've heard, as is true with Juan Luis, a great deal for more resources, more teams, more professional staff. But we know that despite the challenges, people are coming to work every day, the leadership team, and then all the men and the women, patient-facing and non-patient staff that are providing all of the care and all the backup services that make a hospital work, and I just want to thank them. And I guess I will be leaving in just a couple of minutes. Thank you.
Yes, you did mention that you have to leave at 3:30. I'd just like to quickly ask any of my colleagues if there are any specific questions for Mr. Finch. I'll allow one burning question. If not, then thank you for coming. And yeah, so one question.
Thank you.
Okay, several. Okay, Senator Bolkes, you're recognized for your one burning question.
Thank you, Mr. Chair. Chairman Finch, you mentioned in your testimony that Schneider Regional had completed the accreditation survey. Is there a timeline or a marker as to when you hope to achieve the full accreditation?
I think what I mentioned is that Schneider is completely accredited, and as CEO Commission said, that this last accreditation survey then keeps them accredited for the next 3 years.
Okay,
it's an ongoing, it's a surprise inspection in all cases. And this is the highest accreditation body that the hospital can get. So it's kudos to them that they've achieved this.
Okay, so you're just waiting for the next accreditation.
The next one would be 3 years from now.
3 years from now. Okay, thank you.
At a surprise
Mr.
date
Chair.
that they're choosing.
Thank you, Senator Bulkis. Senator Caput, you're recognized for your question.
Thank you, Mr. Chair. This question is for Mr. Chris Finch. Can you explain how the members of the board, how are the boards comprised? Because I know there's a St. Croix board and a St. Thomas board. Can you give an explanation how the boards are made up?
Yes. By the law, each district has a 9-member board that would be comprised of an elected doctor, elected by doctors, a nurse elected by nurses, and then 6 members chosen by the governor, confirmed by this body. Of those 9 members, 6 of those would also be chosen by the governor to move up to the territorial board level, with the exception that the doctor, the nurse, and whoever's chairman of that board would also move up to the territorial level. Those 6 from St. Croix, those 6 from St. Thomas, 12, then are joined by 3 cabinet members. The law states that the director of OMB and the commissioner of finance have to be 2 of those 3 and a third at the governor's choice. Right now, we have far fewer members of that. There are not quorums on either of the district boards. So while they continue to exist and to function, all the decision-making rests in the territorial board. The territorial board currently has 9 members, which includes the 2 elected doctors, the 2 elected nurses, the 3 cabinet members, and then there are 2 confirmed members, myself and Dr. Jerry Smith, confirmed by this body.
How long are the term for the territorial board and the district board?
They're all 3 years.
3 years? Okay. Thank you, Mr. Finch.
Senator Carla Joseph, you're recognized for your question.
Thank you so much, Mr. Chairman, and I'll be really quick. A pleasant good afternoon to everyone. Mr. Finch, I really want to thank you for all your service to the people of the Virgin Islands.
Thank you.
Kindly indicate for us if there is thoughts or discussion for a universal procurement system for the hospitals. That is, when we are ordering supplies, we order it in bulk for both the Snyder Regional Hospital as well as the Wang Louis Hospital, because they're both hospitals.
Thank you for the question, Senator. The board has emphasized and has done a lot of work, and the hospitals have worked alongside of us on standardizing as many things as possible. We have not moved into the area of one sort of procurement system yet, although we for the last several years actually we've been working on procuring the same types of equipment. So if one hospital uses Omnicell machines, the other hospital uses Omnicell machines. Meditech expands, both hospitals would do it. So we're all moving in that direction. One of the things that Mr. Smalls has emphasized from the beginning, and was part of the reason of creating the hospital redevelopment team to be over all of the projects, was that if we're going to use a certain brand of elevator, we're going to use that brand of elevator on all the islands, and machines, generators, et cetera, so that we will be able to stockpile replacement parts. If we lack the ability to repair it on one island, maybe somebody on the other island knows how to repair it because they have the same machine. So we're all moving in that direction. A common procurement is not in place yet.
Okay, and the common supply and inventory of the common supply, is that in place yet?
No, not yet.
Oh, do you have any anticipation or anticipated time frame for that? Because it saves us money in the long run, because you're ordering a larger amount of items in bulk.
Right. I should give a better answer than just not in place yet. The hospitals have cooperated quite a bit of when one of them has had something broken and the other one has an extra one to send it over, even to the extent of moving into JFL North. Schneider Regional Medical Center loaned some of their staff that came over to fix things and to help bring some supplies and whatnot with them, so that already this is working on a hand-in-hand basis at this point. Some of the items you'd save in bulk, some you wouldn't. There are some things in a hospital where they charge you per user, for example. So like we've done procurement, like when we, for example, did the Meditech Expanse procurement, we made sure we did one procurement for both of the hospitals. At the end of the day, it probably didn't save us any money because Meditech just said, well, how many users you have, and that's what we're charging you.
Thank you so much, Mr. Chairman.
Thank you very much, Senator Joseph. Senator Gittins, you're recognized for your question.
Thank you, Mr. Chair. The question is twofold to the chairman. First off, the contracts for the CEOs of the hospital or any contractual employees, any of them are required to get bonuses?
No, no, I don't. No, not that I recall, Senator.
Okay, so you're not sure about that?
I know I'm 99% positive, but without the contracts in front of me, I don't want to say. But I am not aware of any time that we have paid a bonus to senior leadership.
Okay, and in your oversight responsibility from the board's perspective, what is the board doing to address what I consider fraudulent behavior with regards to non-payment to the Government Employees Relations Board, to the GRS system? And I say fraudulent behavior because if an employee's check stub reveals that contributions are being sent to the GRS, and when they go to retire, then they're told that the deductions are not there, then where has the money gone to? What is the board doing to address this?
The for in the case of Juan Louis, a couple of years ago, we went through what was a very painful financial process for Juan Louis to completely pay off the debt that Juan Louis had to GERS. I'm not sure that on the GERS end, all of those counts have been reconciled back to the patients. I know that that Mr. CEO Cook came over here early yesterday hoping to meet with GERS. I'm not sure if that happened to further those discussions on the reconciliation of accounts. As CEO Comisión put on the record a few minutes ago.
Can you slow down for me a second? I'm not understanding what you're telling me about patients. I'm asking you about employee contributions
I meant
to the
staff. I'm
GRS.
sorry. I didn't mean to say patients. I'm just thinking hospital mode. I meant employees. The GERS debt that Juan Louis owed was paid off. And I believe that's been over a year, maybe a year and a half since we paid it off. What I meant to say is I wasn't certain if GRS had completely reconciled that to the employees' accounts so that it reflects on each employee's account, and Juan Louis' staff is working with GRS on that. As CEO Comisión put on the record, Schneider has now fallen behind a little bit with GRS, and they're attempting to work on that.
So what is the board doing with regards to your oversight responsibility? What is the board doing to address this?
It was a board mandate that led to the Juan Louis paying off the GERS. That came to the board, and the board mandated the payment schedule.
So, Mr. Chair, so you keep going to Juan Louis that you've addressed, but so tell me, the problem is at RLSH. Tell me what's going on there.
Right. We have not mandated the payments of that at this point. As I think the CEO detailed, there are times where the cash flow problems are such that decisions have to be made, and not everything can be paid for. It doesn't mean we don't take it seriously. We do intend to address it. And I was going back to the Juan Louis to show you that we have addressed these things, and when it continues to be an important to the board that it gets done.
Okay, thank you. I'll be contacting you after this hearing because there's also still some discrepancies even at Wang Louis. But thank you. Thank you, Mr. Chair.
Okay, thank you. Thank you, Senator Gittins. Senator Potter, you're recognized for your point of inquiry.
Thank you very much. And just very briefly, just wanted to know, on the same vein, Mr. Finch, whether or not the non-payment to GRS has impacted any employee's ability to retire.
Okay, I would have to turn it over to the Schneider Hospital to answer.
Thank you, Senator, for the question. We did have a situation where 2 employees were not able to start collecting their retirements about several months ago because we did owe some of the contributions for them.
Ms. Commission, one moment.
Sorry.
Please. Mr. Finch, thank you for appearing before the Committee on Health, Hospitals, and Human Services. You're released and have a safe flight.
Thank you.
Continue, Ms. Commission.
Thank you, Senator. So yes, we did then make payments so that the individuals I'm aware of have since been able to retire and start to get their collections. And when we submit to GRS, we have to submit both the employee deductions and the employer contribution as a batch. And so we have been willing and have remitted some on the employee side and are ready to do that. It's not fraudulent in any intention in holding the money. We are talking with GRS, their legal counsel, their administrator, in coming current with what we owe them. And as was mentioned, it's really due to cash flow issues, not that we don't recognize the importance of GRS.
Thank you.
Okay, thank you very much, Senator Potter. Okay, so, it's interesting that we can now have an opportunity to compare what's happening at the Wang Louis and what's happening at the Roy Lester Snyder Regional Medical Center. I think both hospitals have very competent staff and great leadership, but right away it stands out the differences in finances because Wang Louis gave testimony this morning that they actually made a profit in last fiscal year, whereas Roy Snyder is not doing so well. So it's very obvious that we need to help this institution. Let me ask you one quick question, Ms. Commission. Do you know approximately what are your monthly revenues and your monthly expenses so we can know what the difference is?
Yes, sir. I will defer actually to Ms. Kenesha Engel, our Director of Finance, so that we're sure we get the correct numbers on the record.
Thank you, Senator, for the question. Our monthly expenses can equate up to $7.5 million. And our monthly collections are about $4.5 million and have ranged from $4.5 million to about $5.2 million.
So you're saying, you finish?
In addition to that, Senator, I'd like to put on the record that we also get the allotment monthly. So our total on the revenue side, cash available side, is usually around 6.5 or so million. And as you heard, expenses are somewhere in the range of 7.5 million. So we are running essentially a deficit month to month.
Okay, so if I get the math correctly, your expenses is about 7.5, your revenue is about 4.5 to 5.
Patient collections are about 4.5 with the addition of the allotment. That additional $2 million it brings us up to about over $6 million.
So you're running a deficit of about $1 million something a month? Okay.
That is right.
And see, and that's what I wanted to point out. We have the listing of your equipment, the 10 million, and you went through it. But I want to follow up on the one question from my colleague with the GERS. The Cigna Health Insurance, that's $7.1 million. Does this mean that some of your employees are without health insurance?
No, Senator. We have maintained the health insurance coverage for all of our employees.
Okay, because, I can see that we need to give a lot of financial assistance to this facility. Going back to the question with billing and accounts payable and collections, how is your accounts receivables? How much do you have in accounts receivables?
Our accounts receivables are quite large. I will defer again to Ms. Kenesha Engel to give the exact dollar figure.
Thank you, Senator, for the question. Our accounts receivable can have up to over $10 million monthly in range.
And what's your total aged account receivable listing right now?
I would estimate to say about $90 million.
90?
Yeah, but that also includes a lot of accounts that may be uncollectible due to bad debt. And a lot of cleanup that needs to also be done through the accounts receivable.
Ooh, that's a big number. Yes, Senator. You recognize Senator Carla Joseph for your point of inquiry.
Thank you so much, Mr. Chairman. Just to follow up on your question, how much of the accounts receivable is bad debt? What is that amount, Director Angle?
Currently, right now, for the fiscal year 2023, we are running about over $5 million in bad debt as of March.
Thank you so much.
Senator Donna Fred, you're recognized for your point of inquiry.
Thank you, Mr. Chair. Somewhere I noted in the testimony there was a $28 million amount account.
Accounts payable.
Accounts.
The total of our accounts payable. Yes,
Okay, so
Senator.
that's your payables.
Yes.
So you have an outstanding amount of $28 million that you owe to
various vendors.
To
Senator.
various
Yes.
vendors. That's what it was. So, so what is your aggregate of your accounts receivables?
Ms. Engel put on the record that it was 90 million, Senator.
What period does that cover?
That's, I think,
Very far.
historical, very, very far back.
So
that's a running total.
At what
ma'am.
point do you write off your debt?
That's the project I think that Ms. Engel was also referring to, that the accounts receivable needs to be cleaned up because it reflects some patient refunds that shouldn't be there and some bad
what
debt
is
that
the-
shouldn't
what
be
is-
there.
What is the hospital's policy on debt write-off?
We have just advanced a draft of our policy on bad debt to the board for consideration, and JFL has also sent one forward. So I think the board is looking at a standardized policy for writing off bad debt for both organizations, and that's going to be part of the project that Ms. Engel was describing, that we're going to be cleaning up that AR list and the AP list.
So is it your testimony that you do not currently have a policy on writing off debt?
It's my testimony that we don't have a current policy that we are using right now to write off debt.
And based on your previous audits, that has never come up in your audits as a finding? That is definitely an issue.
We have had so there's a very old bad debt policy that's in place. We have not successfully, over many, many years, adjusted those accounts the way they should have been. So a cleanup is now required at this point to clean up years of it
So
being
how is that
off.
cleanup taking place? Is that something that's taking place via internally? Do you have a vendor, an
I think
accounting firm taking care of the cleanup? How is that going to be done successfully?
Sure. So it will be done as a combined effort from our internal teams with some support of one of our external vendors who's helping us on the whole financial revenue cycle, billing, collecting, cleanup project. There's a separate assignment for them to help us with cleaning up our AR and determining what's truly collectible and what's not. So we are actively working on that, and as soon as we get the policy from the board decided on, then we will further clean up those accounts.
Yeah, thank you.
And it is a finding. It has been noted in previous audits in the
Yeah.
management letter, et cetera, so it's a known public
Thank you for
disclosure.
your responses. I'll just say that is very concerning that you have an entity that's basically responsible for their financials, and you've had highly paid CFOs, and you don't have a bad debt policy. So when you say 90 million running, I guess the question is on an annual basis from what do your 2022 number look like?
1980.
I will defer to Ms. Engel, Senator Fred Gregory.
And then I will, what's your 2022 number? FY 22.
2022
You did,
for your
outstanding payment.
I apologize that I don't have that number right now with me, but I can definitely get that to you.
So you just have the cumulative of 90 million, the aggregate?
because we have a running AR list that comprises of all of our accounts from a lot of years
Through the
back.
chair, can we get from Snyder Regional a breakdown by year of what the $90 million represents? Thank you.
Yes. Okay, colleagues, we're going to go for a 6-minute round. We're going to start with Senator Potter. Senator Potter, you're recognized for your 6 minutes.
Thank you very much, Mr. Chair. Good afternoon, colleagues. Special good afternoon to Ms. Commission and the team, the leadership team at the Roy Lester Schneider Hospital. CEO Commission, you mentioned in your testimony that you were working on adding services, I believe in interventional cardiology and gastroenterology and so forth. My question to you is, how do we overcome the challenges of recruiting and retaining these specialists to come to the territory to work? What creative strategies do you have in your toolbox that you're utilizing?
Thank you for the question, Senator Potter. Actually, very exciting. I can't announce names yet, but we have 2 candidates, actually a candidate for both interventional cardiology and a candidate for gastroenterology.
Excellent.
That we are in a good point in the discussions with them about joining our team and about the need for this service in our community and our real commitment to building that program for our patients. And so fingers crossed that it all works out and we do have those providers on board this year.
Excellent. That is exciting. I know, it's one thing to recruit, it's another thing to retain. We've had some specialists here before, and they're here for a short span of time, and then they unfortunately leave, which is the name of the game,
Yeah.
But I'm hopeful that you're successful in your recruitment efforts.
Thank you, sir. And I really have to give a lot of thanks and credit to our acting chief medical officer, Dr. George Rosenberg, who is recruiting and finding these very, very highly skilled professionals to join our team and is doing a lot to ensure that when we do get them on board, it's a good fit. They like us and we like them, and that they are well settled into the community here, and that it will be a long-term home for them.
Excellent, excellent. Do you have regular meetings as Schneider CEO? Do you have regular meetings with Wang Louis CEO? I know we have a territorial board, but CEO to CEO, do you guys have, meetings on a regular basis to discuss?
Yes, Senator. CEO Doug Cook and I have a standing meeting every Tuesday morning where we touch base on things that we can do in working together, policy changes that we may want to advance together, how we can, work together for both hospitals, things that our hospital may need that his hospital can supply, and vice versa, and just preparing together to expand services, reduce costs, and do what we can to serve the community. So Doug and I have a great relationship. It's something that we've been building
3 minutes.
since both of us have gotten into our new roles.
Great. I know I was very excited to reading your testimony about your acquisition of Dr. Masorve at the hospital and your outpatient behavioral health initiative that you're moving forward with. I was excited, but at the same time, I know that your gain really equates to East End's loss, and I don't know. I'm trying to figure out what the net gain would ultimately be for the people of the Virgin Islands. But I understand, and we're probably fortunate that you were available to as an option, because he may not have physically been here in the territory. So what is your vision for behavioral health at Schneider?
Sure. So we're so glad to have Dr. Masorve and his team, and glad that we're still able to provide the services, be it at East End or at Schneider Regional, for the community, because we know that behavioral health is so needed right here in our district. So we're glad that Dr. Masorve and his team are on board. That's going to help us to do new things too, group therapy for adolescents, and new treatments. We have a transcranial magnetic chair that you can sit in, stimulation chair, and it's a way for treating depression and other mental health, conditions. So we're very, very excited to having this outpatient program where we can do more to serve the community. Additionally, we have an inpatient unit where we have about 8 staffed beds, and we consistently have between 6 and 8 patients on our inpatient unit, and we provide important stabilization services through our emergency department. So we receive a lot of patients there, and we're able to treat them and get them released directly from the ER. But now that we have the wellness clinic, it's a way to connect them directly to that outpatient care, and it's a way to have more connection on a patient who was in outpatient care, who then needs inpatient care. You still have the providers in the same network who can talk to each other and follow that patient's continuity of care.
I like the positive sound of the wellness clinic as opposed to, the psychiatric unit.
Yes.
I wanted to ask you a question, and I've asked Dr. Hall at UVI this question some time ago. And I asked him about the prudence of us establishing an allied health track at the University of the Virgin Islands. Is there a space for you to have engaged UVI with that type of conversation, given the needs
30 seconds.
In our community for those radiology technicians and lab techs and the like, where there's a demand, and very seldom do you see people that look like us in those roles. Is that something that you see engaging the University of the Virgin Islands in conversation to see how we can further an initiative like that, developing an allied health tract at the University of the Virgin Islands?
Time.
Yes, Senator, I think that's a very good suggestion and a very good thought, and I'd be happy to work with President Hall and UVI on developing an allied health program. We would love to have local Virgin Islanders join that field and come and work at Schneider Regional. I'm happy to announce that actually this past month, I went to UVI along with our lab director, Ms. Francis, and a representative from our AHR team, and we spoke to the graduating seniors in the biology class who have already gotten the core requirements they need to become a MLT, a medical lab tech. And so we made them aware that this is a career path that they can join right in immediately after graduating college, and we're happy to train them up because we want them to join the field. And they were very excited to hear about the opportunity. We got some applications actually from that visit. So we have started that outreach and engagement, not just with UVI nursing, but now expanding that to UVI science. We want to talk to them about IT professionals, about folks in business who could join our finance team and help us with revenue cycle. We see a lot of opportunities to develop that partnership and collaboration with UVI, and look forward to meeting with Dr. Hall on some of those suggestions.
I'm very glad to hear that. Thank you very much for your time, Mr. Chair.
Thank you, Senator Potter. Ms. Commission, I was looking through your testimony here on page 7. You were talking about your mix with your Medicare and your Medicaid and the self-pay. And actually only 19.8% was coming from the commercial insurers, which is, very helpful to become profitable. So I noticed in your testimony you also talked about you needed $250,000 for the colonoscopy screening, etc. Tell me what you're doing to improve this mix. I know that's one of them, but how do we get where more than 19% of your people have that insurance?
Thank you for the question, Senator. For some of the service lines that we will institute, such as gastroenterology, interventional cardiology, we will get a better payer mix just for that service line because folks will elect to come to us who have a different insurance product versus the emergency department or some other areas, some other elective things where persons who live here and who have the commercial insurance, Cigna, et cetera, may choose to go to the States for that care. We are working hard at Schneider Regional to make everything we offer great and to encourage the community to trust us and come to us, and we have great providers. We give good service. So we're working to improve that payer mix, which, as you mentioned, would help us to do all the other things we need to do for the community.
Thank you very much. Senator Carrion, you're recognized for your 6 minutes.
Thank you, Mr. Chair. Good afternoon to the new testifiers that we have this afternoon. CEO, Attorney Commission, I first would like to start by congratulating you and your team. In your testimony, you share that you were able to obtain the full accreditation, and that's commendable. So congrats to you and the entire team there for the hard work of making this possible. Now, I want you to expand a little bit about the services that you intend to expand within the hospital. I saw you mention a little bit about the interventional cardiology services, and if you have a time frame for that. I did see that you mentioned about needing support for the cost of the physician and nursing staff for that. So I would like to know more information what that cost would look like, that whole composition of that new services that you intend to provide.
Thank you for the question, Senator Carrion. So for interventional cardiology services, we would need a few components to get the program running. The one is the provider, which we're already engaged with a very, very highly skilled provider who is looking to join our team. The second is the equipment, and we would need funding for the provider. Just for reference for this body, interventional cardiologists are paid anywhere between $650,000 and $800,000 per year base. And it's a competitive market where it could take 8 months or more to find an interventional cardiologist to join your team. So this is a very expensive but necessary professional to add to our team. So the first part is finding the provider, and we're making great progress there. The second part is the equipment that we would need to actually do the interventions. And from that, through our foundation and the great work of our foundation board, we were able to get a very, very generous donation that should cover the cost of that equipment. And we're buying high quality refurbished equipment that will last us until we get to the new building. And then the last part is building a team. It's not just the physician. We also have to have talented nurses, techs, and other support professionals who are going to support the program. And so we still have to build that out. That's part of the nursing recruitment that we're doing. But we really are committed to building this program. We know how important it is and how needed it is. So with your support, this is something that we could accomplish and really start to provide immediate care for a heart attack in the next 3 to 6 months, which is saving lives and reaching people in a way we're not reaching them right now.
Understood, but do you have a cost of what the cost of everything would be?
So I think the outstanding costs, aside from the equipment, let's say a year of the provider and the supporting, nurse and tech staff, is probably somewhere in the range of $1.5 million, Senator.
1.5 million. Okay, that's information I wanted to have. Also, with regards to your hemodialysis services, you're looking to expand. Can you share with us what you currently have and what that expansion looks like?
Sure. Thank you for the question, Senator. So we currently have and consistently have had 70 patients or so on dialysis in our outpatient dialysis program. We provide multiple treatments per day, Monday through Saturday. So we are actively treating 70 patients. We know there's more demand for care from Schneider Regional for hemodialysis patients. We have a wait list of patients who want to come to us for their services. We have patients who we are discharging from an acute condition who would like to come to Schneider Regional, but we are at capacity. We also get requests from Virgin Islanders who live in the States who want to come home to visit family or come home for a funeral that want to get intermittent dialysis so that they could get it the 3 times the week they're here so that they stay healthy while they're here and can get back home well. We can't offer that right now because we're at capacity. Visitors who want to come here in terms of expanding our tourism product, who want to get dialysis. It's difficult to accommodate these folks because we are at capacity. So there's a lot of value to the Virgin Islands in adding, and to our district specifically, in providing SRMC with the resources it needs so that it could expand its capacity and take care of more patients.
So this expansion includes purchasing 4 additional machines.
So the
but you also need a water treatment system with costs, which the cost is 1.4.
1 minute.
I apologize for the interruption, Senator Carrion. So the 4 machines that we bought are just our existing machines, which there's more than 25 of them, are end of life. We have had to start replacing them as quickly as we can using operational funding. So we've bought the first 4, but we need to replace the remaining machines, and then we need to add new machines. And we also need to add water quality is a huge part of dialysis, and so we need to add that water purification system and water treatment system, which goes along with the individual machines to treat patients on dialysis.
Okay, and lastly, which is a bit concerning, but I know it
30 seconds.
you inherit this, is the fact of your accounts payable, which is currently 28 million. I didn't really see a plan. What's the plan in order to make amends and fulfill your obligations? And if you can, through the chair, submit to this committee that listing. And I know some of it date as far as back when. Could share that information, which is your oldest that you have.
Time.
Sure. So, Senator Carrion, our plan really, we have to increase our revenues and decrease our expenses so that we have more cash to deal with monthly to be able to start paying down some of that AP and to stay current with the vendors that we're receiving service from. So that is part of our plan, and that's why we're adding more profitable service lines. That's why we're trying to improve the payer mix. These are all things to get more cash in the door, which would then allow us to pay our bills a little better and to work down some of that AP that we have accrued over years of not having enough cash to do the patient care that we do. And more funding support from this body, it would be very helpful also in then there being more to work with and paying down those important vendors.
Thank you very much, Senator Carrion. And yes, can you send the details of the 28 million in accounts payable? And also, I'd like to see the 90 million that you have in accounts receivable, because it's obvious what's happening here is the Snyder Regional Medical Center needs infusion of assistance, because I can see how you talk about how you have your meeting and you decide which bill is the most important. That's not the best way to be operating the hospital. So Senator Gitt, point of inquiry, Senator Francis. Joseph, I'm sorry.
Thank you so much, Mr. Chairman. I wanted to follow up on a question asked by the previous speaker relative to the hemodialysis units. I noted that you placed a capital project, about 23 new machines and the like. How much staff do you have to man that department and division? Are you understaffed or are you meeting capacity?
Thank you for the question, Senator Joseph. For now, with the current capacity we have almost a full complement of staff in our hemodialysis unit, so that's great. We're missing 2 staff members that we would need, but to expand any more beyond, even to take another patient, we need to add more nurses and more techs. And so we recognize that it's an area that we have to recruit for if we want to expand our volume to meet the need.
Okay, thank you. I noted that you also had in your testimony that you were in need of a nephrologist as well.
Yes, and that's another position that we have a very good candidate for, that we're in active discussion with, who, if they join our team, would do more than just support the hemodialysis unit. They could introduce new things to the community, like preventative care to people who are needing hemodialysis from getting on it, and they can introduce new modalities like peritoneal dialysis, dialysis at home, other ways for treating patients that have chronic kidney disease. So we're very, very excited about the individual we're in talks with, and we hope we have good news to share with you on all 3 of those recruitment efforts at our next testimony.
Okay, thank you so much.
Thank you, Senator Carl Joseph. Next, we will go to Senator Gittins. Then, following Gittins will be Senator Donna Fred Gregory. Senator Gittins, you're recognized for your 6 minutes.
Thank you, Mr. Chair. Let me see how I'm going to do this in 6 minutes, because, again, I want to start with the proactive healthcare security measures that we've been talking about and the importance of security services at our hospitals. Again, at this time, still following what's going on.
One moment.
There's a feedback on my
One
end.
moment. Media, can you check the feedback on Senator Gittins' mic? While we're checking that, can you hold Senator Gittins' time, Madam Clerk? Media, are we good on St. Croix?
1, 2. I think we should be good now.
Okay, you may proceed, Senator Gittins.
So as I'm saying, as I sit here, I was still multitasking and following what's going on there, and you know, it's unfortunate that the incident occurred. Period, and again, it happened at a medical facility. And here it is, we have the hospitals before us. I just want to ask 2 questions pertaining to this, and then I'll have some sidebar discussions with both CEOs. CEO Commission, how many peace officers, or don't tell me how many. Do you have peace officers at RLSH?
Yes, Senator Gittins, good afternoon. We are very, very proud to announce that Mr. Gideon Garfield, who's our Chief of Security, has recently been sworn in officially as a law enforcement officer, and we're very proud of his accomplishment. And this was the first step in bringing that to the rest of our department.
Okay.
So we're very, very happy.
I don't want you to go too far. Okay, I don't want you to go too far. So you just answered the second question. So yes, you do have peace officers, and you just swore in a chief enforcement officer, is what you're saying, correct?
That's correct, Senator Gittins.
Okay, thank you. So we'll have a discussion on that later on. Now let's go back to the GRS payments that I asked about earlier. When you send these, I'm assuming they're balloon payments to the GRS, are you telling them specifically who these balloon payments are for, or you're just putting down a payment to GRS?
Thank you for the question, Senator Gittins. I will defer to Director Angle to speak to the specifics of the transmission.
Thank you for the question, Senator. When the payments are made to GRS, a lump sum of money is sent together with a listing with all of the individuals' names for that period and the dollar amounts that should be associated with the sum of money that's being sent at the same time.
Okay, I'm receiving contradictory information with that. So again,
3 minutes.
that's a matter that we'll have separate to make sure, because we're being told that the hardship is that you're just making these down payments, but it doesn't specify which employee. And I want to caution you all again that if people's pay stub is stating that these monies are coming out and being paid to the GRS, you need to ensure that the monies are going there. Anything other than that is considered fraud. Page 5 of your testimony, CEO, you spoke to 60% of nursing positions filled. I'm trying to figure out how RLSH is functioning, because in the ER, you only have 6 of a required number of 21 permanent RNs, and in ICU, you only have 7 of a required number of 13 permanent RNs. Of the 6 emergency room RNs and the 7 ICU RNs, how many of these RNs actually are PAFFOD employees?
So, Senator Gittins, to clarify, the numbers that we reported earlier are the number of permanent staff that we have employed. We complement up to the full amount that we require for safe patient care with agency nurses to include Pafford and other agency vendors. So we have a full complement of nurses in our emergency room, in our ICU, but the complement is broken down as a portion as fully employed permanent nurses and a portion as contract. And we're trying to get more fully employed and reduce our number of contract nurses so that we can improve our cash position, have more stability in the care we provide, and build our permanent team.
1 minute.
Okay, I don't want the time to be eaten up. I just want to be clear. 6 nurses, RNs, permanent RNs in the ER. Of those 6, how many are Pafford employees? Are they
None.
Pafford employees?
No, none, because all 6 of those are fully employed by Schneider
none.
Regional.
It's okay. It's okay. No,
30
none.
seconds.
Thank you. That's what I want.
Okay.
I also need to know the average wait time to see a doctor in the emergency room, and I wanted to get from Mr. Smalls with regards to him stating that the entire hospital has met criteria for replacement. I wanted to know how he envisions this going forward, and will the hospital be constructed alongside the existing facility, and how many beds will be at this new facility? So start with you, CEO, first with the average wait time to see a doctor in the emergency room.
Time.
Yes, Senator Gittens. I would like to have Dr. Delphine Olivaci respond. We track our ER wait times for regulatory compliance, and so she has that data.
Yes, good afternoon. Delphine Olivaci, Chief Nursing Officer, Schneider Regional Medical Center. So when we look at...
Can I see this person? I'm not seeing the person online. Can the camera...
Media, can
you
you recognize Ms. Delphina?
Yes, good afternoon once again. Senator Gittens, thank you for the question. Delphine Olivaci, Chief Nursing Officer for Schneider Regional Medical Center. So we do track on a monthly basis the wait times in the emergency room. And so from the time the patient presents to the emergency room, the first triage process is that they see a registered nurse. The goal for that wait time is about 45 minutes. Right now, our wait time averages about 60 minutes from the time the patient enters the emergency room to the time they see the registered nurse for triage. From the time the person presents in this triage to the time they actually see a physician is very dependent on the census and the acuity. We don't see patients based on when they present to the ED, but their acuity, which could be impacted by ambulance services, other critical patients, gunshot wounds, and so forth. But on average, it is about 3.5 to 4 hours between when they actually come to the emergency department and are evaluated by a physician. That's about the average.
Thank you.
You're welcome.
Mr. Small.
Good afternoon, Senator. The plan is the Roy Schneider Hospital, as we said, will be completely replaced. Yeah. The strategy is how do we construct a new facility on the campus. We're going to continue to exist in the existing hospital, and then once completed, then transfer the patients into the new facility. In terms of a bed count, that has not been determined as yet. What we're going to do is we're working with the census here in the territory, looking at the census here in St. Thomas, St. John District, and that will help us to formulate the actual bed count. Both facilities, like I said, were built as 250-bed facilities. I'm not sure what the average daily census is right now, but that will be a major factor in determining the number of beds that we will ultimately construct.
Yes, thank you, Senator Gittens. And again,
okay. Mr. Chair, allow me to just close out. Thank you.
Okay, you may close out.
Thank you for your. Thank you. 250 bed facility. So thank you for that, and thank you for the latitude, Mr. Chair. Hopefully, at some point, I'll hear something about the mental health wellness clinic that the CEO spoke about on page 2. Thank you.
Mr. Chair, can I provide clarification? I
Yes,
don't want
you
the
may.
senator to walk away and say that
Yes,
I
you
said
may.
250 beds. I said the current facility is 250 beds. A determination of what the new hospital bed count is going to be based upon our average daily census and what the census of the territory forecasting out to about the next 10 to 15 years.
Yes, Senator Gittins, did that answer your question satisfactorily?
So I guess I'll have to ask if there's a possibility of that number being reduced then.
I would say, based on what we're looking at here in the territory, I do not see us constructing 250 bed facilities, but that is yet to be determined.
Okay.
Thank you. Thank you, Mr. Chair.
So you see, the future for the Roy Lester Snyder Hospital looks bright. We just have to be able to make sure that Roy Lester Snyder can sustain itself and keep its doors open and provide the care in the meantime, because we're talking about, I don't know, maybe 7 or so years, 5 years, whatever, but it's not going to be tomorrow. It's not going to be next year. Senator Donna Fred Gregory, you're recognized for your 6 minutes.
Thank you. Thank you, Mr. Chair. The previous speaker in St. Croix asked a question about the average wait time, and that response is extremely concerning. I want to make sure that I heard 4 hours. I read your testimony on page 14 as relates to the plan to address it, but I'm not certain that that's a clear plan. I know that the JFL folks were here earlier, and they spoke to an hour 45 to 2 hours. So, Attorney CEO Commission, you share that you speak with the CEO on a regular basis. I believe you said every Monday.
Every Tuesday.
Every Tuesday.
Mhm.
So, what type of conversations are you having around this? If we're having a 4-hour cycle in and out, on average, and that's average?
Senator, I certainly agree with you. It's too long. I think Dr. Olavachi is tapping me that she wants to clarify the number that she provided.
Please,
So let me
because
let her do
is
that,
not
please.
a
Thank
good
you.
look.
Yes.
Agree.
So we need clarification on that, please.
Once again, thank you for.
And don't be long-winded, because my time is running. So please be.
So for
succinct.
clarification, once again, it is based on acuity, depending on what the patient's presentation is.
No, don't do that to me. You said that already. Don't do that. This is what we're going to do. What is the average wait time? On average, you have different scenarios, but what is the true average wait time?
The true average wait time before a patient with low acuity is seen by a physician.
Give me the
is
average
3
wait
to
time
4
in
hours.
cumulative, please. I don't need to know all the ancillary stuff, because that doesn't do anything for me.
4 hours.
So it's 4 hours.
So part of the plans that we discussed, Senator Fred Gregory, is that what we need to do is get to seeing the patient sooner, getting to do their diagnostics sooner, getting their labs done sooner, their x-ray done sooner. We're going to have the nurse-driven orders, standing orders
so
there.
All of that stuff is outside of my school.
Okay.
The issue here is, how do you fix this? Because when do you intend to fix it? We had a conversation with you a few weeks ago, early in January or February, and that was also a discussion. So I expected to hear that you are well on your way to addressing this. So I'm not going to stay on it any longer. The expectation is that, because if you're having a 4-hour wait, that's mean you're turning people off from coming to the hospital, and then people are dying.
3 minutes.
So that's a problem. Right.
I certainly agree with you. I agree with you.
Okay,
we have
so-
made some progress since we've gotten the committee meeting. We've looked at the holes. We see where the opportunities are.
Thank
We've
you.
got testing down.
Let me ask my questions, please, because she
Yes,
just said 3 minutes out of my 6. So let me first congratulate you, second congratulate you on the fact that we did a site visit with you in, I believe it was February.
Yes, ma'am.
And there was a concern that I had in particular with regards to the behavioral health unit and the lack of their ability to come out for rec. And I've since learned, based on your testimony, that matter has been resolved. So we know that you hear us, and the conversations that we have are, we're seeing results from them. So congratulations to you and your staff for that.
Thank you, Senator.
Okay. Now, what is your ideal number of staff physicians, meaning in every category, internal medicine, cardiologists, all of that? Do you have a chart? One of the things that we got from GFL was an actual chart of their proposed, their current, and their need, and of course they shared with us physicians with privileges. So,
sure.
What's your what do you look like right now?
So I have that list also, and I can share it through the chair. Specialties we currently staff: anesthesia, cardiology.
No, don't
ER.
give it to me later.
Okay.
I just need numbers.
We have approximately 50 employed medical staff members.
What
maybe
is
a
your
little
need,
less than
though?
that.
What's your ideal need, and what do you have?
I'll be happy to get that number because I want to give you the exact number. So I'm happy to forward it through the chair, Senator.
All right, cool. Okay, so let's talk about your. There was something that's still not clear for me, and that's around your uncompensated care. So, I'm certain that your emergency room has a presumptive eligibility lead or a person that's there to qualify and or to help to fill out the documentation, etc.
1 minute.
In the discussion that we had earlier, as it relates to your liabilities, your receivables. You spoke to, there was a high number that you spoke to, but what is your current annual uncompensated care amount?
Thank you for the question, Senator. And as you mentioned, we do have presumptive eligibility in place. Actually, all of our patient access reps are trained on that. So we do try to qualify everyone, but
Wait,
so
hold
many
up,
don't qualify.
Please
30
just
seconds.
answer the question because my time is running. The question is, what is that number? What is your presumptive eligibility number? Sorry, your uncompensated care.
Our uncompensated care number, depending how you calculate that, if you include charity, bad debt, underpayments from Medicare, Medicaid, is like
Annually?
$39 million annually.
Okay.
If you're including the underpayments.
So this is what I'm going to ask from Roy Snyder. Y'all have to provide us with more direct information because the information that we're receiving is very unclear. Okay. The information that we received from Wang Louis was very straightforward. So we need to know what your uncompensated care numbers are.
Time.
Please. That's still not clear. We're making a lot of assumptions, and that's unclear. And the reason why I asked the question is because you talked about a $1.5 million deficit, and that's your monthly deficit. Mm-hmm. And you're asking the legislature for additional resources. Mm-hmm. May I continue, Mr. Chair?
Yes, Madam.
You're
You may
asking the
proceed.
legislature for additional resources, but we need to first understand what your uncompensated care amount is. What are you doing about it? As far as what your billing practices are, there are certain things that we have to be clear on before the legislature can say, we're giving you this. We must know that each hospital in their respective place is doing all that they can do to collect the resources. And that's not clear coming from Roy Snyder in particular. So that's something that's important to me. Now, let me ask you one more question because my time has been called. I had a few more questions, but I'm just going to ask this last one. And that is related to, oh my goodness. Yeah, your strategic plan. So, do you have a strategic plan?
Yes, Senator.
And when I say strategic plan, I'm talking about a strategic plan around providing medical care in particular. Do you have a hard strategic plan? Is it a strategic plan that's being discussed? Is it being updated? What do you have in place currently that's tangible?
Yes.
That we can look at as it relates to a strategic plan. So I can have an idea and my colleagues can have an idea as to where you're going.
Sure, we do have a strategic plan. I'm happy to share that with you. I'm also happy to have the additional discussions that you recommended so that we can demonstrate to you all of the hard work that's happening at Schneider Regional to help ourselves bill and collect more, to show you where even though the presumptive eligibility program exists, we can't enroll everybody who shows up uncompensated.
Absolutely.
And so we
Yes.
can demonstrate to you so that there's a comfort from this body as to the true need for the community in terms of healthcare at Schneider Regional.
So do you have information around those who are self-pay?
Yes, Senator.
Okay, so through the chair, we also need that information, what your self-pay is and what your Medicaid-related, of that amount, which we don't really know what the amount is. What are the ones that are truly self-pay who did not qualify for Medicaid?
Okay.
So that's information that's very necessary before we can begin to talk about we have this need, we have that need. We have to know exactly what does this truly mean for us. Okay?
We're very happy to share that
All
with you,
right.
Senator. Thank you.
Thank you. Thank you, Mr. Chair.
Yes, thank you, Madam Fred, Senator Fred. In addition to that, remember we also needed the details of the 28 million accounts payable and the 90 million accounts receivable, because I think we have to take a very close look, because from what we're seeing here, there is definitely more information that's needed, but we're seeing that you do have some financial needs. I want to talk, actually one quick question before we go to Senator Balkis. The borders, you have how many borders now? 13, 14?
Senator, we currently have 13 borders.
13 borders. And there's one of them that has been a border since 2018, and they have a bill of about 2.5 million.
That's correct, Senator.
What's the solution for that patient? Where do they need to be?
I'll defer to Dr. Olivaci. Of course, we have to be very sensitive about specific patient information
we don't
that
wanna,
we share. But it's really
divulge.
that there is not an appropriate discharge placement option for this patient.
What, they
There's
need
not a
long-term-
facility on island to provide the level of care that they need, and there's no contract set up or a location already contracted for to discharge this patient to.
So they need long-term care, ambulatory, assisted living. What's the status?
I'll defer to Dr. Olivaci for a little bit more of the clinical specifics that can be shared.
Okay.
Yes, just for a very
I can't hear you. Can you speak into the mic?
for a HIPAA compliant response.
You can't.
The patient, and not only that patient, but others, require long-term skilled nursing care, such as the care from a Seaview or a nursing home.
So you've
which-
spoken to Human Services on that, and
Yes.
what's the conversation? Where are we at?
So the conversation with Human Services is that we're working very closely with them to try to, this particular patient, to place them in a facility that can meet their needs that
Okay,
are
so let's
long-term.
have that conversation off the record
Yes.
because of the HIPAA issues.
Thank you. Yes.
Tomorrow, yes. Senator Donna Fred Gregory, you're recognized for your point of view.
Thank you, Mr. Chair. So I'm glad that the issue with the borders came up, because that was one of my questions, but I had to move along. So this issue with the borders and our hospitals, and particularly with Royal Snyder Hospital, because I had a personal experience. The problem is Department of Human Services is refusing. Just say it. It's okay to say the truth. They are refusing to take responsibility. The law is clear between the Virgin Islands Department of Justice and the Department of Human Services. What's happening here with our hospitals should not be happening. That's the issue. And it's really okay to say that that's the issue. Am I correct?
In some
Yes,
cases,
yes.
yes.
Yes, and that's a problem, because there's a lot of hoops you have to jump through, and there's just a whole lot of things that you're put through to deal with this. And if you have individuals who do not have anyone externally to provide that support, then our hospital is stuck with it. But my question that I have to ask is, so there's bills, $2 million, this million, X million dollars. So where does the Medicaid come in? Who's filling out that paperwork? If they don't, the issue is the hospital can't fill out that paperwork for them. So the hospital is stuck while Human Services is not filling out that paperwork. So what's happening there?
Yes, and we have no ability to collect from Medicaid after their acute portion is done. So we don't have an ability to receive payment for their care, Senator, and we don't have an ability to place them anywhere else. They're truly not acute care patients that are in the scope of our responsibility, and it's not what we get funding for. But we are shouldered with the responsibility of caring for them and continuing to absorb all the expenses while not receiving any funding to
So
support
break that up. Help me to understand that piece you just said about after the acute.
So we only get paid for the first, in most cases, 30 days of the patient's stay while we're handling the acute care issue. But after that, you don't get anything for keeping them there because the insurer does not recognize that as a place they need to be and does not recognize it as a valid claim. And so we receive nothing for all the care that we are giving. And it speaks directly to the earlier point of why is your ER wait 4 hours long? Because we can't move the patient from the ER up to the bed because there's a border in the bed. So the patient waiting in the front of the ER can't come to the back of the ER to be seen by the doctor unless you're going to put people in the hallways. So we really have to relieve the hospital of the borders so we can move patients to the floor and have a better throughput through our emergency department. It's part of the problem.
So this is why it's important that when you provide your testimony, don't worry about who's offended. Tell the truth. The issue here is you are not getting the support from Human Services. That's the issue. So you're right. That's why you have a 4-hour issue, because you have folks that come to your emergency room who's there for 5 days who can't get a bed. That's the problem. So you have to put it on the record. Thank you. Thank you,
Yes.
Mr. Chair.
Thank you very
And
much.
I think
for,
Dr.
Yeah.
Olavachi wanted to say
thank
something.
you. I just wanted to, that was one of the comments that we were going to make. This week we had 6 patients in the emergency room with admission orders that we could not place in the inpatient bed because we have 7 boarders on the medical unit, 3 boarders on the surgical unit. Thus, they have to wait outside, and that is why there is that 4-hour time period. If we could move those patients to an inpatient bed, we would, without a doubt, be able to meet the national standards.
Very, very good point. Let me just follow up on that. One other question. Of the 13 borders, we discussed that one that's there. Are there any others with a similar situation that really need to be attended to by Human Services? Are there any of the other 13 that fall in that same category?
A number of the patients that we have, Senator, as boarders presently do need the assistance of placement through either Department of Human Services, and for some of the patients that have a behavioral health condition, they need the placement through Department of Health, yes.
Okay, so we need to talk to Human Services on that post haste. Thank you very much, Senator Fred Gregory. Senator Bolkis, you're recognized for your 6 minutes.
Thank you, Mr. Chair, and good afternoon, colleagues. Good afternoon, testifiers.
Good afternoon.
The growing crisis in the uncompensated healthcare system poses as one of the most severe threats to the medical profession today. And if left unresolved, it will only erode the health of our society and the erosion of the principles for our healthcare system providers that, accessibility is what is built upon. Healthcare systems are founded on that with universal access, and our people should have that full access to that premium healthcare system and the services that it offers. And while I understand it's challenging, I regret to say that the residents of St. John have not had their fair share, and have experienced many shortfalls for decades concerning that access. And I want to start off because in the previous block, I mentioned the helipads, and I want to follow up on that right now. When was the last time that we've had an air care provider contract for those helipads? When was the last time?
To my knowledge, there's never been any in the territory.
Okay, very well. What is prohibiting us from executing such a contract with such companies or a private entity that is willing to supply us with the carrier service? What is prohibiting us from doing that?
I don't know of anything prohibiting us, Senator Bolkes, good afternoon, from engaging and looking at that as an option for transporting patients between St. John at Myra Keating and the main hospital, Royal Leicester Schneider Hospital on St. Thomas. We have helipads working at both locations, fully functional. We have used them in an emergency. We would use them today in an emergency if we needed to. But the regular mode of transportation that's been established actually is a coordinated effort with Department of Health, EMS, now Fire EMS. And so the transportation of patients happens via the ambulance boat. That's been the modality that's been studied and has worked traditionally. We are open to something new.
Understood. We have lost an individual because of the inaccessibility of the ambulance boat. And if in fact we had a helipad or the option thereof, we may have been able to save that person's life. So I still think we need to look at it from a proactive approach. I would really love you to please work on that. It's very
I'm happy
important.
to do that, sir. Both are functional. So if we find a provider, we are totally willing to entertain that.
Well, let's get it done.
Okay.
Let's get it done. So you mentioned also that there's a transcranial magnetic chair. Is that donated or purchased?
We're actually leasing that piece of equipment right now so that we can continue those treatments for the community, and we're going to continue to look at some point if we replace that or
So,
what we
so
do
I
with the lease.
understand it to be a device that is used for depression.
It can
So
be used
are
for
we
anxiety.
cutting out counselors and therapists from helping with depression by the utilization of that chair? And let me tell you why I'm asking this
Sure.
question. Because there is no dialysis chair on the island of St. John, okay? And patients have to traverse from St. John to St. Thomas at least 3 times a week. That includes boat, parking, taxi, expenses thereof. And I'm trying to figure out what is the alternative. Why aren't we supplying them with that option on St. John? I heard home dialysis. Tell me what is required with that. How can we materialize that option?
Sure. So I'll start with dialysis. For dialysis, we had one patient from St. John, I think, actively enrolled in our hemodialysis program. We are looking at new ways to provide dialysis, and that may be an option for St. John residents as we move forward. To have a machine and the staff, you would need a nurse, a tech, you need the RO system, you need the water purification. There's a whole lot that goes into a chair.
Of my time, I don't mean to speak over you, but
No problem.
because of my time, I totally understand that. But the home dialysis that
Could
you
be a
brought
good
up,
option.
let's see if we can get that done as soon as possible.
We
and
would
save
love to make that an
please.
option, yes.
Okay. So my office and I have also been receiving a number of what I would categorize as complaints reporting upfront payments by patients for obligations being required prior to procedures, even with insurance, right?
Yes.
And including one of my staff members who's been dealing with it since January. And they're being told that the entire obligation has to be paid upfront, which is several thousands of dollars, before they can be billed or placed on any sort of payment plan. Now, similarly, I understand, if I can use this as an example.
1 minute.
A woman who is pregnant has also obligations, their family, to have a bed. You have to pay the $1,000 for the bed or something like that in order to have a bed before they can even go through the intake service for that individual to have a baby, right? But we're not really talking about that. I understand that the hospital needs to have that obligation of finances. But why is it so...
30 seconds.
Why do they have to pay $5,000 to $10,000 upfront for another procedure? And why can't they just... Why are you walking away from a $35,000 procedure because of $5,000, which...
Sure.
Why is that why is that happening?
Great question.
Is there a policy?
Yeah.
Can I get a copy of the policy? Explain that to us.
Great question, and thank you for asking the question. We are contractually obligated to collect the co-insurance. So our obligation to Cigna, for example, is we will collect the co-insurance from the patient if they're going to have this elective procedure. They have to put some skin in the game. And we are happy to put patients on a payment plan to accomplish that. And I'm happy to look into that specific situation and the patient you're talking about. But there is an obligation that the patient has to meet. And we are contractually obligated to enforce that.
So that obligation is an immediate obligation? Can they have a
It can be done
payment
over
process?
time, and it can be done via payment plan, and it should have been offered. And if it wasn't offered, I'm happy to look into that case because we can offer it, and we should have offered it.
I appreciate that. Mr.
Yeah.
Chair, may I please ask one last
Yes,
question?
you may, Senator Bogus.
Thank you, Mr. Chair. I appreciate it. Patients are also receiving bills to the hospital due to claims which have not been processed timely, if I can say it that way, which includes like the VA clinics and so forth. What is being done to address that? Because they're seeing late fees because of invoices not, or allegedly not being processed timely.
So let me respond to that. But 1 second, because I think your last question was really, really important, and I missed a big point on it. We are the government hospital. This is a person with Cigna government insurance. Why are we have such a big copay to have your service done at the hospital? We have to work with the plan. We have to work with the GESC to make the hospital, to incentivize that care to be done at the hospital. And when you have a big copay like that, it disincentivizes you from coming to the hospital. And that copay is in place for even things like preventative screening that we're trying to encourage that saves the plan money. So we need to ensure that as the government, we are creating a plan and a program and an insurance product that encourages people to use the government hospital, and that then helps to change the payer mix. So it's less money the government has to give to support the government hospital. It's less money that needs to come in an allotment because now we're able to help ourselves better because we have a better payer mix. But we have to incentivize people to come there. Us, by providing a better product, a great product, good health care. And structurally, we need your help and others' help to create structural incentives for that. So I wanted to go there. I'm sorry.
That's okay.
I went there
But
first.
for the timely processing.
Timely processing, we have to do better at dropping bills, following up on bills. Some people get calls from an entity associated with us that sounds at times like a collection agency. They're really a third-party extension of our business office that's helping us to follow up on bills. We have to get better at sending out our own bills, following up on them timely, and processing getting as much cash in the door for the good work we're already doing. We have to put a focus on that in revenue cycle. We have been, and with that focus, we've seen our collections grow from an average of $3.5 million, $4 million a month to now well exceeding that. So our goal for going forward is even to get up to $6 million a month as we continue the work in creating more profitable service lines and doing better with our collection activities.
Okay, thank you for your answers. I appreciate it. And Mr. Chair, thank you for your leniency.
Yes, thank you, Senator Bogus. Senator Carla Joseph, you're recognized for your 6 minutes.
Thank you so much, Mr. Chairman. A pleasant good day to everyone. And I really want to commend you, Mr. Chairman, on your first meeting. You're doing a good job and just keep up the good work. And also to commend the team at Schneider Regional Hospitals because you've been doing some really exemplary work here. I really also want to commend the leadership team for being able to recruit Virgin Islanders and to bring them back home. And that is very good. I want to touch basically on your executive staff. I noted you had some promotion. Ms. Angol, you were before the financial manager, and now you are the director. Congratulations to you, as well as Mr. Peter John Baptiste, the Vice President of Facilities. You were last year the interim. So I like to see when our people are placed and elevated based on their work, it keeps them here, and that's what we want to try to do our very best to keep our talent. But I noticed Dr. Olavachi is now the Chief Nursing Officer, and prior to that, she was the Vice President of Quality, what is it? Quality for the, Vice President of Quality and Performance at the hospital. So is Dr. Olavachi fulfilling dual roles presently?
No, so we're very, very proud of all three of our executive team members that you mentioned. They're very committed, hardworking employees who really demonstrate high levels of leadership and are taking our organization in the right direction. So I'm very, very proud to work with each of them. And Dr. Olivachi is a very accomplished nurse who's worked in almost every unit, came here as a travel nurse and stayed and made it home, made it her home. And so we're very happy to have her in that spot.
Attorney Commission, because attorneys like to talk a lot, but just try to be succinct.
Sure.
So she's not filling dual.
No, there's a director now there's a director spot that we will be filling for quality and performance improvement, which will report up to her in the chief capacity.
Okay, good. And you mentioned that your acting medical director, Dr. Rosenberg.
Dr. Rosenberg, George Rosenberg.
Okay, good. I just wanted to make sure I have those notes. Now, I've been to a series of meetings with our veterans here in the Virgin Islands. And what is happening now, that the veterans were having some challenges getting their lab results. Is there an update that you have with Schneider Regional Medical and the veterans relative to them being able to get their labs taken and then those results being transferred to their primary physician or whatever specialty physicians that you have?
Yes, Senator Joseph. So we've had multiple conversations with the VA to try to work out both the authorization process and then also the results sending process. I know as we move to Meditech Expanse, it's going to be so much better for patients to be able to get their own result and for the hospital to be able to directly send the results from labs and imaging to the primary care provider. So we're
one moment.
We're very
close. So the Meditech is able to interface with the VA, their system?
Now many of these advanced EMRs have common ways of talking to each other. So when we move to Meditech Expanse, there will be a way for us to link with the VA system and transfer patient information to them directly.
Okay, I listened into the presentation earlier and they indicated it will be coming live at least for St. Croix next year. When is our time slated? Are we slated to come live in the first quarter? Well, I'm looking at the first part of next year.
We're hoping to accomplish it in the last quarter of this calendar year. So yes, we're closer to our implementation.
So that's good news because, some of my colleagues were saying we were a little bit behind of St. Croix, but I'm glad that on the technological end, we are advanced. Perfect. Now, I wanted to also talk to you a bit about the amount that was stated by Ms. Angle relative to the amount that we have in the bad debt. How much that amount was? Was it $5 million, Ms. Angle?
1 minute.
For the current fiscal year, about $5 million running total as of March.
What
Over $5 million.
What is the total aggregate amount?
For fiscal year 2023?
No. Well, you said for fiscal year, and this runs back until what years, as far as the bad debt?
For the $5 million, that's from October 2022 to currently March 2023.
And do you have previous year bad debt as well that you've just written off and said no, that we're not going to look at that?
We currently right now have, we've identified over more than a large amount of accounts that we've recently marked off as bad debt.
Okay, so we're going to need to get that information. We need to get that detail on the amount of bad debt because that is another issue. Now, what mechanisms do you have in place to collect some of these account receivables that you have outstanding for the years? I know you had a really aggressive contractor who would call people, Mr. Chairman, if I may.
Yes, you may.
Thank you kindly. Who would call individuals to be able to collect monies. Do you still have a collection agency that you're working with?
Yes, Senator Joseph. I'll defer to Ms. Angle to give the specifics, but we do have an extender to our business office that helps us with that collection. It's a third-party vendor.
Okay, and how much have they been able to collect for you over the past 2 years, if you're able to give us any of that? Because that's part of your bad debt, and you have this reoccurring. So do you need to send it to the chair?
Yes, we'd be happy to send it to the chair, please.
Okay, all right. Thank you so much. Mr. Chairman, I do have some other questions, but my time has been called, and I want to thank you for the latitude.
Thank you very much, Senator Joseph. Senator Gittins, you're recognized for your 2 burning questions.
Thank you, Mr. Chief. I want to go back to my good friend with the big title, the THRT. What's that? Territorial Hospital Redevelopment Team, right?
Yes,
so I was asking you earlier about the rebuild of RLSH. And you stated that you didn't want me to tie the 250 beds to this project. However, now I'm getting a little concerned whether or not this will be reduced. But I'm wondering how we don't know at this point what it will be when we're hearing that FEMA will give you a response by, I think you said June 2023, that's next month. So what are they giving a response to if we don't know how many bed facility it is that we're planning to build?
Senator, how FEMA approaches this? The hurricane damaged a 250-bed facility. FEMA is basing their cost estimate or fixed cost offer on a replacement for a 250-bed facility.
Right.
Until we know the dollar amount that we're going to receive, it would behoove us to declare that we're going to construct a 100-bed, a 150-bed, a 250-bed, because we don't know the dollar amount that we're going to receive.
But I guess where I'm not clear is if they're planning to give us a full replacement of a 250-bed hospital, then the full replacement is another 250-bed hospital.
Senator, I understand what you're saying, but it does not necessarily equate to the dollar amount of what it's going to cost to construct a 250-bed hospital in the United States Virgin Islands today.
Okay. I guess we could discuss that later. And the last thing is the cancer center that you spoke about. You believe that December 2024 is a realistic date? Where are we exactly on this project at this time?
Senator, we have just recently completed the selective demolition of the facility. That solicitation is currently being advertised with a due date of June 14th, after which we will, as long as we receive a responsive bid, we will award a contract to that responsive bidder with a time certain for that project to be completed. We have an estimated schedule of how long it should take, so that is why I stated on the record for December of 2024.
No problem. Just asking if it was a realistic date. So the answer is yes. I trust what you're saying. Thank you, Mr. Chair, and I'm still waiting to just hear from the CEO with regards to the mental health clinic that she spoke of on page 2.
Okay,
Thank you.
You may proceed on the chair's time, Ms. Commission.
Thank you, Chair. Senator Gittins, we're very, very excited about the wellness clinic that we have established at Schneider Regional Medical Center. We have a team of clinical providers to include Dr. Zen Maservi, a psychologist, a therapist, a licensed clinical social worker, and they're really going to be providing wellness treatments, mental health treatments, behavioral health treatments to our patients. They're going to be doing counseling and therapy and group sessions, working with our youth, and just working with persons with a variety of behavioral health, mental health conditions. We named it the Wellness Clinic because we want it to be very stigma-free. We know many people need support and help in this area, and we want to make it a very welcoming place, non-judgmental, really just providing the care that our community needs. So we're excited about that program, and we're really glad we were able to bring that online.
Thank you. Senator Donna Fred Gregory, you're recognized for your point of inquiry.
Thank you, Mr. Chair. I want to go back to the outstanding 28 million? Your payables? What period does that extend to, back to?
I'll defer to Ms. Engel, but I believe that's also a cumulative running total. Ms.
How
Engel?
many years?
Thank you for the question, Senator. That 28 million goes back as far as, I'd say 2004, 2005.
So this is 2004, that's what?
19 years.
19, 20 years? And how are you making decisions as to how to make these payments?
So regularly, our executive team meets every Wednesday to discuss the feasibility of what we can do with the cash in hand. Oftentimes, we run into cash flow issues, and we identify critical vendors that are sustaining staffing or supplies need that the hospital would currently need to continue sustaining its patients.
Is it safe to say that you're currently not paying any of your 28 million because of the testimony that you shared earlier, where you indicated that on a monthly basis you have a $1.4 million deficit?
That is accurate.
Yeah. How many? So you are the interim CFO, correct? No?
Senator Fred Gregory, we have a vacancy still for our CFO position, but Ms. Kenesha Engel is serving as our Director of Finance and assisting us in a very strong way in our finance department.
I want to thank her, but I'll tell you that the Snyder Regional has had many CFOs over the past couple of years, and clearly we need to hire a CFO that understands the importance of moving us out of a insolvent situation, because that's what we're experiencing here. We've been primarily focusing on what's happening at the Virgin Islands Water and Power Authority, but you have some challenges here that we really need to figure out how we are going to resolve them. I actually packed up my stuff to leave and realized that we didn't really drill down on this $28 million. This is not something for us to ignore. So Mr. Chair, I am the chair of the Finance Committee, but I believe from this committee's perspective, we need to have a further discussion around addressing this issue. Our hospitals, the work that they do are critical to our living. So if they have a $28 million issue, I'm not certain why we're not getting any requests, not from you, but from the executive branch saying, hey, we need to try a lifeline to these folks. So we have to drill down on this a little further. So, Mr. Chair, I believe that we need to have some sort of a behind-the-scenes conversation to really figure out how do we provide some supports to our hospitals. And I'm certain that the GFL have similar issues. It just didn't come out in the discussion today. So thank you, and this is a serious matter.
Yes.
Thank you.
Yes, thank you.
Thank you, Mr.
Senator Fred. I fully agree. The testimony here today shows that we really need to throw out a lifeline. As a matter of fact, it should have already been thrown out based on what we're looking at here. But, I wanted to go back real quickly onto the testimony that we received here today from Mr. Christopher Finch. And I'm going to read his testimony. It's relating to the border issue. He's saying here, and I quote, "Our border issue is directly related to the lack of long-term care beds in the territory, and it's a long-standing problem. He became aware of the local shortage of long-term care in the 1980s when he was with Lutheran Social Services." And then he goes on to give us a chart. Herbert Grigg Home for the Aged. In 2017, it had 40 beds. To date, it has 25. That's 15 less. Queen Louise Home for the Aged, in 2017, it was 30 beds. Today, it's 17. That's 33 less. We also had Seaview Nursing Home, which had 25 beds. Today, of course, it's 0. So there's a total of 53 long-term care beds that we have lost. But in addition to that, Based on the Federal Health and Human Services report, it's saying that based on your elderly population over 65, you should have 3% of that number set aside in bed. Well, that number is 18,541. We have 18,541 people living in the Virgin Islands that's over the age of 65. That means we should have 556 beds, long-term care. Guess what, ladies and gentlemen? We only have 53 long-term care beds. We are 503 beds short. So, the way you treat your elderly population reflects a lot about your society, because, the elderly population have given their lives to this community. Some of them have worked hard. Some have gotten into an unfortunate situation where in this stage of their life, they now need help. They need assistance from the community, and this is what we're doing. We're shortchanging our elderly population. I'd like to give my condolences to the family of Alric M. Thomas, employee of the Public Works Department that unfortunately was involved in that shooting incident in the Carnival Village, outside of the village last Saturday, and lost his life. A 50-year-old guy was working. And of course, this is also a problem in the community, the gun violence. So at this time, I would like to ask the testifiers to please give us a one. Oh, I'm sorry. Bulkis went, yeah. Okay, Senator Carla Joseph, please go ahead for your burning question.
I'm so sorry, Mr. Chairman. I was out conducting some business with a representative here that I needed to talk to urgently. I wanted to ask one very probing question regarding the behavioral health. With your behavioral health, I know you stated you have some boarders who have behavioral issues. Are you interfacing with human services regarding having those persons maybe transition into a behavioral health facility or a facility that can house them properly? Have you had those discussions?
Yes, Senator, we've had those discussions both with the Department of Human Services and with the Department of Health. The three patients that we have really probably are to be placed more by Department of Health on the mental health side.
Okay, so where are we with that? Because I noticed your borders have increased by 3. Now, I don't know if it's a behavioral health that increased from 3 from last year, because last year only was 10.
Yeah.
Okay, and now you have 3 additional borders, which is taking up beds, which is causing you to have a long waiting time in the ER, all of those things. So where are we with the discussions? Is it that they are not urgently moving on these items?
We meet every Friday, Senator Joseph, with a high-level group of stakeholders about the border issue. And unfortunately, we are still waiting for some movement and new contracts and new
So we are
funding to
waiting
be
for new contracts?
We're waiting for expanded options for discharge, which have to come from other entities.
That's Human Services end.
And health for the mental health, behavioral health
So this
patients.
committee chairman, I'm sure he's going to be calling those individuals in, because it's very critical. You see, housing, and we're just looking at housing, low and moderate housing, affordable housing. But housing also includes long-term care. Housing includes behavioral. All of that is housing and being able to care for people. So those are very important items that we really need to focus in on, because we are, based on the data that the chairman just related, we are going to be in a major crisis when this major silver tsunami hits us for real. Thank you so much, Mr. Chairman.
Thank you very much, Senator Joseph. Okay, so at this time, I'd like to ask that you give us, the testifiers, a 1-minute summary of your presentation.
Thank you so much, Honorable Chairman Ray Fonseca. Thank you. Good afternoon again. to all the esteemed members of the Health, Hospitals, and Human Services Committee. We really appreciate the excellent dialogue we had today. It was a pleasure to respond to your questions. We really thank you for your support, and we look forward to having additional discussions with you on the items that we talked about today. Thanks for an opportunity to present an update on the progress that's being made at Schneider Regional Medical Center, which includes both the Royal Leicester Schneider Hospital on St. Thomas and the Myra Keating Smith Community Health Clinic on St. John. We hope that our presentation today has demonstrated that there's a very bright future ahead for Schneider Regional Medical Center, and we hope we demonstrated that we are remaining steadfast in our commitment to providing quality healthcare services to our patients, our families, and the community, despite the challenges that we face. At SRMC, we continue to make significant strides in recruitment and retention, on expanding our service offerings, updating our technology, improving our financial stability, and maintaining a clean and safe environment for our patients and staff, despite the fact that we are operating in an older hurricane-battered facility and have multiple other challenges that have been presented since COVID-19. We are dedicated to ensuring that our patients and staff receive the same level of quality or better than they can get anywhere, including on the mainland. We're continuously improving, and with the help and support of community members, this body, and other partnerships, we will make additional investments in modern technology to be able to provide critical life-saving care to our community. Before I conclude, I again want to express my heartfelt gratitude to our employees, who are the backbone of our organization. We're very fortunate to have such a dedicated and talented team of medical, clinical, and professional staff taking care of our community, working tirelessly every day to provide exceptional care to our patients. We're excited to celebrate the outstanding contributions of our nurses and our hospital staff during National Hospital Week, which is next week. We hope that you will join us in celebrating our team. And we celebrate all of our nurses during National Nurses Month. Once again, Senators and Chair, thank you so much. We want to thank you for all your support. We want to thank Governor Bryan and his administration for their support. We want to thank the district and territorial boards for their oversight and support. And we want to thank the THRT for their partnership as we continue to work together to increase access to quality health care for our community. Thank you, sir.
Thank you, Madam CEO Commission. Mr. Smalls? Okay, you've given us your summary.
Yes.
Yes, and so I want to close by saying a special thank you to all of the legislative employees and also my staff and all my colleagues that attended this hearing. People of the Virgin Islands, the Roy Leicester Schneider Hospital, the future is very bright. We can see where they're going to get a new building, the Myra Keating, the Cancer Center. There's a lot that is coming that's in the pipeline. But right now, they need a lot of assistance. You've heard all of the issues detailed today. And, it is my duty as the chairman of the Health, Hospitals, and Human Services Committee to make sure that you have the resources so that you can do your job, which is to provide patient care. So we're going to continue this discussion, but this is something that we need right now because, like I tell you, all of the politicians agree on two things: health and education. That's everybody's priority. Well, right now, health, specifically the Roy Leicester Schneider Hospital, needs our help. So thank you very much for coming, and you're relieved from your duties as testifiers today. And have a pleasant good evening, and thank you very much to the listening audience. Have a good night. I did. Yes, I did say thank you. The Committee on Health, Hospitals, and Human Services is adjourned.